Prova. Prova. Test. Ce l'hai?
Good morning, everybody. Thank you for joining us early in the session. We have another exciting day. We start the third World Consensus Conference on BIA-ALCL today. And I'm pleased to give the microphone to my co-chairman to explain you the program today. Thank you very much, Mark.
Good morning, and welcome to the second day. We're very excited to welcome you to the third World Consensus Conference on breast implant associated ALCL. We have a very packed agenda today. We're going to be starting off with Unveiling the Truth. I know that that sounds very controversial, the way that it's titled, but what we really want to get to is it the multiple truths that you hear at meetings. We want to get some kind of consensus. And really we'll be tackling some of the most controversial aspects of breast implant ALCL. We've got fantastic lectures on pathogenesis. Every year we see some of the newest data presented. This isn't what's happened in the past year. This is what you're going to be reading about in the journal in the next 6 to 12 months. And so that's one of the most exciting parts of this meeting every year. We're going to return back to a focus on treatment and management. The very first time at any meeting, we're going to take a deep dive into the psychological aspects of BIA-ALCL, and then we're going to end with some international authority guidance, as we do every year, listening to our government authorities and hearing from them about why they made the decisions that they did. Now, I just want to point out something that we do talk a lot about controversial issues, and it would almost seem to be that we're courting controversy at times. Fabio and I, when we came up with this meeting, foremost, we want it to be a forum for discussion. You're going to see people that seemingly disagree with us. You're going to see some people that make statements that you may disagree with. We invite them into this forum. We want to have those discussions. And when you see people that all have the same opinion, we don't learn from each other. We don't grow. And so if we have an agenda, it is always for patient safety. If we are biased to data. So, thank you.
Thank you very much. I invite the chairman, Padre Malucci, and Peter Cordeiro to start the first session, Unveiling the Truth. Thank you.
Should we wait till 8:45 to start, or?
We're a bit early, Fabio, but yeah.
Patrick will sing and dance for 10 minutes until.
La la.
Oh, okay.
So together with Lennox.
Yeah. And are they going to interact, or?
I'm going to let you know before.
The first one's pre-recorded?
Yes.
Oh, okay. First to Peter and
No,
I know.
Lennox.
Yeah.
And then we're about McCarthy
And we.
and Munhoz.
Okay.
I'm going to let you know about
Do you have a pen? No.
Do I have a pen? Let's have a look. So Peter, do you know which is the richest football club in the world now?
the richest.
Chelsea? No. It happened 2 days ago. Newcastle United. A Saudi Arabian conglomerate worth $700 billion. And they are now the richest club in the world.
So it seems like we went very fast. We're actually ahead of schedule. So we thought that we would just remind you that we will be having a conference next year in Houston, Texas. This will be September 30th and August 1st. This will be on the MD Anderson campus. We tried to do that this past year, and unfortunately we had to make it virtual, but we're really looking forward to bringing as many of you to Houston, Texas as we can. You're going to see that we're going to continue to take a deep dive into pathogenesis, as well as keeping this hybrid meeting. I think that there's a lot of value in focusing on plastic surgery, breast surgery, the day beforehand, really looking at it in a multidiscipline fashion, and then on a second day, having a breast implant ALCL. Fabio, do you have any thoughts on that structure?
Okay, I think that I want to be clear. We are human beings, so we may make mistake, of course. Our aim is only in the sake of the patient health. Our conflict of interest has been disclosed to authority level, and they've been accepted. So we are fully transparent on our bias. If you are aware of any bias, please just tell us, and we can discuss it. Because apparently some bias are not reliable and they're not true. And so we will work on that direction, and we will love anybody that can stand up and say, this is not correct, and discuss it. So we can improve from your point of view on eventually our mistakes, or go on with the track. So that's what I wanted to say. And sometimes when you force a speaker to present in 11 minutes, it's quite difficult to pack all together the data of a very long story, very complex, with several different research branches and data in one slide. So of course we try to go to the main concept, the main conclusion, then we can open a discussion. It's like when you read the paper, you read the summary, and then you have to go through the whole text in order to have the minimum data out and understanding. So that is the aim of our studies, presentation, and session. That's all. So I wish you will enjoy today, and I hope you will participate actively with discussion and question. Thank you. Take the mask off. Okay. It's me talking, really. You never know who's talking behind the mask. It's for the photo. Thank you.
We should just start. Should we start with the pre-recorded? Should we start with the pre-recorded?
It's a pre-recorded one, so we'll start with Daphne de Jong.
Dear participants, first I would like to thank the organizers of this meeting for inviting me to participate in this session on Unveiling the Truth, quite an ambitious title. And I would like to thank the organizers to have me attend online. I will present this talk on behalf of the Dutch BIA-ALCL consortium, a multidisciplinary group in my country. I have no disclosures. Unveiling the truth. Well, reported risk estimates cover a very large range that go from 1 in about 400 to way more, over 30,000. Well, that brings up various questions. What may be the true risk? And if this range would be true, what might be the cause of that range? And to put it differently, which women are actually at risk and which are not? Well, what may be the true risk? As we have addressed in various instances in this World Consensus meeting before, epidemiological research in rare diseases is quite difficult. And that goes for descriptive series as well as association and risk studies. It all relies on completeness, unbiasedness, and on dedicated designs. Well, the point is that there are very few retrospective historical breast implant registries. And prospective registries are not mature yet in view of the long interval that goes between breast implant and ALCL. Very few countries can identify all breast ALCL cases. Self-reporting by clinicians and no request to report cases without the implant pose a bias in that respect. Little information on the background risk of ALCL and suboptimal information on reference of implants in the population that is so needed for absolute risk assessment. So there are all sorts of caveats, and we've addressed those. But in the meantime, various excellent studies have been reported. And those really show that wide variation in reported incidences between New Zealand, Australia, the US, Netherlands, as I indicated, a wide range. Our own study is an example of a case control study with a comprehensive national database. And we find an odds ratio of 422 over 400, which can be an attributable association. And the absolute risk by the time a woman reaches 50 years of age is 1 in 35,000, and by 75 years of age, 1 in 7,000. That shows you, on one hand, the consequences of how to represent risk, and on the other hand, the ranges of, well, let's say 1 in 400 to 1 in over 30,000. And I think that range is true. Now, what could be the true causes for such reported risk variations? Well, let's have a look at the causes of BIA-ALCL and see how we can relate it to risk assessments. Implant texture. We know that the type of implant impacts largely on the risk of developing BIA-ALCL, meaning that studies reported from those areas or cohorts that have a very high rate of smooth implants, we report a significantly lower risk than those that have a very high rate of textured implants. Same holds true for possible variations in surgical techniques that may relate to presence of biofilm or microenvironmental causes that impact on biofilm. Toxic products. They may be implant related. Shedding of silicone material, toxic material that is part of the production process of implants have been implied, but also more vague factors might be considered, such as environmental related toxic products. Or if we just look at patient groups, the patient population per se, cancer patients may have a different toxic exposure, chemotherapy, radiotherapy, than cosmetic patients. Then we have the molecular aspects, genetic risks. Those may be population related, ethnicity, population genetics, or relate to individual predisposition. And that largely also relates to immune responses that rely on population genetics and individual genetic predispositions. So types of implants used in the study, these may therefore partly explain reported national studies, but it should be realized that that may be confounded again by population genetic effects impacting on those factors that I've mentioned. Meaning that worldwide recruitment for database studies has large advantages because it increases numbers and power for various questions, but that may not be optimal for all questions, and especially is not optimal for risk assessments. Exposure to toxic products. Let's look at that in detail. And therefore, we updated the Dutch BIA-ALCL cohort that contained 69 patients by the end of 2020. Mean age over 50 years, interval 13 years, cosmetic versus breast cancer setting 2/3, 1/3 more or less what we expected. And the type of implants used in the Netherlands is largely textured implants. One thing struck me really is the significant drop in the incidence of diagnosed BIA-ALCL in 2020. And I personally think that that has to do with the delayed diagnosis, the referred medical care due to COVID-19. If this is true, needs to be reassessed once the epidemic may have subsided, and we will see about that. It is an interesting observation, and I challenge you to look in your own record if you see a similar effect. The updated cohort gave us the opportunity to separately assess the breast cancer cohort, which were 21 patients separated here in on the left side for the updated cohort. Noted that the cosmetic patients are significantly younger than the breast cancer patients. Interval is significantly different with a way longer interval in the cosmetic patients than in the post breast cancer patients. And it especially strikes that this is very short in the contralateral breast. But in view of the numbers, we should not make all that much of that. It's striking, though, that 25% of these patients received radiotherapy. All received chemotherapy. So we compared the chemoradiotherapy patients versus the non-chemoradiotherapy. And most importantly, we found a significant difference in the interval between the two. So that's a preliminary indication that toxic exposure by chemoradiotherapy for breast cancer may influence the development of BIA-ALCL. Genetic predisposition to develop lymphoma after breast cancer. Again, we looked at the updated cohort and saw 8 patients with known BRCA BRCA1, BRCA2 mutation carriership. Previously, we had performed the study on the non-updated cohort with 6 patients, and we additionally tested 18 patients for additional BRCA1 and BRCA2, which we did not find. With these 6 patients, we found a prevalence of carriership of over 12%. Comparing that to the control cohorts of the general and breast cancer population, that was significantly higher. And it allowed us to calculate the absolute risk for BRCA1 and BRCA2 carriers for 1 in 1,500, which is significantly higher risk than the corresponding absolute risk in non-carriers of 1 in over 70,000, both by the age of 75 years. So small study, few patients, and it's an indication that women with BRCA1 and 2 carriership may have a specific higher risk to develop BIA-ALCL. Needs to be confirmed in independent series worldwide. Other genetic predispositions. Well, we have several case reports of patients with Li-Fraumeni syndrome, germline p53 mutation. Those are obviously the ones who reach the age to develop breast cancer, and it is a selection. It's an interesting observation, very difficult to study in an epidemiological risk setting because of the confounding effect of Li-Fraumeni leading to so many different variants of cancer, especially before the age reaching the development of breast cancer. Interesting observation, though. Also, it has been reported that germline Jagenstat mutations may be present in patients with BIA-ALCL. Also, an interesting observation of which we do not really know how to place that yet, as such mutations have not been really associated with immunological syndromes in the immunological studies. So it's an observation, but we do not really know how to place that. What we can conclude from this overview is that the wide variation that we see in reported risk assessment actually bears the truth. And the risk may differ widely in various populations. And we can indicate causes for that may be implant related to environmental factors and population factors. And also individual risks may depend on clinical settings and individual genetic predispositions. So there is much more balance in risk assessment for BIA-ALCL, and we are slowly approaching opinions and views on which patients might be at risk and which populations might be at risk. And it's important to realize that such factors need to be weighted and reported in risk reports. It's not just that we can talk about the general population anymore. So with that, I would like to conclude. Thank my collaborators of the Dutch BIA-ALCL consortium, and I'm happy to answer your questions. Thank you.
Thank you, Daphne. That was, your update is pretty interesting. Do we have any questions from the audience? Maybe I'll start by asking, I probably see 10 to 15 of these patients every week in my clinic who have textured implants, and they come in and they ask, what should I do? And I usually try to give them a sort of summary of the literature. And many of them will ask, are there any subgroups that have a higher risk other than those with textured implants and the time with implants, which I think are pretty, that are factors that we think are certainly related to risk. Given your new data, would you say this to patients? You're a BRCA patient, you have a higher risk. Would you be more likely to remove their textured implant and replace it? Or if they're a cancer patient, how, these are pretty small numbers that you have, and would you really use any of this information to help patients make decisions?
Well, I think the most important factors to help patient make a decision is for the large group, the implant type and the texturing. For BRCA patients, this may be different because BRCA patients are very aware of their risk. So I think the patient can be very well be discussed. Although we know obviously that that these patients run is not really known yet.
Well, can you hear us? Can you hear us, Daphne? Daphne, can you hear us?
Connection sound pretty good.
Yes, I can.
Oh, you can hear us now. No,
Yes, I hear you.
yes, we hear you clearly now. We couldn't really hear you clearly before.
Could you repeat what you just?
Terrible echo here on the side.
What's that?
Could you
repeat what you said?
I can repeat very briefly. What I said is that for the large group of patients, yeah? Do you hear me now?
Yes.
Yes, we can.
Yes.
Do you hear me now?
Yep.
All right. So for the large group of patients, all right. For the large group of patients, the texture. The echo here is terrible. I will write my answer in the chat and you can read it.
Daphne, do you hear us?
Yes, I hear you, but yeah.
Can, can,
Yeah, I hear you.
can I ask another question?
I cannot get my answer through because the echo is terrible.
Oh.
Huh.
Yes, please.
I just wanted a
Headphones?
comment. You talked about risk being anywhere between 1 in 400 and 1 in 30,000. Now that, according to the FDA, 85% of all reported cases of ALCL are from BIA-ALCL allergan, which no longer exists. So what do you make of, should we be talking about different risk figures? Surely the risk is much, much lower than those quoted.
In terms of
Well, if 85% of all cases of ALCL are related to allergan BIA-ALCL and it no longer exists, where does that leave risk today?
I feel that the risk is not related to the implant brands per se, but rather to the implant type. So I fear that the basic risk is related to texturing rather than brand. And so we need to consider that the very high incidence though are related to very specific patient groups that have possibly genetic predispositions. And so that's a different story to me.
Well, I guess we're out of time. Thank you very much, Daphne.
Thank you, Daphne.
The next presentation will be Fabio, an insight to risk for reoperation. That's a struggle.
Thank you. Can I have a presentation? Thank you to everybody. Okay, so now, check please, Michael. Apologize, waiting a little bit. I'm a strong, convinced supporter of using my own laptop from the podium. It's a sabotage. Yes, we go on with Dr. Lennox until they're ready with mine then. You can send the movie of Dr. Lennox.
We're more ready with a Canadian presentation than we are with a local one.
Good morning. I'd like to first of all, say thank you to Drs. Clemens and Santanelli de Pompeo for inviting me to present at this meeting. I was really hoping to be able to attend the meeting, and I certainly missed the opportunity to be there with all of you in Rome, and hopefully we'll be there next year. I'm going to be talking about structure and variations in breast implant registries, which as a topic, when it was assigned to me, I had some concerns about my knowledge of it and how interesting it would be. And actually, I've found it to be a fascinating topic, and I'm hopeful that I can share some of that interest and knowledge with you. These are my disclosures. I'm a consultant to Alastin. I'm on the editorial board of ASJ and a shareholder at Strathspey Crown. In terms of outline, my goal is to review the histories of medical device registries and some of the components of them, review the history of breast implant registries, review current registries, talk about some of the controversies, and then hopefully come to some conclusions about the future of device registries. Medical device registries exist for multiple devices in many forums around the world. Mandavia et al. In the British Medical Journal did a systematic review to identify prerequisites for a successful medical device registry. And they identified a number of general guidelines which should be in place prior to implementation of any registry. And the first thing they identified was clear registry leadership and management, and that meant having clinical and data management experts, having clear objectives, having clear sustained funding, and this is particularly important for medical devices that are implanted and will be in a patient over the long term, collaboration with stakeholders, development and design criteria, so the type of data you want to collect and the collection methodology, determine the data set and management, and a theme that will come up repeatedly is that overly comprehensive data results in poor uptake. However, limited data is much less useful in terms of the database. They make the comment that patient-recorded outcomes may be too resource intensive for a national device registry, and that's something we can touch on later on. There has to be the ability to clean data once it's in the database and be able to process it and then be able to use that data and create reports that are useful in the future. In an editorial in J-Press in November of last year, Melnikov described further characteristics of a useful breast implant registry, and these are using the FAIR data principles of Wilkinson et al. And this requires that a database should be findable, accessible, ideally using a formal shared language that crosses databases, interoperable, and reusable. He also outlined that data sets must include unique patient and unique device identifiers, which he terms UPI and UDI respectively. Any data set that includes UPIs must have pseudonymous data. They must have secure encryption by an independent organization, and they should adhere to relevant ethical standards and national privacy laws. He also outlined that implant registries should be clinical quality registries, which is different from simply a device registry, and that it should serve all stakeholders. These include patients, clinicians, manufacturers with some caveats, insurers, regulators, and researchers. As I mentioned, registries are not new. For breast implants, there have been multiple attempts at data collection that have happened either under the auspices of government agency or as part of pre-market approval for industry, again, usually under the auspices of regulators. Most have had poor uptake with less than 10% uptake often, and they did not produce good or useful data. Recently, the PIP crisis, BIA-ALCL, and breast implant illness have all led to increased interest and pressure for device registries. This is a systematic review of breast implant registries done by Wurzer et al., which was in Annals of Plastic Surgery in December of 2019, and is basically lessons learned from breast implant registries at that time. The findings that they had were that the databases that were in existence, and this is at the time of their review in 2019, had published minimal information, primarily around implant numbers and implant types. There was some publication of short-term follow-up and some longer-term follow-up, including capsular contracture rates, but otherwise no meaningful information on outcomes. An example of a criticism that they referenced was a perspective from Jeeves and Cooter in Australia in 2012, who noted at that point that the Australian Breast Implant Registry, which actually in its original form was in existence from 1998 to 2010, had only 215 patients listed with PIP implants, despite the fact that over 6,000 women had received them in Australia. This criticism led to meaningful changes in the ABIR to become a clinical quality registry with a mandatory opt-out consent, which we'll talk about, which has also resulted in one of the most robust systems in terms of breast implant registries. They also went on to define the difference between a simple product registry and a CQR, or quality control registry. There are multiple issues which must be considered in device registries. So the first is data collection. And in data collection, opt-in means that patients or clinicians decide to register and initiate that process, and they tend to have only a 10 to 15% capture rate. Opt-out registries is where the data collection is mandatory, except that patients have the option to opt out if they wish. Those have a 99% capture rate. Mandatory means there is no option to opt out. As these are quality registers in the current iteration, they do not require formal consent from patients, nor do they need IRB approval or coverage. And there's an issue related to research from those, which we'll talk about later on. As I mentioned, you have to consider volume of data, so increasing complexity of data results in decreasing uptake. Conversely, too little data makes a registry less useful. Control over CQR is important, and ideally CQR data should be held by a financially independent organization, and that means independent from clinicians, industry, hospitals, etc. The ideal model is therefore an academic institution or a research organization. The easier the interface of a CQR or of a device database, the better the uptake will be. So examples include having, automatic barcode readers, having simple web-based interfaces, having all of the implants already in the data set so that they are automatically populated. So there's multiple things that can be done to make the interface easier. Usability is obviously critical, and that is how easy it is to generate reports, review the data, and use the data. And then finally, access is important. Who has access and how do they obtain access, and are annual reports generated? These are some of the current breast implant registries that they identified in their review. And they identified 6 countries with what they outlined as functional registries: Australia, the Netherlands, Sweden, Austria, the UK, and the United States. And this is a summary of each of those. And so the Australian database is funded by its national health system. The repository is Monash University, and it's an opt-out mechanism. And most of them are very similar. The National Breast Implant Registry in the United States is funded by industry, and the Dutch registry is funded by a surcharge on implants to patients. This is an interesting paper from Korea. So Korea was trying to create their own implant registry, and rather than reinvent the wheel, they did a meta-analysis of all of the existing registries, and they identified 25 initially, and they used those to create a breast device registry minimum data set. They identified 4 of the most functional registries based on their review, and those included the Netherlands, Australia, Sweden, and the UK, and they use those as the basis for their creation of their own registry. And this is the breast device registry for them that is the minimum data set, and so has identifiers which you would expect, additional factors which include the type of the procedure, and specifics of the procedure, and then finally a separate component to identify anaplastic large cell lymphoma patients. Finally, I want to talk about controversies. Dr. Eric Swanson, who I know is on the faculty of this meeting, and so firstly, I'll apologize to him if I interpret, or rather misinterpret, any of his findings or thoughts, and secondly, I look forward to hearing his comments. But he wrote an editorial in Annals of Plastic Surgery in March of this year, which raised some valid questions about registries in general and the US NBIR specifically. So the first concern is lack of control groups. So there's clearly a concern about collecting huge amounts of data with nothing to compare that to from a research or assessment perspective. Time requirement. Interestingly, a survey of Dutch plastic surgeons revealed that they felt data entry was very important despite the burden of time. I'm not sure if that applies to other countries which have different social systems or social environments. Cost, there's different funding models, and these vary, excuse me, it's outlined from national governments to patient surcharges to industry, and those all have implications. Follow-up, previous data sets such as pre-market approval studies with aesthetic patients have notoriously poor long-term follow-up. It's difficult to know how you'll maintain that, particularly with cosmetic surgery patients in a medical device registry. And finally, one of the most interesting things to me is that, as I mentioned, medical device registries are exempt from IRB oversight as they are not research but are quality initiatives. Therefore, patient consent is not required for inclusion within them, and personal information which is not de-identified can be kept. This raises the question of how one could do research utilizing this data. It would require contacting the patients, obtaining specific consents based on IRB approval for a specific research project, and then de-identifying those patients. In summary, breast implant MDRs have evolved from very simple device registries that provided little useful information to what are now clinical quality registries. Hopefully, these can provide useful information to improve outcomes and identify risks for patients. The requirements for a successful breast implant registry include clear objectives, stable long-term funding, independence, simple interface and data upload, an opt-out mechanism, concise data requirements, and clean data which can be utilized and reported easily. Finally, a well-designed breast implant registry that follows the principles outlined should contribute to our understanding of implant safety and ultimately provide better outcomes for patients. Thank you.
Hi, Peter.
Hello. Nice to see you.
Any questions for the audience? We've got Mark. Mark Clemens is going to ask a question.
Thank you. Can we have the, thank you so much, Peter. That was really enlightening and a great summary of the current state of breast registries. I wonder if you could maybe clarify for us this idea of an opt-out registry. In my mind, I think of opt-out means that the patient doesn't necessarily have to participate, but that the default is that all patients are captured and they must ask to not be part of that registry. And you've listed that all of them are opt-out, yet we know that the vast majority of patients are not in these breast implant registries. In England, the vast majority of patients aren't. In the United States, it's a very small proportion of patients that are.
I think you're right. I hope I'm not having the same problem Daphne had. You're correct that opt-out means that the patient doesn't have to be asked to be in it. They have to ask to be out of it. I think the low inclusion rate is related to physicians not uploading the data. And that goes back to the point about different cultural systems. So in the Netherlands, for example, surgeons are quite keen to do it. I suspect in lots of other places, they are less interested in uploading that data.
taking a deep dive into this, do you feel that breast implant registries are the solution or are part of the solution, or do we need to have better prospective post-market approval studies? Where do we go forward from here? Knowing what you know about registries and the shortcomings of trials, what is our gold standard now?
I'm not sure what the gold standard is. I do think that registries are part of the solution. You and I have talked a lot about in Canada, there's no registry at all from a government perspective. And that's really been a challenge in terms of trying to track cases or even get basic information about numbers of cases. So I think there is some role for registries.
Eric, did you want to come back on, because just a different viewpoint?
Well, Peter enumerated some of my concerns, but I did write a letter to Annals. So I have several concerns about the NBIR. One is, as an opt-out registry, patients' information is automatically sent into the registry. They're not asked their permission, even including their social security number. And I think a lot of patients would object if they knew that their information is being shared with a third party without their permission. Now they can say, oh, I don't want to participate, but the information stays in the NBIR, if I understand correctly. Now at the meeting, and you can Google this segment at the meeting, but Dr. Pusik basically sold it as a way to investigate breast implant illness, but there are no questions about breast implant illnesses, in the questions on the registry. So I question, the purpose of this registry, because it does take some time. The capture rate is low. So I'm not sure what the objective is and whether it'll be accomplished using this registry.
Let's go back. Are we all set up for
Thank you,
Professor Santanelli?
Good to see you.
Thank you, Peter.
Good to see you too.
Take care.
I hope you are going to sleep now. Okay, let's see. Oh, good. God. So, I'm going to talk about the risk for reoperation, which is an unclear point in the discussion. These are my disclosure. Okay. So, what is the rationale for no prophylactic explantation? We know that the vast majority of patients with implants at higher risk of BIA-ALCL, like Allergan, BIA-ALCL, will never develop a disease. Yes, okay, I agree. But there is no evidence that an en bloc or total capsulectomy in a symptomatic patient reduces the risk of BIA-ALCL. Yes, but this can be difficult to demonstrate, and there is no evidence that it does not reduce. Cases of BIA-ALCL have occurred even after textured breast implants have been removed. Okay, but there is no evidence that the proper total capsulectomy was performed at that time. So the FDA and the ASPS and ECHEC did not recommend the prophylactic removal of breast implant in asymptomatic patients due to the low risk of developing BIA-ALCL versus surgery-specific risk. That is the comment. Let's go back to a group I participated in 2016. This is the Independent Clinical Expert Advisory Group from the Netherlands National Institute for Public Health and Environment. So we could find out in 2016, this is an open document, public on the web. In 2016, we find out that a patient wearing texture implant from Silimed or polyurethane from Silimed may have a total maximum exposure to 3,000 fibers, man-made fibers, which are glass fibers and rock wool fibers. No man-made mineral fiber could be isolated from any of the Silimed smooth implant. And that's an important data that I could find in the document. So the risk analysis that we did together with epidemiologists and toxicologists at that time it was that they estimate an increased carcinogenic risk for man-made mineral fiber of 9 cases of cancer among 1 million of patients having this kind of implants. But those risk analyses were undergoing to many uncertainties and limitations. The first one is that it's unknown if this tumor risk being extrapolated from inhalation of fiber into the rat or into intraperitoneal deposition of the fiber into the rat study can match and compare with the situation in human breast. So the first problem is this one, according to the risk analysis that was estimated. The second is that it is not known if the higher length and thickness of the rock-wall fiber compared to the mineral made fiber used in the animal study may lead to higher toxicity through an increase in biopersistence. So the longer the fiber stay, the stronger is the reaction, the higher is the carcinogenic risk of the system. So explantation, finally, as a conclusion, we conclude that explantation should be a joint decision of patient and physician, as surgical risks have to be taken in proper consideration. But if we move from 2016 to 2019, then we find out that the risk was tremendously underestimated at that time. Because now we are about, in the Silymet polyurethane at least, in one case every 2,000, not one case every 111,000, as it was supposed to expect. So we have a much higher prevalence of this problem. So what is the mean age of breast implant first position? We know it for cosmetic augmentation and is 34 years. We don't know in reconstruction, but it's available the mean age of cancer occurrence, which is 62 years. And most probably, including also higher approximation, we can evaluate a kind of formula we can develop, because we know that breast implants are used nearly in 300,000 augmentation and 100,000 reconstruction annually in USA. So we have a ratio of 25% of reconstruction versus the aesthetic. So the mean age of breast implant first positioning, regardless of cosmetic or reconstructive indication, can be estimated to be 41 years. So then we have to consider how long a breast implant lasts. And there are different ways of measuring the lasting of a breast implant. On literature, they talk about implant lifespan, which is the time between insertion and rupture of the implant or removal. So some authors say that it's around 10 years and 7 months, while longer studies of 1,000 patients claim that the life implant span is 9 years, 8 years, 7.9, 8.3. on 1,800 implants. Follow-up for 10 years. So the rupture rate, which is a different way of measure, at 10 years were 24% in primary augmentation, 23.7% in revisional augmentation, up to 40, 38, 39 in revision reconstruction, quite high rupture rate at 10 years only. That's just a frame of what I could find on literature after research, and how often breast implants are replaced or explanted. So they put together the two figures, which is not easy to understand when they replace, when they explant, only when they implant. By the way, some author, like Middleton, on 1,200 patients, he claims that the implant rate per woman is 3.8. So it's not 2 implants, but double, at least. Similar other authors, they find out, like core studies from McGann, mentor post-approval studies, you can see that at 3 years, you already have a replantation rate of 14% in cosmetic augmentation, while mentor post-approval goes from 25 to 49, depending if it's a cosmetic or reconstructive branch, primary or revisional surgery. Nevertheless, the worst case is 49% in revisional reconstruction at 10 years. How often women bearing implants are reoperated because it's not only when they are broken, but how many times they undergo surgery and anesthesia to do any reoperation. That's even more complicated to understand. But we can go from the best data, which is from 12 to 23% at 7 or 10 years of time, and that's the best data I could find in literature, to the worst one. I don't see the last one, please. Okay, then I can only tell you, and I can cite you how it is. It's 71% from Scott Spear in Allergan. 71%. The ideal breast scenario, which can be? So the mean age we can estimate as 41 years. Implant lifespan, it's 9 years. Women life expectancy is 85 years. So if you start with an implant when you are 49, 41, you may expect to replace the implant 4 times during your lifespan, according to literature. What is the real life scenario? The real life scenario is when you are 41, you wear your implants for the first positioning. When you are 44, 3 years after, you have a chance of 7.4 to 14 to have it replaced already when you are 44 years. When you are 51 years, we have a chance up to 49% of implant replacement. We change by time, of course. When you are 51, again, from 36 to 46, augmentation, 71 reconstruction with BIA-ALCL implant are reoperated, this woman. So if you need to be reoperated in 71% of the cases, does it make sense? I mean, breast implant, especially if you wear a BIA-ALCL implant, that need to be replaced and revised more than once for different reasons. Sorry, I'm going long. Does it really matter to replace it one time? So a consistent number, that's the rationale for prophylactic explantation. Consistent number already have to undergo more than one implant replacement reoperation. Recall, do not create a burden in USA system, having a lower incidence of texture. Implant surgery specific mortality risk is unknown, so it's only a problem of cost insurance coverage. The mortality rate in literature is quite variable, from 50 to 72,000. As those data are reliable, since the AACF database does not disclose which are the percentage of breast implant specific related procedure, but only cosmetic procedure, we designed a study with a time frame of 8 years, and we use as a denominator all the operation intra-hospital for implantation, explantation, implant exchange. Only intra-hospital that we went to check, and 3 different databases. And the active population was 1,000 procedures, and we found 0 events of death in the court of oncology, 0 death in the court of aesthetic. So the incidence is 0 on 100,000 patients. So the rationale for prophylactic explantation is a consistent amount of wearing breast implant already have to undergo, women wearing breast implant, already have to undergo more than one implant exchange and revision. Recall, do not create additional burden to USA healthcare system, having only 3 to 26%. Maybe in Europe it does, because we have 95%. And the implant surgery specific mortality risk is neglectable. So it's a problem of cost insurance coverage. I'm going to conclude. Since polyurethane and microtexture implant expected carcinogenic risk was 1 in 111,000 patients, but we found the BIA-ALCL actually on the same implant occurs in 1 every 35, or on the same implant 1 every 2,380. Implant surgery mortality risk is neglectable. Mortality for BIA-ALCL is 1 case every 32.8 patient affected by BIA-ALCL. We have to consider 1 every 32 die. Does it make sense to suggest the explantation of a very high-risk patient, such as oncologic with microtexture implant, or patient bearing polyurethane and microtex, Silicone, or BIA-ALCL Allergan? That's my question to the audience. Thank you for your attention.
Any questions from the audience? Roger Wickstrom. Roger. Yeah.
Right. Yeah, so quick point. So on the mortality issue, in the publication we had in Aesthetic Surgery Journal in January, I think it was 2020, based on US data, it was estimated as 1 in 72,000 mortality risk for aesthetic breast surgery. So in the two populations that you surveyed, the aesthetic and the oncologic one, those populations were all well below 75,000. So I think although you saw 0 there, I don't think we can necessarily extrapolate that to larger population. Brad Calabrese, in a number of his publications, cited an aesthetic surgery not restricted to breast of 1 in 50,000. So I just say, I think it's not 0. One can debate what that number is, but that's the best number that we were able to derive in our paper was 1 in 72,000.
Thank you for the question. That's an interesting point. I would like to explain probably better. I mean, the data we extrapolated is not mortality in breast surgery. The data we extrapolated is mortality in specific implant-related breast surgery, which is not the data included in those papers you cited, because the data coming from the ASF are not including only implant first positioning, replacement, and explantation. So these are 3 specific surgery that can be closely related to the principle of replacing or not replacing breast. Those other data are including any type of cosmetic surgery under outpatient situation, not into the hospital, or any type of breast surgery, including not using breast implant. So definitely it is not a clear data. As far as we could find out on 3 different registries in Italy, on 100,000 patients, and 8 years of follow-up, there was no case. And that's the data we report about those 3 specific type of surgery, which are of my interest if I have to talk with the patient and say, I need to replace, you want to explant, you want to first implant. I think they are the most closed. That's why.
Fabio, just a comment, Fabio. Fabio, I'm here.
Yes, sure.
So you suggested that between the age of 41 and 85, on average, people would need to change those implants 4 times.
No, I don't suggest anything.
No?
I report data from literature.
Oh, no, well, okay.
It's different. I report data from literature, so don't put in my mouth what I don't say.
No, I'm not putting anything in your mouth. I'm just... that seems quite high, that number. It seems quite a high number. I wonder, does it take into consideration implant type, implant size, are they saline, are they silicone? In an era where we're using tissue-based breast augmentation, where you're respecting anatomy, you're selecting better, it seems like a very high number.
Yeah, I appreciate your question. So if I want to have a look as an epidemiologist of the data I have on literature, I can only work on what the authors offer me. So then those variables are not considered in those papers. So what I can observe is that we have some implants which are at the very high risk. And we have to take the responsibility to tell it to ourselves at least. That is not our duty to suggest or to decide if to explant or not to explant. This is the role of the authority, which will come after, and they have to tell us. I only have the responsibility participating to a group of study more than once and put up the data. And I find out that we thought some high-risk implant as a lower, but they haven't, because it was demonstrated later on by literature. Now, I don't suggest, I claim, discuss all together what to do with this very high-risk implant since we have a mortality rate of 1 every 32 patients. Thank you for.
So, thank you, Peter. You're going to talk to us about variability and incidence.
Yeah, thanks. I think there's going to be several talks that touch upon some of the stuff that I'm going to go through here, and I'll try to skip through some data that may not be that may have been mentioned already. These are my disclosures. So The numbers, as you know, are going up, but the one number that to me stands out is that to date there has been no well-documented or substantiated case of a patient with a smooth implant that got BIA-ALCL. We've had 36 deaths worldwide, and Colleen McCarthy will be touching on the profile registry and the most updated numbers. We talked about global networks and national data registries sharing information. The numbers, though, have gone up, and the current published lifetime risks from regulatory agencies vary widely. The ASPS, 1 in 3,800 to 1 in 30,000, the TGA, 1 in 1,000 to 10,000, in the Netherlands, about 1 in 7,000, Health Canada, 1 in 24,000, and I personally think that the large variations are likely based on reporting as opposed to true genetic predispositions. What's the current literature pertinent to risk, and what are the differences and why? And I'll touch on sort of the most quoted papers. This was probably the earliest one by Gary Brody, 173 cases in the literature. It's totally retrospective, and his risk estimates range from 1 in 500,000 to 1 in 3 million. Problem here being that this is retrospective and there's no real denominator. This was a paper by Mark Clemens, now in 2015. 100 cases documented in the US. The incidence was calculated to be about 1 in 30,000. And the problem with that paper is, again, the denominator is calculated. This is the pre-market approval study for the Allergan 410 implants. The prospective, certainly, 17,000 patients with the Allergan textured implants. The problem with this paper was that the mean follow-up was 2.9 to 4 years, and we know that BIA-ALCL starts to present itself at 8 to 10 years. So within this publication, there were 4 cases of BIA-ALCL with an incidence of 1 in 3,500. Yes, prospective study, but the very, very short follow-up. This is the Italian Ministry of Health data. Again, this was about, I think, 1 in 35,000 patients, but again, a retrospective study and an estimated denominator. So the denominator, in my mind, keeps popping up in most of these papers in the literature, and unless you have an accurate denominator, you're not going to get an accurate incidence. This was Daphne de Jong's original paper, risk estimate of 1 in 7,000, and she just updated it. But again, the absolute risk is based on an estimated denominator using chest x-rays, 3,000 chest x-rays that were reviewed to determine the incidence of implants in patients. This is one of the early papers out of Australia and New Zealand. There were 55 cases, and it was, I think, good because they broke it down by type of implant, biocell versus polyurethane, Siltex, demonstrating different incidences with a fairly good follow-up in terms of mean time of follow-up, 7.46 years. But again, this was retrospective, and the denominator was also just an estimate. This was touched on by Peter Lennox, and although there are multiple international or national databases that exist, this paper looked at databases from 40 countries. There were 363 unique cases of BIA-ALCL, many of them from the US MAUD database. But the problem that they found was that there's no accurate data in most of these registries, and I think it was well described by Peter Lennox. And certainly having good, accurate databases will help, but to date there really are, most of them are really deficient. This paper from Colette, I think, nicely summarizes, and if you look at the risk estimate, you can see that the risk estimate starting at 1 in 3 million back in around 2008, 2011, the risk has gone up significantly to 2018, where it was 1 in 3,000. And just to reiterate, I think the problem with, and the reason for such variability in the literature is that this is all retrospective data. It often doesn't capture all the cases. It's dependent on reporting, sometimes from patients and or physicians. The clinical case data is often incomplete or inaccurate, and the denominator is often extrapolated. Additionally, I think the follow-up in most of these series is very limited and short-term. So how do we really determine an accurate risk? And I'd like to just quickly review a paper that we recently published last year. And it's a personal experience over close to 30 years, prospectively collected data with very close long-term follow-up. And the point I would make about this particular data set is that the implant denominator is quite accurate. We know exactly how many patients have the implants, what type, how long, et cetera. So this is a 25-plus year experience, about 6,000 implants. Most of these were textured implants, 96%. And my standard follow-up on these patients is yearly. They come in every year for 10 years and then every 2 years subsequent to that. All patients with silicone implants will get routine MRI scans to look for leaks starting at year 3 and then every 2 years. And all the data in the database is entered prospectively. Many of our patients, since we're a cancer center, are also followed long-term by the oncologists and breast surgeons, and most of my patients are breast cancer patients. So I think what we have is an extremely robust and fairly accurate database. What was the experience? During this period, 1992 to 2017, there were about 3,500 patients who had textured implants with a median follow-up of 8 years. You can see that vast majority, hard to read, but were BIA-ALCL. So 96.7% were BIA-ALCL implants, and I think that's worth noting. Most of these were reconstructions after mastectomies, very few cosmetic. And there was actually almost 50%, 50-50 split of silicone versus saline in this overall cohort. So of what's been the experience of the 3,546 patients, within this publication, 10 patients had BIA-ALCL, giving an incidence of 1 in about 350. And to look at those 10 cases, you can see that 80% presented with seroma only, the other 20% with mass and seroma, and 20% presented with metastatic disease. So it's not a benign disease. The median time to development of BIA-ALCL in this group was 11.7 years. So based on this 2.5-decade experience, what's the risk of developing BIA-ALCL with a textured implant? As I said, it's 1 in 354, but that's with a median follow-up of 8.1 years, and I've continued to follow these patients. I now have 12 patients, so the gross calculation would be 1 in about 300. So the numbers keep going up. If your follow-up is long enough, the numbers will go up, and they are going up worldwide. This is a better way of looking at cumulative risk. It's a Kaplan-Meier type curve, and you can see that it's very flat for the first 7 to 8 years, essentially 0, and then it climbs pretty quickly, and by the predicted risk at year 15 is about 1 in 100. What about the institutional experience? And everybody asked me, well, is it your technique? It's a single surgeon experience. We have 11 plastic surgeons at Memorial Sloan Kettering, and within that group, we retrospectively looked at everybody's data, about 6,000 patients with textured implants. The median follow-up is shorter than my particular group because many of our surgeons have not been there that long, but it's a follow-up of about 6 years. There are 11 cases of BIA-ALCL, and the incidence within our group of surgeons was 1 in 559. So it's still, I think, quite high, and it'll continue to go up as their follow-up increases. So what do we conclude? The incidence of BIA-ALCL in the literature has certainly rapidly increased over the past 5 years. The risk of developing BIA-ALCL with highly textured implants is much higher than it has been previously published. And I think it'll be very useful as more registries and databases are established with much longer follow-up. We'll start to get more accurate estimates of risk. And I think these risk assessments will certainly help patients and surgeons in the decision-making process. Thank you.
Question from Mark.
Thank you, Peter, for putting that together. I was wondering if you could come back to a comment that was made yesterday, in which it was suggested that purposefully avoiding any follow-ups past 12 months, purposefully avoiding follow-ups past 12 months, because then you might just subject patients to unnecessary screenings and tests, and in the reality, if a patient's got a problem, they're going to come back and just see them then. A survey by Penn State would suggest that that's actually a majority view, with about 80% of U.S. plastic surgeons only seeing their patients for about 12 months. You've taken a different tact. Why is that?
Well, I didn't take that approach anticipating that 20 years or 30 years into my practice, this would pop up. I mean, I'm a big believer in data, and I've been interested in implant reconstruction, and I've input all this data, and I continue to see patients and to evaluate them. So I know every time I see them, I evaluate them for contractures, I do aesthetic scales, we give them patient-reported outcomes now with the breast Q. And I think all of that data is important data to know, to establish what happens with patients long-term, with implants long-term. And my long-term experience was published in the past year or so. And I think it really shows, it answers a lot of questions. Do implants hold up over time? Do aesthetic results hold up over time? And for me, that's all very valuable information. I find that patients are actually very grateful to see me. And, when I go from seeing them every year to every 2 years, after 10 years, many of them say, Dr. Cordeiro, can I come back in a year? And I think they just feel more comfortable about it. I mean, I've picked up many, many recurrent breast cancers seeing these patients. So is it worthwhile? I think with the cancer patients, for sure. And I personally think operating on someone and not seeing them again, after your first post-op visit, to me is not, taking care of that patient. And implants are going to, the longer you have them, you're going to start to see the problems, and you're going to develop leaks. And I think it's good to be able to follow them up in this way. So that's really that's been my rationale.
Peter, can I just ask, the institutional paper you quoted, 11 cases, did that include your cases?
It did.
But that means that there was only one extra case.
There was a time period. So within those 11 cases, 8 were mine, 3 were other surgeons.
Okay. And then just a point, you say that yours is a prospective study.
Yeah.
But in 1992, you weren't looking for BIA-ALCL.
Correct, but prospectively entered all the data.
Okay.
So
right.
when patients pop up with a problem, that complication, that problem, whether it's BIA-ALCL or anything else, gets entered.
Okay, so I'm going to ask the question again to you and to Mark and to anybody else who wants to answer this. BIA-ALCL is gone. 85% of cases of BIA-ALCL are BIA-ALCL related. Why aren't we changing the language with regard to risk?
What language, though? I mean, BIA-ALCL is gone.
Well, the numbers you quote are with the existence of BIA-ALCL.
But BIA-ALCL is gone. They're not on the shelf anymore. But there's millions of implants in these patients. How can you say that that's not a problem?
But they will wash out. That will go. That will go.
In 20 or 30 years, when these patients start to pass away, and the implants are still there.
But there has to be a recalculation of risk going forward. There has to be.
It will change.
you know, but Mark, any comments?
May I say one word? Because I have a private clinic and I make a calculation as well in statistics. And the last 10 years we performed the pure 3,500 cosmetic augmentations. And I have documented 4 cases, 3 on the Allergan and 1 on the Mentor. But when so it is, the ratio is, the risk is 1 for 1,000. But we operated on 550 Allergan patients. And for 550, we have 3 cases. So now the risk is 1 to 150. So probably when I checked my patient more, because we have the regular follow-up. 1 year, I see all my patients. So at this moment, it's 1 to 150. So it's much higher even than yours. So
Sure.
What we discussed yesterday, there is a problem only if we want to find, and we are more precise in the follow-up, for sure will be below 1 case of BIA-ALCL for 100 patients. So it's really very high.
So to get back to that,
That's my data.
Yeah.
At this moment, it's 1 to 150.
Okay.
At this moment.
Yeah.
To get back to your point, you said 84% are Allergan BioCell. So the actual number from the FDA is that when the device was, so that's of all population, when the device was actually known, it was 91.5 was Allergan BioCell. So it's even higher. I couldn't agree with you more. I think when we quote risk, we do need to quote a BioCell risk, and then ideally a textured implant risk, ideally a macro-textured risk. But the reality is we have the best data only on BioCell, and it becomes incredibly difficult to come up with a quote on anything else. So I think a lot of times we use the wording that ALCL is associated or causative by textured implants. When we talk about risk, we're really quoting BioCell risk. And I couldn't agree with you more. There's a big difference that can't be extrapolated to all breast implant types.
No, I don't disagree with that either.
Thank you,
I mean,
Mark.
absolutely.
Thank you.
No, I agree. Implant to implant, and
I
the
mean,
data,
but it's too conveniently forgotten in this discussion.
but the data that I'm quoting, as I said, it's 97%.
Yeah, but they're all BioCell.
And if you have a patient with an Allergan implant, you know, that's their risk.
The problem is that it's the BioCell data which defines your position, not yours, but in general, position and philosophy around texture. And what I'm saying is that possibly is not justified, given that BioCell doesn't exist any longer.
Agree when you state it that way.
That's the message I'm trying to get across. Yes, who else?
Next.
Sorry.
I have a very quick question, Peter. So you have a large cancer clinic. So how many of your patients are BRCA mutation carriers?
Of those dozen patients, I think only a couple.
Right. Okay.
Yeah.
Right, I think we move on to. Sorry, who we move on to? Oh, it's Eric. Eric, welcome back to the stage.
Thank you,
Tell
Patrick.
us your
Yes.
story.
Yeah, good. So my disclosures are these 2 books. Now, what are the indications for capsulectomy? Well, capsular pathology, of course, BIA-ALCL, universal agreement about that, calcified capsules. But you notice on this list, I do not have capsular contracture. Now, I occasionally do capsulectomies if I have a patient like this, prepectoral implants, Baker 4. They can be easily removed. You can see them on the right side. I've opened up one of the implants, an old silicone gel implant. So this is a suitable case for a capsulectomy. But capsulectomies are not a trivial matter. They seem simple enough, but it's often not possible or advisable to perform a complete capsulectomy. Additional dissection is not favorable for a good cosmetic result. A number of these patients feel mutilated after this surgery. You lose the lining, you lose control of the pocket. It can be a highly morbid procedure. We talk about risk. I'm aware of 1 death from a capsulectomy and a serious injury with injury of an axillary vein. And there's the other, I think Mark made this point a few years ago, there's the possibility that you may be spreading occult disease. So why consider explantation alone? First of all, there's no evidence for prophylactic capsulectomy. And it may surprise surgeons to realize that there's no evidence of a systemic benefit from capsulectomy. So if you leave the capsule behind, you're preserving an intact lining that may even provide some barrier function. Partial capsulectomy, I think, is illogical. Either the capsule needs to come out or it doesn't. And our objective here is to eliminate a triggering factor. And if we're wrong, if a BIA-ALCL tumor develops, it's not a dire situation. The cure rate for BIA-ALCL is still very high. It's not like breast cancer. This is the same slide that Peter Cordeiro showed. The risk, of course, goes up with time, like a lot of cancers, so it makes sense to eliminate the triggering agent as soon as possible. So, open capsulotomy. This is a patient, by the way, with a capsular contracture, treated simply with an open capsulotomy, reinsertion of the same implant. I described my technique in this paper that was recently published. Circumferential linear release, 20 or 30 minutes, no drain, easy patient recovery, insurance is not billed. Patient payment is minimal. Just if it's my patient that I've implanted, they just pay for the surgery center and anesthesia. So what's the history of capsulotomies? How did capsulotomies get a bad reputation? Well, the existing studies are almost all involve old second-generation implants that were inserted in the 1970s that were highly prone to rupture. So whether it was closed or open capsulotomies, they were very prone to recurrence because of free silicone in the pocket. So the failures were due to this free silicone. Now, third-generation implants that came along in the 80s are much less prone to leak. So there's not really an endless cycle of open capsulotomies. Now, I wasn't aware of any literature really looking at what is the recurrence rate from open capsulotomy, so I did my own study. I looked at 20 years, retrospective study, my own practice. This was published 5 years ago. What is my recurrence rate from performing just simply open capsulotomies? So if the implant is ruptured, of course, we replace it. If it's in a prepectoral position, I'll often put it in a subpectoral position. So what are my results? Well, 17 recurrences, which was 22.7%. Now, this actually compares favorably with capsulectomy that can run as high as 53%. Capsulectomy, people wouldn't be using ADM if capsulectomies were working. And I found that patients with ruptured silicone implants had more recurrences. That's not surprising. Interesting thing, when I replaced intact implants versus putting in a new implant, there was no difference in the recurrence rate. And the recurrence rate, I stopped using betadine in 2000, and I found there was no change in my capsular contracture, recurrence rate after just switching from betadine. I just used sterile saline for irrigation. So what are the advantages? Limited wound, shorter surgery, as I mentioned, better preservation of breast tissue, less risk, much less expensive, and you can repeat the surgery. It's not something to be dreaded. Even if your surgery is unsuccessful, patients can come back easily, have another capsulotomy now. So I've done 2 capsulotomies. I've been in practice over 30 years. I've never done a third. I've never done a third. Now, I tell patients that that's possible, but I haven't actually had to do it. So risk-benefit analysis. Now, the FDA did not recommend implant replacement because of the equation of what is the risk of the disease versus the risk of the treatment. Well, first of all, now we know that the risk of the disease is much higher than we originally thought. And the surgical correction, surgery is not surgery. Are you talking about an implant replacement, a simple implant replacement, which is what I'm recommending, or are you talking about replacement and a total capsulectomy? They're different, and the risks are different. So the equation may tilt more favorable to the intervention if the risk of BIA-ALCL is much greater and the risk of surgery is essentially zero, as Dr. Santanelli was mentioning. And of course, any supposed benefit of a capsulectomy is a moot point if the patient decides not to undergo the surgery. What about pathological examination of the capsule? Well, a number of institutions require that, but it does involve additional expense. Patients may be irresponsible, and there really is no evidence of its value in asymptomatic patients without any evidence of capsular pathology. And I think we have an error in logic. When people say, you do not need to have your textured implants removed, but if you do, then you must have the capsules removed and also have them examined by a pathologist. We hear that all the time. Now, logically, if the capsulectomies and pathological examination are necessary, so is the surgery. So we're all familiar with the reconstructive ladder. I think we've been dialing up our interventions with total capsulectomies and even en-bloc capsulectomies. I think we need to dial down, and I just go to that open capsulotomy, and I can repeat it if necessary. Now, what about capsulectomy and ADM insertion? Well, this was a paper by Hidalgo and Weinstein. It was published last year. It was actually the most read cosmetic paper in PRS. And the surgeons recommended ADM for women with bilateral capsular contracture or unilateral previous treatment failure. They used Stratus, a charge of $5,460 per breast, which is going to be financially punitive for patients. They had 185 historical control patients versus 32 that were treated with this technique. They did not report complications. So I wrote actually my rebuttal was just published last month. I looked at their numbers, and actually I couldn't find a significant difference when I just did an online chi-square test. And I presented the alternative option of capsulotomy. You're preserving the original capsule, so you've got the lining, no need for a new lining material. And I brought up the risks of ADM use, the fact that these studies often do not have IRBs. It's not mentioned that it's not FDA-approved ADM for use in the breast, and the concerns about foreign DNA. Capsulectomy and ADM, this is an article by Bengtson and ASJ, and this author claims that capsular contracture can be prevented and eliminated in the absence of infection using ADM. And he does not offer treatment of recurrent capsular contracture without ADM. And he feels that withholding this product is like withholding a curative medicine. An incomplete operation like what I do is insane. So I wrote a letter, and this is the findings. You know, I'm putting forth the advantages and disadvantages of that intervention versus just doing an open capsulotomy. And I think that you can see the results are better with just the open capsulotomy. There are authors who are even using ADM in primary breast augmentation, just deciding this patient should have ADM because they believe that they're at higher risk of capsular contracture, usually unjustified, by the way. And there's selection bias. One of these papers that I just mentioned, they got 3 capsular contractures in their first 4 patients, but they deleted those from their data analysis. So they're selecting their data. So why do studies report few reoperations using ADM? Well, shorter follow-up times like Hidalgo and Weinstein's study, selection bias that I just showed you, subjectivity of the diagnosis. But here's the big one. Capsulectomy and ADM is regarded as the kitchen sink option, the final treatment, and nothing else can be done, if it recurs. So, patients are not going to come back. Besides, it would be financially prohibitive to come back and have additional surgery. Conflict of interest, big problem. Here are some of the amounts that these authors are being paid by Allergan for promoting these products. And you can be a highly paid spokesman for a company, or you can be an unbiased researcher. You can't be both. So it's not surprising that very few problems are being reported. And it's not sterile. I think a lot of surgeons believe that the cells are being removed. I mean, acellular dermal matrix, it means that the cells are being removed. But maybe they're not. Maybe foreign DNA remains. There's even a risk of Creutzfeldt-Jakob disease. I mean, it may be extremely small, but as soon as that happens in a patient, it's going to be blamed on the ADM, and there's going to be a huge public outcry. And I'm concerned about that because the time lapse can be 20 years. And it's happened in brain surgery patients with dural grafts, 130 patients. So we think we need to be wary of this. This is a study that I just read from Korea. Alloderm is on the left. See the electrophoresis, a high content of DNA. And you can see under alloderm, see that? It's hard to see the photograph on the bottom. All kinds of nuclei, okay, in the ADM. I thought it wasn't supposed to contain cellular material. Now, I'm going to briefly mention that I think the role of antibiotic irrigation is questionable. Povidone iodine irrigation is actually not sterile. A lot of people don't realize that. It may be contaminated during the manufacturing process. And I use sterile irrigation instead. Ordinary sterile technique avoids introduction of bacteria, unnecessary elimination of harmless bacteria. En-bloc capsulectomies that these people are advertising, they're opportunists. They're doing hundreds of these in a year. And it's a very destructive procedure with poor aesthetic results and almost always unnecessary. Does capsulectomy really improve pulmonary function? This was a study suggesting it did, but there are problems, including the fact that the statistics didn't even support the conclusion. So my own approach is I do not discourage patients with textured implants from having surgery. I think you should advise patients the way you would advise a family member and inform them that capsulectomy has not been proven to reduce the risk of BIA-ALCL. And it's lacking for BII as well. So I offer implant exchange to patients. This is an example. And we have to be aware of the law of unintended consequences. You know, we have the best of intentions, but the outcomes can be not what we were hoping for. And I welcome what Mark was saying earlier. We really need to debate. We need debate. That's what drives the scientific process. And I'm so glad that Dr. Santanelli and Dr. Clemens recognized that. This was a very interesting book making the point that the dissenter can actually help the debate, help science even when they're wrong. And all scientific medical advancement depends on that one red fish, not all those other blue fish swimming upstream. Thank you.
Thank you, Eric. Are you the red fish, Eric?
I hope I'm one. I'm a red fish, yes.
Any questions for Eric? Eric, where do you stand?
I think everybody agrees with me, Patrick.
Yeah, of course, yeah. That means you're not a red fish.
That's true, that's true.
And yeah, what's your take on the relationship between biofilm and capsule formation?
Yeah, you know, that was a major reason that a lot of people do capsulectomies, because they subscribe to the idea that there's biofilm and we need to remove that, infected biofilm, but it makes no microbiological sense. You're not going to sterilize the breast pocket by removing some or all of the capsule. I mean, the microbiological environment is going to stay the same. So why take out the old line and just put in, a new one is going to be created in the same microbiological environment. And we've seen these studies recently with microbiomes that show that they're more patient-specific than they are illness-specific. So I do not subscribe to the biofilm theory for capsular contracture.
Do I have time to give a comment? So, if I just can make a comment. For me, the rationale to remove the capsule depends on the brand and on the implant. I truly don't believe in BIA-ALCL, in a biofilm theory. This is not the point. Even if you do a primary augmentation, it will be always contaminated. It's impossible to have a sterile pocket. The point is that you probably bring with some implants fibers, microparticulate that you leave there in the capsule, and they continue to give a chronic inflammatory reaction, which is the trigger. So from that point
that's possible, yes.
That's my idea. Thank you.
Thank you. Eric, I would agree with you. When in terms of capsulotomy, if I'm operating on a patient for capsular contracture, purely aesthetic, even for the reconstruction patients, then I think doing capsulotomies where they're indicated, et cetera, it certainly helps. And I don't do extensive capsulectomies unless it's a patient with a capsule that's totally calcified, kind of like a coconut, you have to take it out. But for the patients that I'm removing textured implants specifically, mostly because they are concerned about developing BIA-ALCL, and that's an increasing group in my practice, I do a capsulectomy, but just a limited capsulectomy wherever it's not going to injure the tissues, the chest wall. And the reason I do it is that it does get sent to pathology. The pathologists look at it and they say it's normal capsule. And I think for patients that's very useful because they've read up on all of this and they say, well, how do you know there's no ALCL there? And even though you're not taking out the whole capsule, I think it makes them feel a lot better knowing that at least at the time we did the procedure, there was no lymphoma in the specimen. So I think it's useful from that standpoint. It has nothing to do with treating the contracture.
Yeah, no, I accept your point, yeah. Thank you.
Right. I think we're going to move on to the...
Is Colleen live, McCarthy live, or?
Thank you and good morning. It is my great pleasure to be speaking with you today and to be a part of this Third World Consensus Conference. A warm hello and thank you for the invitation. In my role as Principal Investigator of the Profile Registry, my goal today is to share with you both the origins of this rare disease registry and our findings to date. I have no financial disclosures. You may remember in January 2011, the United States Food and Drug Administration released a safety communication warning of the association between breast implants and ALCL. At the time of that initial communication, only 34 case reports were known worldwide. The FDA at the time warned that their own medical device-related adverse event database, or MA database, had potentially some significant limitations, including the submission of inaccurate, unverified, and even maybe biased data. Thus, it was determined that there was a need to create an infrastructure where detailed data pertaining to cases of ALCL could be housed. And so, as a result of the subsequent collaboration between the American Society of Plastic Surgeons, the Plastic Surgery Foundation, and the FDA, the profile or patient registry and outcomes for breast implants and anaplastic large cell lymphoma etiology and epidemiology registry was born. Established in late 2011, it was designed to be a centralized collection of both past and future cases of ALCL in the United States, and the goal was to capture complete and consistent detailed data elements needed to evaluate factors associated with the disease. So where are we at today? Well, since October 2011, 372 distinct cases of BIA-ALCL in the United States have been reported. In 224 cases, or 60% of the total cohort, complete case report forms have been submitted. These case report forms housing that granular level of detail that then populate the registry. If we look at cases of ALCL in the registry diagnosed per year, it is notable that the vast majority of cases were reported following that initial safety communication in 2011, potentially indicating improved awareness and testing for the disease. We can see a drop-off in cases following what appears to be a peak in 2019, although it is hypothesized that the impact of the world pandemic may being felt in terms of cancer screening and ultimately submission here. A note about the workflow of the registry: there are some unique features to profile. Firstly, we accept at this time physician-reported cases only in the United States. When the registry was conceived, it was hypothesized that physician reporting would increase the quality of data pertaining to pathologic details, operative details, for example. Business agreements are signed, internal IRBs provide approval. We collect patient health information, and as such, we are able to rule out duplicate entries. So we have distinct, unique cases within our registry. And then once these steps have been completed, the physician then submits that detailed case report form. Initially, it was submitted in a pen and paper format. In 2018, we switched to a web-based format. So looking at this cohort, we see that the median age is 55 years. The overwhelming majority of women in this cohort were white or Caucasian. Disease was diagnosed in 2 Black or African American women and 1 multiracial female. 35% of patients endorsed a medical comorbidity. 45% of patients had a cancer history, the majority having a history of breast cancer. Interestingly, 4 patients having a history of non-Hodgkin's lymphoma. The indication for breast implantation was cosmetic augmentation in 55% of patients, post-mastectomy reconstruction in 45%. Looking closer at that reconstructive cohort, the overwhelming majority underwent a therapeutic mastectomy. Only 4 patients had a prophylactic mastectomy. These are patients who overwhelmingly underwent bilateral reconstruction using 2-stage approach. 44% had chemotherapy, only 11% having chest wall irradiation. Looking again at the total cohort, the time from implantation of the implant in place at the time of diagnosis was a mean 9.2 years. The shortest time was 1 month, with a range of 1 month to 27 years. This patient, who had a 1-month history of their current implant, did have a significant history of a prior textured permanent device. The earliest time to disease in an implant-naive patient was 2.0 years. Notably, 63% had a history of multiple device exposure, the majority of those patients having a history of multiple prior permanent textured implants. 100% of patients were diagnosed with a permanent implant in place. Not surprisingly, the overwhelming majority had a textured implant at the time of diagnosis. But you will see that 11 patients had a smooth implant at the time of diagnosis. Looking further at these cases, These patients had a mean exposure of 3.8 years to a smooth implant with a range of 1 to 16. 9 of these cases had a well-documented history of a prior textured device, 3 patients having a history of textured permanent implants, 6 patients having a history of tissue expanders and permanent implants. 1 patient had a 14-month history of prior textured tissue expanders only and then underwent exchange for smooth implants. And in 1 patient diagnosed at the time of a smooth implant in place, their prior implant history has yet to be confirmed. The overwhelming majority of patients had an Allergan device in at the time of exposure. Looking at ancillary procedures, only 6% had a history of fat grafting, 8% had a history of ADM use. Only 17% had a history of a prior complication, such as an earlier capsular contracture. Only 2 patients had a history of an implant rupture, 1 of an infection, no patients having a hematoma requiring surgical intervention. How did these patients present? Again, not surprisingly, overwhelmingly, they had local breast symptoms. In 9% of patients, they endorsed, in addition, systemic symptoms. Interestingly, in 6 patients, they were diagnosed after incidental findings on radiographic screening and were asymptomatic at the time of diagnosis. Looking at the local breast symptoms, 79% had a periprosthetic seroma, 25% had a new capsular contracture grade 3 or 4, 14% endorsed a palpable breast mass, 12 breast redness, and an 8% new cutaneous findings were present. The most common systemic symptoms endorsed were fever, fatigue, and night sweats. Notably, there was a single case who presented with isolated systemic symptoms only, without local breast symptoms. This patient had fatigue, night sweats, and upper extremity paresthesias. 8 patients were diagnosed with bilateral BIA-ALCL. In 3 of these patients, they presented with bilateral symptoms. Interestingly, 1 patient with unilateral symptoms had a history of non-Hodgkin's lymphoma. The typical story for these patients is a history of bilateral augmentation or bilateral implantation with a unilateral presentation, bilateral explantation, and ultimately pathologic examination confirms the diagnosis. Looking closer at pathology, lymphoma cells were found in the fibrous capsule in the majority of cases, in 55% in the periprosthetic fluid. 1 in 10 patients had a positive axillary lymph node. Looking at staging data in patients whom accurate staging was indeed possible, the majority had stage 1A disease. In addition to complete case report forms, 1 year following submission, all physician reporters are contacted to provide follow-up information on their patients. We have follow-up data for 130 patients at a mean 2.2 years since diagnosis. At this time, 126 patients are alive without evidence of disease. 3 cases were deemed to have persistent disease with following inadequate surgical and or medical therapy. 1 case of recurrent unilateral disease is known. This patient had bilateral explantation with partial capsulectomies, developed a unilateral recurrent seroma at 2.2 years, ultimately underwent bilateral en bloc resection and is now free of disease. We are aware of a total of 6 deaths, 3 cases due to metastatic disease, 1 case due to a second primary B-cell lymphoma. Highlights. Well, we have learned that nearly 1 in 4 patients present, in addition to a seroma, with a grade 3 or 4 capsular contracture. Systemic symptoms are present in nearly 1 out of 10 patients. 6 cases were asymptomatic at the time of diagnosis. 5 patients were diagnosed in the presence of smooth implants with a history of prior textured permanent implants or textured tissue expanders. Nearly 6 out of 10 had a history of multiple permanent implants over a mean of 9.8 years. 1 in 10 patients had a positive axillary node. Fat grafting performed in only 6%, ADMs used in only 8%. Again, these ancillary procedures likely not predictive nor protective for disease. Our bilateral cases support the NCCN guidelines for bilateral surgical therapies, and our follow-up data underscores the real need to provide complete surgical therapy in these patients. These granular details are critical to our understanding of disease, and the registry will continue to support discussions regarding the real-world performance of implants and will be instrumental in determining what factors play a role in etiology and treatment. Looking forward, improved data harmonization with other national and international registries will advance our understanding even that much further. And going forward, we need to engage both physicians and patients alike, which will ultimately increase our reporting and increase our understanding in the importance of this registry data and its impact on the real world. Thank you.
Trying to find information on these patients, and it's important to have accurate information. And it's now, you know, a cohort of patients of over 200 people, 200 cases of the disease. I think that helps to start, may help to start identifying subgroups that might have a higher risk. Do you know what percentage of those patients had the BRCA gene?
No, and good morning to everybody. It's a real pleasure to be here. It's a really good question, and watching the earlier presentation, Daphne had alluded to this. We don't have a gene testing data on these patients, but as noted, we do know that there were 4 patients who had prophylactic mastectomies, presumably for a genetic mutation or high family risk, but that's where we're at.
Questions from the audience?
Colleen, just based on what you were saying and some of the subgroups and what Daphne was saying, do you think it's fair to say that the risk of BIA-ALCL is therefore lower in a purely cosmetic surgery case than in a recon case with the same implant?
At this time, we don't have that data. So, you know, I don't think we're there yet. We can see in the profile registry, the cases are nearly equally split between the reconstructive and cosmetic population. So I think this registry is good to start looking from the 10,000-foot view as to what these factors may be in etiology. And then what we need to do is take these realizations from the registry and really use them to drive hypothesis-driven research that will include some of the registry data or collaboration between registry data or specific real-world sites.
Colleen, you skimmed over one slide. I didn't see the other numbers, but 73% of the patients had Allergan implants. What were the other 27%? Because we were having a discussion about it's only Allergan, and it certainly isn't only Allergan. And we don't have the denominators. You know, Allergan might just happen to have the most implants out there in the US, and it's proportional, and it's how long these implants have been in place. But what were the other companies that?
Yeah, good question. So predominantly an Allergan, an implant in 73% of cases in which the implant manufacturer was noted. The second most common manufacturer was Mentor, followed by Sientra. So Mentor in the range of 15 to 20%.
Other questions? One back there.
Wickstrom, just a quick comment. I think, although we don't know the answer, I think the fact that there's a similar number of recon cases and OG cases, if you combine that with the fact that most estimates are there's 4 times as many OG cases as reconstruction patients, wouldn't that suggest that the risk may be a little bit different?
Good, great question. You know, one of the things to note is that the registry is not designed to look at risk or incidence. We're focusing, if you will, on the numerator and the specific details around those cases. But to more address your question, the other thing of note, and Peter Cordeiro alluded to this, You could argue that reconstructive cases have greater follow-up. So at our cancer center, we see people annually, and those patients are more likely to see, if not their plastic surgeon, but an oncologist or a care provider. Someone else this morning, suggested if we sort of look for things, we may find them. So there may be other factors at play, but good question. We need to look forward and use registry data going forward. National, international data to answer your specific question and others like it.
Great. Thank you very much, Colleen.
Thanks.
We're going to move on now with Giovanni Botti, who's going to talk to us.
Okay, I'm going to speak about our experience in shifting from microtexture implants to smooth implants. It seems to be a very good idea after hearing all this. I have 15 minutes as agreed with Professor Santanelli. I don't have any disclosure. Like many other surgeons from more than 20 years, have mainly used anatomical implants with mostly good results. Unfortunately, though, over time I realized that these implants have also many serious flaws, the worst among them being the Allergan devices that I was using in more recent years before moving on to round implants. Now, finally, I and my patients are really very happy with these new round implants, but what was wrong with the old anatomical ones? They have pretty many defects, unfortunately. They need to be macrotextured, this is the main defect, in the hope of avoiding rotation. Unfortunately, instead, at least in my experience, less than 40% of them really stick to the capsule, while most of can move freely. Actually, the only certainty is that macrotexturing can be responsible for seromas, double capsules, folding, and even ALCL. Once upon a time, macrotexture was even deemed capable to reduce the capsular contracture. Concept later proved to be false. The main problem is that if macrotexture surface doesn't stick to the capsule, as it happens in more than half of the cases, we have a kind of soft tissue irritation by the macrotexture, by this rough surface. And irritation of the soft tissues could lead to late seromas, to double capsules, and probably, as we have seen, to ALCL. You know what it is, late seroma, which very often is the first sign of ALCL too. And anyway, we have to go back to the OR in order to treat it. Double capsule, this is typical of Allergan devices, of this kind of biocell surface, and it's one of the causes of the rotation. And these are all my patients of mine. Unfortunately, I have seen so many of these problems. And then we have BIA-ALCL. The onset of ALCL seems to be indisputably linked to macrotexture surface implants. And the question is, if you are conscious that performing breast augmentation could lead to such a serious disease, how can you keep on doing this kind of surgery? I mean, would you put macrotexture implants in your daughter's, mother's, or sister's breast? I definitely wouldn't. You know, anatomical implants have several defects, as I said. They need to have a firm consistency in order to keep their teardrop shape. They have been called gummy bear implants, but this is not natural. It's nothing to do with the natural breast, which should be soft instead. They cannot move together with the body. These are not natural breasts. These are like a statue breast. Breast must be mobile in every position. It should change its shape. From stable, immobile anatomical implants have nothing to do with real anatomy and natural laws of physics. When standing, the breast should hang over the chest wall according to its size. Of course, bigger it is, more hanging should be. The following cannot natural breasts because they are static. They have nothing to do with naturalness. Breast shape should vary according to the body position. When laying down, the breast should move a bit laterally, and the following cannot be natural breast because they stick in the same position even if the patient moves. Ergonomics implants are morphodynamic, which means more anatomic than anatomical implants. One can see teardrop shape when the patient is standing, and moderate flattening and lateral shifting when the patient is supine. What your patient like better, the right or the left shape? My patient likes this one better, and me too. Furthermore, Allergan implants had another defect, a high early rupture rate, at least the last ones. For all these reasons, almost 7 years ago, we tried hard to find an implant that could give great outcomes without the drawbacks of the anatomical microtest ones. And we found this ergonomics implants. And we decided to almost abandon the macrotexture implants and use mainly the nanotexture ones. You see, this is the surface of these implants. If you compare with the BIA-ALCL, they are 30 times less thick, and this means that they are almost smooth. Why do we think that ergonomics implants can be a tool in preventing all these problems? Because they have special characteristics. This kind of smooth texture gives, at least so far, no seromas, no double capsule, much less possibility of ALCL, if any, thanks to less irritation, less biofilm. And they don't adhere to the capsule, so they can move in a more natural way, and they give a more natural shape to the breast. And there is less folding, wrinkling transmitted to the surface. Much less capsular contracture. So far we have less than 0.5% and much more natural mobility. This is the usual capsule thickness of these ergonomics implants. It's very similar to a plastic wrap, nothing to do with any other capsule you can find with other implants. Why is capsule contracture so rare? Because probably this kind of texture irritates surrounding tissues much less than macrotexture, but at the same time it depresses myofibroblast activity and consequently the formation and contraction of linear collagen fibers, and no particles detached from the implant. This is very important. No gel bleeding, but now this is shared by many implants. And there is less bacterial contamination, it has been demonstrated. About the round shape, we don't have worries, of course, for rotation or flipping, so this kind of complication, they are over. There is a better feeling of the upper pole, which is what many of our patients wish for. And in the majority of cases, the outcomes are overlapping those of anatomical implants, but with less potential problems. We can sleep much better. Let's see a few video cases. I want to show you a few of these because it's important to understand that we really don't have a worsening of our results. I want to show you a few of them because it's important to understand that even if you shift from an anatomical implants to a round, smooth implants, the outcomes are not worse. At least in my experience, after almost 1,500 implants, what we get is almost all these. These are not the best of my cases. I just selected, have been selected randomly by the secretaries, and they are just some of the results. And I just ask you if you can see that these are different than a regular anatomical implants. I cannot see it. To me, they give exactly the same outcomes. Maybe the upper pole is a little bit fuller, but this is very much appreciated by the patient that they can show a better cleavage. I can show so many of these because fortunately we are happy with these outcomes, and the patients they come every year and we can take photographs and videos. Videos are very important because there is no trick, there is no photoshopping here, of course, and so you see the real outcome of these implants. And to me, I really ask you if you can see any difference with what we used to obtain with the anatomical implants And I repeat, I have been using them for at least 20 years. So I consider myself an expert in this field. And look at this. Can you see any difference? The shape is absolutely anatomical. To me, even more anatomical than with the old anatomical ones. And these are some of these patients are really flat-chested women, and still they are mostly of them, they are submuscular when the patient is quite flat. But if you look at them, they really look very much natural and very much, let's say, anatomical, even if the implant are not anatomical at all. This is 6 years after the implantation. Is one of my first cases, but you see still the shape is kind of teardrop, even if the implant are absolutely round. Again, this is still 7 years after the operation. But do you think this is a round implant? Do you see the roundness of the implant? I cannot. Truly, I am really very satisfied of the outcome of this new experience. I want to give you some numbers. We use the inframammary approach in 55% of the cases, perioral approach in 35%, and 10% with transaxillary, which is my favorite approach. In almost 7 years, we have used. This is at May this year, 1,278 implants exactly, and our complications are as follow. Capsular contracture, Baker 2, 4, Baker 3, only 1, so it means 0.4%. Double capsule 0, seroma 0, ALCL 0, hematoma 3, immediately evacuated, infection 0, we don't use drain, and bottoming out just 1. In all cases, we have used no-touch technique, funnel, expanders, light retractors, as you saw yesterday, and no drains. Almost all the patient, 98.5%, have been very happy with the result. And those requiring secondary surgery noticed a huge difference in the consistency and mobility of the breast. What else we like in ergonomic symptoms? They are easier to use. They need a smaller incision. They shift inside very rapidly because they are almost smooth. No need to check the orientation, of course. No fear for rotation because they are round. And they are perfect for the axillary approach. They are much easier to choose. You don't need very many calcul. You just take the diameter of the breast. You remove something, maybe 1 centimeter or 5 each side in order to have enough coverage. For example, here we have 14, the rest 11, and with an 11 diameter, you can choose between, among 4 types according to the projection, so 220, 265, 315, 380. That's easy. It's not really, you don't need any particular calculation. Ergonomics implants allow the surgeon to give the breast different shapes. The question is, what is a beautiful breast? It's hard to give an appropriate definition. I know Padma Lucci speaks about 60 and 40, but I think that these have different proportions, but they are all anyway nice breasts. It depends by the taste of the patient. I mean, this on the left side, this lady has for a flat upper pole with most volume in the lower part of the breast. So I position the implant a little bit lower, while in this case she asks for a full upper pole. So I move the implant a little bit higher, and you can get both outcomes according to what the patient is asking for. These implants give really very natural touch feeling. Fortunately, there is no way to let you palpate one of my patients, but perhaps you can appreciate the softness of them and the mobility of the ergonomic implants through the following images. This patient was operated 4 years ago with a transaxillary breast augmentation, but you can see how the breast can move very easily. This is the scar after this operation. Yes, I am almost at the end. Okay, skip this. As any other device technique, also the use of each different breast implants has a learning curve, of course. Compared to the old-style microtest anatomic implants, ergonomics need to be positioned in a slight different way. They should be placed half a centimeter higher than the old microtester implants. They virtually produce no capsules, so there is nothing which keep them in the proper position. The pocket must be precisely tailored and not extended too laterally, as we used to do with the polyurethane covered implants, because they could move a little bit too much laterally. In most cases, it would be better to fix the new inflammatory fold by suturing together deep dermis, scapus, and deep fascia. And to me, this implant should preferably be kept smaller than 400 milliliters in order to prevent bottoming out, which now is anyway the trend. If these simple rules are respected, no bottoming out will develop. I can show you just a few cases to end my lecture. Before 1 year and 2 years later, can you see any difference? And again, this is 1 year after and 4 years after the operation. And as you see, the inflammatory fold is absolutely at the same level. And again, 1 year after and 3 years later, there is a slight movement downwards, but it's probably more the length between the lower border of the areola and inflammatory fold that lengthened by a few millimeters, but generally they look exactly the same. Nevertheless, I wish to show you the only bottoming out I had after an ergonomics, which was this. Look at the left side. I had to lift the implant and to fix the inflammatory fold. This was the only bottoming out with these implants. In conclusion, what we have obtained, shifting from macrotexture to nanotexture implants, it was not that difficult because basically the technique was the same. Happier patients and happier surgeons, and we can sleep much easier now. Thank you for listening. Thank you.
Thank you, Giovanni. Unfortunately, we don't have any time for questions. I think there is one more recorded presentation. Just to say, Giovanni, this is a meeting for debate. I don't agree with very much of what you said, and I'm going to give you an alternative this afternoon for everybody to see a different side.
Prerogative of being on the podium.
Yeah, of course.
Hello, everyone. Thank you again for the invitation. And in this talk, we discuss some aspects related to capsule contractor and smooth implants, past and contemporary evidences. And this is my disclosure with Established Labs Motiva. Over the last 60 years, we have seen different advances in silicone implant technology, including constant change in surface. In the 70s, we have the version 1 of smooth surface, the grade 1 with roughness with 0.2. In the 80s, the versions of grade 3 and 2. And on 2010, the new version of smooth surface with a roughness of 3.6. However, it is a common idea that textured surface reduce CapCon and smooth surface version 1 favor it. One of the main theories that comes from the 90s is that smooth surface favors the organizing alignment of myofibroblasts, and this alignment favors the tightening of the capsule around the implant. Between the 80s and 90s, several studies favored this theory, and not all with conclusive results and consensus, mostly retrospective analyses, some showing a higher incidence of CapCon and smooth and others not showing this effect. Thus, a common question in 2000 would be, what is the validity of these retrospective studies, and even more, the need for more evidence on this subject? The 2000 meta-analysis that would come next. So in 2000, we have two important systematic reviews. The first one, 2006, published by Barsley, including more than 1,000 patients from 7 clinical studies, retrospective, and implants from the 80s and the 90s. Here you can note very clear in an odds ratio graph a tendency where we can note less than 1 more CapCon and smooth and favor the behavior of texture implants, and more than 1 more CapCon in the texture and favor the smooth surface. So in conclusion, we have very clear more CapCon in smooth groups, and it was noted in all studies. And when we analyze the subgroups saline versus gel and pocket, submuscular versus subglandular, we observe similar results. Less CapCon in texture and more CapCon in smooth surface, except one study published by Asplund in 1996 where he observed more CapCon in texture and less in smooth. The conclusion number one in this study that texture has no effect in the submuscular pocket. And the second observation that the sample is too small. In order to have a 50% reduction, 15 versus 8.6% of the incidence of CapCon, we have to have more than 350 patients in each group, and not 50 versus 56 patients as presented by the authors. And another interesting result was observed in complications and reoperation. Texture surface had a lower incidence of complications than smooth ones, except for infection and reoperations for infection. And this data is really expected, since surface with higher roughness and surface area are more susceptible to bacterial adhesion and biofilm formation than surface with lower roughness. And another important systematic review was published by Jong, where he included 235 patients from 6 clinical studies. And analyzing different periods of follow-up, 1 year, 3 years, and 7.5 years, the authors observed the same conclusion, and more CapCon in the smooth group when comparing to texture surface. And despite these results that I present, and looking deeper into the studies, we can note that most of them have retrospective nature, inconsistent diagnostic criteria, and inadequate follow-up. Thus, the real benefits of texture over smooth surface versus one are overrated, resulting in a dearth of sound clinical data. And additionally, all these studies included the old generation version 1 of a smooth surface. Thus, we arrived in 2010, where we have the possibility of finding new surface within the same category, different smooth but smooth surface. And classifying the same category is crucial, as it allows you to identify different behaviors. You can identify objectively and accurately, you can analyze the individual characteristics, you can evaluate the performance, and you can determine results and complications comparatively. In this way, in 2016, we already emphasized the importance of using objective analysis in surface. With the use of surface profilometer, we were able to analyze the details of each surface, peaks and valleys, and still obtain an objective number, which is the roughness. And objective analysis using the profilometer is currently the basis of the most existing surface classification. We published this analysis in 2019 in PRS Open together with Mark and Maurice. Here you can see in ISO classification that there are 2 subgroups in the smooth category. We have the traditional, the smooth surface version 1 from the 70s with a 0.27 of roughness, and the new generation of smooth surface with a roughness of 3.2. And here you can note that the new generation of smooth surface, previously defined as nano, is not totally smooth and has more peaks, 16 microns, and few valleys, thus determining a surface totally different from the traditional smooth one. So now the main question in 2010, when you have 2 types of surface, it is, what's the role of the new type of smooth surface in the behavior of inflammatory response and CapCon rate? And to answer this question, one of the first studies on new smooth surface with different roughness was carried out by the Manchester group coordinated by Dr. Byatt in 2009. And based on the principles of nanotechnology and photolithography, the authors developed 2 new smooth surfaces with a very low roughness and utilized the quantification of the behavior of the fibroblast with electronic microscopy. And in the traditional smooth surface with roughness close to 0.2, you can see a different behavior of the fibroblast with a random direction and distribution and focal adhesion points, as you can see here on the right side. However, in the new smooth surface, the 2 to 5 micrometers roughness modify the fibroblast morphology, facilitate diffusion, and reduce the inflammatory response when you compare to the fibroblast growth in a completely smooth surface with roughness of 0.2. And in summary, modifying the roughness of the smooth surface, you change the fibroblast forms, and especially its behavior according to the environment. And this was a qualitative analysis, but anyway, can you quantify the inflammatory response and capsule thickness according to the roughness of the smooth surface? So we arrived in 2017 at the MIT study in Boston. And this study was performed at Professor Robert Lang lab at the MIT Department of Chemical Engineering. It's one of the most important engineer of surface labs in the US, which develops different types of research which has an interface of biotechnology and material science. And we had the honor to have our study published this year in the Nature journal, one of the most important in the area of biotechnology. In this study, we evaluated the inflammatory behavior of different surfaces, including the traditional smooth surface and the new generations. And in the present study, we utilized two experimental models, one in small animals represented by the C57 Black 6 mice. This is one of the most widely used genetic background mice for use as models of human disease and inflammatory process. And the control group represented by the smooth surface, the traditional one, and the test group represented by the new generation of smooth surface. And associated with the mice, we used a large model, the New Zealand rabbit, in order to assess the inflammatory process in implants with the size of the scale used in humans. And samples from the capsules were collected from the top and from the bottom of the implant in a period of 3 weeks and 6 months after surgery. And after 3 weeks, you can see the difference in capsule thickness between the control group, the traditional smooth, and the smooth silk group. Similar results in both the top and the bottom of the implant. And here you can note very clear a greater capsule thickness in the texturized groups. And similar results were observed after 6 months of surgery, where thinner capsules were observed in the new generation of smooth surface. And concerning the initial inflammatory process represented by the number of macrophages, we observed interesting results. A smooth surface with roughness close to 4 showed fewer macrophages in the inflammatory process when compared to traditional smooth implants, roughness close to 0, and even macrotexture, roughness close to 90 implants. This fact partially corresponds to the thickness of the capsule observed between the different surfaces, as I showed before. And when we specifically compare the smooth surface and the number and percentage of macrophages, we observed the important and significant difference. There is a reduction of almost 70% in the number of cells and almost 50% in the percentage of cells, as you can see here in the migration of green-marked macrophages, demonstrating in this way a lower inflammatory process in the smooth silk surface. In this way, it's the first proof of the difference in behavior of two smooth surfaces with different roughness. Both are classified as smooth according to ISO classification, but the behavior is totally different. In conclusion, in 2021 we have most studies analyzing traditional smooth implants, first generation, roughness 0.2, and implanted in the 80s and 90s and showing a higher incidence of CapCon when compared to texture implants. However, the great part of these studies have a lot of limitations in terms of number of patients, randomization, and inconsistent diagnosis criteria. In addition, in recent years, new generation of smooth surface, version 2, have emerged. With objective methods, it's possible to classify different categories with different response in the smooth surface group. Currently, there is a strong experimental evidence demonstrating that new subtype of this surface where altering the roughness results in different inflammatory response and capsule thickness. And finally, there is already short and medium-term clinical evidence on the lower incidence of CAPCON in the new generation of smooth surface implants. And long-term result as a part of FDA prospective core study analyzing the behavior of new smooth surface will be released soon. Thank you for your time and attention, and thank you again for the kind invitation, Fabio and Mark.
Hear us? Alex? You can hear us? Just a quick message from Fabio. He says he owes you a coffee because it's 5 in the morning there.
Okay.
Any questions from the audience? Any comments? Alex, just, you know, you've demonstrated, and I think it's quite well documented now with the silk surface. There's very thin capsule that has advantages, of course. It has some disadvantages in terms of implant stability. Can you just comment on that?
Yeah. Good morning, everyone, and thank you again, Fabio and Mark, for the kind invitation, and thank you for your question, Malucci, and it's a very interesting issue. And when you're working with implant, I think there is not a bulletproof that can you fix all your problems in surgery. And now the products and the implants that we have in the market, we have the positive and negative aspects. So you have to adapt your technique in order to have the benefits of this new surface. There is no doubt, there is no question, in analyzing my cases before this new generation of smooth surface, especially in the worst scenario for breast implants, like recon patients with radiotherapy and thin skin, the contribution of these new devices in terms of inflammation and in terms of thin capsules, it's huge. So I think you have the possibility to have better results, less inflammation, and other stuffs related to islandness of silicone and ALCL, etc., that I don't have any time to discuss here. But of course, that working in a scenario with no tissue adhesion and less inflammatory process and thin capsules, it is very clear for me that you have to adapt your technique. If you adapt your surgical technique, you have the best part of the two worlds. So you can control the pocket, you can maintain the implant stability, and you can avoid complications. But if you use the same mindset that you applied in the old generation of macro texture surface in this new device, for me, and especially in risky patients, you have some problems. But working with specific techniques and specific surgical planning, it's very predictable, the results, and you can control and you can maintain the implant. This is my experience in the last 4 years and a half using these new types of device.
Alex, just one more question. Radiotherapy and capsular contracture with the silk surface. Can you tell us something about that?
Yeah, we don't have the data, enough data to talk about this, because the recon patients submitted to smooth silk implants, in my experience, the longest follow-up is 3 years. But comparing my older experience with texture devices, especially grade 4 Textor devices, it's very, very different. I have a significant number of patients that I did the recall 10, 15 years ago and come back, especially after the recall that we have in 2019. And the patient presented Capcom grade 3 or even 4 or implant rupture. And after 2017, I switched all the implants, the Textor, to this new generation of the smooth silk. And the behavior in the great part of the cases, of course, that is not 100%, but I can guarantee that in 75% of the patients that grade 4 became grade 2, grade 3 became grade 1 of capsule contracture. So this is the behavior of the inflammation. This is the behavior of thin capsules that produce in this kind of implant. So if you have these cases and you will just do a total capsulectomy and just switch to smooth silk implants, I'm sure that the behavior in terms of capsule thickness would be totally different because the process is different.
And I might be simple-minded, but either an implant's smooth or it's not. And isn't this really a textured implant that you're calling a smooth?
Hi, Peter. I don't think so. If you take a look to the classification and the profilometer analysis, and if you take a look very close to the surface, if you use the standards of classification, both surfaces are less than 10 micrometers. So in ISO classification and even in NATLAN classification, they are smooth, but the roughness is totally different. As I showed in my presentation, the traditional smooth from the 70s, you have a roughness of 0.2. The new generation, the smooth silk, have more than 10 times of roughness, but is still classified in the category of smooth. So I think it's a problem of classification. I consider a smooth implant.
Thank you for that contribution. We're going to have to close the session, but thank you very much for joining us.
Thank you. So I'm sorry for the delay, but it was interesting discussion. We can take 25 minutes instead of 30 minutes break. So see you at 25 past 11, please. Thank you.
The esteemed Dr. Suzanne Turner from Cambridge University. I know I'm probably not supposed to say it, but I'm probably most excited about this session. It's always turned out to be one of the absolute highlights of the meeting to see some of the basic science research, genetic sequencing that's coming out on breast implant ALCL. We're going to start off the session with Dr. DiNapoli, who will be speaking on the genetic background of BIA-ALCL. Dr. DiNapoli. To talk with you last week.
I was so busy.
Yeah, but I appreciate, I saw you were with my parents, so that was nice. Yes.
Okay, so
Yeah, we're going to stay for a week.
this is my conflict of interest. Well, what we think is that lymphomagenesis is a multi-step process that starts with a polyclonal proliferation triggered by an antigen. And then within this polyclonal proliferations, developed an abnormal clone which starts an atypical lymphoid proliferation that at the end become clinically evident as a malignancy. But the whole process is guided by different genetic changes that occur gradually, conferring to the cell specific abilities. But which are these genetic events in BIA-ALCL lymphomagenesis? We all know that the T cells are stimulated by different antigens, some particles from the implant itself, maybe bacterial biofilms or other toxins. So we have these T cells that start to proliferate and to differentiate. But at a certain point, something should go wrong. And what could happen is that the players, or what we call the JAK-STAT inflammatory pathway, could be affected by mutations. And these mutations make this pathway constitutively activated, meaning that we do not need anymore any antigen, any cytokines to activate this pathway. And indeed, we found that more than half of the BIA-ALCL patients harbor mutations in these players, as you can see from these articles. But this is not a specific characteristic of BIA-ALCL. Indeed, STAT3 activation is shared with other ALCL subtypes, which also characterized by the downregulation of the T cell receptor. So we can think that after the acquisition of JAK-STAT3 mutations, the lymphoproliferation become independent from any antigen or stimuli. So the T cell receptor could be downregulated from the surface of the T cell. But is the JAK-STAT3 mutation sufficient to transform a T cell into a lymphoma cell? What we know is that the germline mutation of STAT3 induce lymphoproliferation and autoimmunity, but it is insufficient to transform a T cell into a malignant cell. So there should occur something else, and this could be represented by mutations in the epigenetic modifiers. These are enzymes that modify the chromatin state to make it more accessible or not to transcription factors that control several cell functions. And indeed, we found in a very high proportion of BIA-ALCL cases mutations in these epigenetic modifiers. And more importantly, these mutations were more frequent in the tumor type of BIA-ALCL respect to what we call the seroma type or the in situ type. So meaning that they cooperate with the JAK-STAT mutations probably during the progression of BIA-ALCL. However, we know that DNMT3A, which is an epigenetic modifier, could also be mutated in a progenitor cell, the hematopoietic stem cell in the bone marrow. And then depending on which additional mutation it acquires, it may develop a myeloid neoplasm or alternatively a T-cell lymphoma. So we call this process clonal hematopoiesis. So this means that the epigenetic changes could also predisposed to other neoplasms. But which are the late genetic events? We know that in indolent B-cell lymphomas, they transform into a more aggressive disease, such as the diffuse large B-cell lymphoma, by acquiring mutations in genes that are gatekeepers of several important functions. Indeed, we talk about mutations in TP53 gene or in MYC gene. In particular, P53 is known to control several cell functions, including cell cycle and DNA repair. And we found in one of our patients TP53 mutation, somatic mutation, but this observation was supported by other authors. But at least in our case, the patient had a more aggressive disease because the lymphoma already spread to the lymph node and also recurrent. So we may think that TP53 may impact the aggressiveness of the disease. But what we also know that germline mutation of TP53, which characterize the Liefeld-Menis syndrome, may predispose to BIA-ALCL because patients actually with TP53 germline mutations are predisposed to develop several tumors, including BIA-ALCL, which show it to be more as a tumor mass with lymph node involvement. But TP53, as we said, control the genomic stability. And as you can see from this cytogenetic analysis, the karyotypes of BIA-ALCL is very complex. And among the alteration in the chromosomes, the losses of chromosome 20 seems to be the most frequent one. Well, there's another controller of the genetic stability, the BRCA1 and 2 genes. And as we have listened to from Daphne Day Jong, carriers of BRCA1 and 2 mutations have higher risk of developing BIA-ALCL, probably because they are prone to have alterations in their chromosomal setting. But BIA-ALCL are not characterized only by chromosomal alterations. Very recently, this paper showed that JAK2, the gene JAK2, could be also rearranged in a very high number of cases. And one of these fusion was between JAK2 and STAT3. Again, the JAK-STAT3 pathway is involved. But it is of note that this gene is very close to another gene, the PDL1. And we found amplification of PDL1 in 30% of the cases. So it might be possible that this region, the 9p24, in which maps both genes, could be alterated. And so we have two effects, one in the proliferation and the other one that impact the immune evasion of the neoplastic cell. Other authors look for DUSP22 and TP63 rearrangements. However, none of them have been detected in the BIA-ALCL cases tested, in contrast to what reported in systemic and cutaneous LCL. So we recently decided to perform a targeted RNA sequencing in both cutaneous and BIA-ALCL because both diseases are localized form of LCL. And what we found is that both are characterized by relatively infrequency of fusions. And when they occur in BIA-ALCL as intrachromosomal rearrangements. 3 of them occur in the same patient. And this patient, as you can see from the cytogenetic, had also a very complex karyotype. So we might think that these chromosomal rearrangements are another example of the highly unstable genome that characterize BIA-ALCL. We don't know which are the effects of these fusions, but one of these was also reported in patients with lung cancer, and it seems that the loss of neurofibromin may impact the activation of other important pathway for survival of lymphoid cells, which are the MAP kinase and the PI3 kinase pathway. And in particular, PI3 kinase pathway is upregulated in all ALCL subtypes, but for us, through different mechanisms. In particular, in BIA-ALCL, we found that the neutrophil signaling sustains the PI3 kinase AKT pathway. And this is confirmed by the upregulation of the receptors only in BIA-ALCL tumor cells and not in cutaneous and systemic ALK positive ALCL. And this is important because we know that there are new inhibitors that could block this pathway. So just to conclude, we can say that so far we have learned that there are several genetic alterations. There's not only one that drive the BIA-ALCL lymphomagenesis, but several, and we are putting all together this information to get the whole picture of the BIA-ALCL genetics. And let me thank all the people that work with me and you for your attention. Thank you.
Thank you so much, Dr. DiNapoli. I've got to throw out, at last year's meeting, we really brought forward the idea that Lee-Fraumeni syndrome was essentially a contraindication to receive a textured implant due to the very high rates of BIA-ALCL associated with that. Now here we are 12 months later at this year's meeting. Do you think that you're ready to say that BRCA should not receive a textured implant, or at least that a BRCA patient should have extra counseling that they may be at increased risk for BIA-ALCL?
Well, as I said last year, I think that mutation in a gene like TP53 could be considered a risk factor for BIA-ALCL. But a risk factor doesn't mean that you for sure would develop a BIA-ALCL, because you know that TP53 carriers have the chance to develop multiple tumors, but we don't know which one for sure they would develop first. For example, maybe breast cancer or lung cancer, pancreatic cancer. So it is a risk factor for sure, because it is a very strong gene, a very gatekeeper gene, of different functions. But as I said before, to me, lymphomagenesis is not just a one-step process. You need multiple genetic hits. So you may have a TP53 mutated because you are born with TP53 mutated, but then you have to acquire additional mutations to develop a specific cancer.
Your work was instrumental in showing that TP53 has a more aggressive course. Are we now ready today to say that ALCL patients require genetic testing because it has a specific prognosis based on that information?
Well, I mean, if you cure patients through surgery, you then remove everything. But if you have a disease that already disseminated, like ones that already spread to lymph nodes, it might be useful to do it. I can just tell you that in patients with chronic lymphocytic leukemia, we now test for the presence of TP53 mutation because it's a very risk factor of transformation that we call it the Richter transformation. And also because it may impact the choice of the treatment, the pharmacological treatment. Because in CLL, if you have also 1% of the tumor cells with TP53 mutation, you cannot use fludarabine, because otherwise you're going to select those cells that could transform later into an aggressive lymphoma. So it might be useful in a disseminated disease to study better what's their genetic.
So for the audience keeping notes, that's seismic, and we'll be looking forward to seeing what Steve Hurwitz says in the next panel as chair of NCCN guidelines on lymphoma for that very point.
Thank you.
Thank you for your talk, Ariana. I wanted to ask about, you put this sort of diagram up of multi-step carcinogenesis. Is there a reason why you came up with that order of events, or is that just random?
Well, I put them, thinking about them. Because JAK-STAT3 mutations drive lymphoproliferation, but not transformation. So I thought you may have this as an early genetic event instead of to be a late. But it is not so striking forward, because as I said, epigenetic modifier could occur later, but could also be a priming event. So it is difficult to, draw this line exactly with what happened. We know that, for example, in colon cancer, we have this multi-step process that is being more delineated, which genes are mutated first. Here, I'm still confused, but I think that JAK-STAT3 may be an early event, although it is not something that I can, subscribe.
We've seen in your manuscript in PRS suggesting that some stages may be lymphoproliferative. We've seen some industry key opinion leaders hold that up at national meetings, celebrating it, saying, finally, we have data to suggest this is not a cancer.
No. This is not my opinion, absolutely. For me, BIA-ALCL is a lymphoma. Mm-hmm. We cannot exclude that it could start as an atypical lymphoproliferation earlier. We cannot, confirm but not exclude it, because we don't know what is going on in the capsule that is within the implant. So it might be possible that you have an atypical lymphoproliferation, but it is not clinically evident. And then it becomes evident, as I said, at the end of the transformation as a seroma where you can find these very atypical cells, that is the hallmark cells of the BIA-ALCL, which already have some genetic alterations. But the point is that, is the BIA-ALCL seroma something that is the same of the BIA-ALCL tumor mass? We don't know. We don't have any proof to say that these are two different diseases, biologically speaking. But we don't have any proof that this is, like a multi-step process, as I suggested, in which maybe the tumor mass, they have acquired additional mutations that confirm the ability to invade and to disseminate. Because in one of the paper by Roberto, it's a very recent paper, they look at patients that had recurrent seromas, and they found that there was already, correct me if I'm wrong, the disease, but none of the patient progressed to a tumor mass or a spread to the lymph node. So there should be something that differentiates patients that progress from those that do not progress. In our experience, we had one patient that had for 1 year the seroma and then spread to the lymph node, but we have another patient with 1 year seroma that did not spread to lymph nodes. So there should be some differences between them.
Thank you so much. And I think we're going to find from Dr. Miranda, he'll share his study right now as well. So,
exactly.
Dr. Miranda, thank you. It was wonderful. Thank you so much.
Good morning. Thank you for inviting me to this important symposium. This title is of the lecture. That's the title was asked to talk. So I talked about pathology the previous 2 years, so they told me be more definitive this time. So what I'm going to do, just review very briefly what I say in 2019, then briefly also what I say in 2020, and then what I'm going to say now, based on what. So I'm going to build on those concepts. I'm going to repeat those. And then today I'm going to say, how I think we should try to, not to miss the diagnosis. I think it mainly is because you suspect the disease, how we proper handling cytology, flow cytometry, pathology, how to do grossing. And then I'll talk very briefly what is beyond ALCL. So what did I say first? 2 years ago, which this is a lymphoma, is seropositive, can be systemic or localized, and certainly this one of localized, the ALCL of the breast, usually present as diffusion, less frequent as a mass. We talk also about how do we define the pathologic stagings and the margins, and then also how we process to have a good surgical orientation of the specimen. So this is cellular cells. All cells are seropositive. And we say that there is a spectrum of disease ALCL, identical cytologically and histologically, but there are forms localized. One of them is the breast implant. The other is cutaneous. This is as you can see, an effusion. That's the most common form of presentation. And the other form is as a mass. I already reviewed that. And then based on that experience, we found that some cases are just floating in the fluid. Cells are floating. We call T0. And then we have progression of T1, T2, T3, T4 as it progresses, as invaded the capsule. And I want just to emphasize there, in the bottom, that's the margin. So we ink all these processes. We want these negative margins, and this is our criteria to say that, to affirm as pathologists that the surgery has been complete. So what is, again, a total capsulectomy? An implant, again, I cannot preach to you. You know this better than I do, but this is complete resection of capsule, including posterior wall. Has to be an oncologic technique. When we know this is a tumor, we orient the specimen, certainly our surgeons, Dr. Kelly Hans, our main surgeon, as well as Dr. Mark Clemens. And then excision of any lymph node. This is an example of an en bloc, and I just copied this morning about this. What is the en bloc resection? It's the surgical removal in the entirety of the tumor without violating the capsule. The capsule has to be intact and requires resection of any lesion, and then there is a little bit of normal tissue around that. So that's a perfect, you can see there the sutures, which tells us where is the superior, where are the margins there. So what else did we say there? So we say that the orientation of the specimen is essential. We want to ink margins, and we want to map the lesions where they are. And now also then we propose a method to process this. So this is our initial specimen, and then we consider that the lesions can be anywhere. So we just randomly, how do we orient a sphere? So our creation was that this, we can say this is like a cube, and give this the side based on the sutures, and we orient this anterior, posterior, superior, inferior, and so on, all the margins, and we ink accordingly. So this is how we get the specimen. Here, this is in the block. We remove the fluid, we open, and we separate. Usually these implants are essentially floating there. And this is how we, at the end, you can see that how we make a sphere flat. So that's the flat, and that's how it allows us to sample thoroughly. After fixating this, we fixate in a wax table and wax where we fix this overnight, and at the next we flip it and ink all the margins according to what we know, and then we take samples of each two of each side, and then we consider that based on the mathematical analysis that we did, that we say that's sufficient to essentially, if we don't see any tumor, I'm sure we are very certain, 95% certain, that we are going to get the tumor. So we publish this, and very well follow. We try to, every time that we get one of these cases, we advertise our article. Now, that is last year. So what I will say today. So the emphasis in how do we don't miss it. First of all, we say suspect the disease, handling property cytology, the flow cytometry, the pathology, but we already just did that. And then also we'll talk briefly what is beyond ALCL. So when to suspect it? We already know, again, now you know very well about this, when the patient has a texture implant, a medium of 10 years, the range can be 2 to 30 years. Usually the patient presents with effusion. Then what type of effusion? If a effusion doesn't respond, initially you put an FNA, you aspirate, and then comes back, you do a replacement of the implants, comes back. That's the typical case. When we see this cytology, this is extremely easy to say these cells are malignant. We do CD30, it's perfect. The diagnosis is very easy. The problem is when things don't go right. Why? Because the patient has been aspirated 2 or 3 times, the patient already has surgery, the cells, the neoplastic cells tend to disappear. Essentially, we don't see them. Sometimes the cells the infiltrate is very necrotic, looks like an inflammation. The patient receives a lot of antibiotics for months, and then appears that the tumor is going away, but really that's not the truth. So how we should handle the cytology? Usually, let me tell you, when you get a effusion which is 5-10 mL, probably it's not ALCL. It's very minimal. You can have a little bit. The patient can have that. And certainly, it has 200, 300. It's very suspicious. And then the main thing is that we should demand that we obtain at least 50, 100 mL of that fluid and send a good amount to cytopathology and do cytospins and then cell blocks and do CD30 immunohistochemistry. That's very useful. We can also send for flow cytometry, and also we can do this. This is an example where you can see a cell block. You can see the cell, how very easy to highlight with CD30. And sometimes you don't see any cell, but CD30 highlights the tumor cells. They are dying. What happened, Dr. Ariana in Napoli also published a very nice article about looking at the cytokines in that fluid. You see a pattern of increase of CD interleukin 10, 13, or eotaxin. It's very likely that this is a ALCL. Versus if you don't see that, it might be just a reactive. So that's when you want to be absolutely certainly. How do we handle flow cytometry? The problem with flow cytometry is that, again, you have to send a good amount, 5, 10 mLs to the flow cytometer, but you have to do request CD30 stain by flow cytometry. Many laboratories don't have it, so then what can you do? You just do the cytology. But when you do flow cytometry and you go to the lymphocytes, because these are lymphocytes, you miss the lesion, because the ALCL cells go where the monocytes are. So if you don't gate on those regions, you miss the lesion. How do we do this, the proper handling of flow? We did it. So we save time here. We already went through this. And then what else can happen with pathology? You say, this is failed interpretation. You get this capsule here. You see that, I don't know how to point this without passing the slide. So anyway, maybe here. Okay. You see the surface here. You see, to me, that's abnormal. And then what happened here, this wasn't suspected as a lesion. 3 years later, the patient comes with an invasive ALCL in the same capsule. So what happened? When that happened, I just request the previous specimen, look at the original, and it's there. What happened here? This is very fibrotic lesion, very few suspicious cells. The pathologist initially says nothing. I say, maybe it is something. So let's do CD30. So we did a study here. We collected 70 cases of patients who had a history of, we diagnosed with breast implant ALCL. Of these 70 cases had a previous episode of effusion or something, but only 10 were able to say, we have a previous material. All the others didn't have any evidence that we get a biopsy, we analyze the fluid, but on these cases, this is what we got. We got 10 cases, 3 remain the same after several years of observation, 5 progress from T4, T2 to T4, and 2 remain the same or progress at T4. Of these 10 cases, 2 died because of progression from T1, which was missing initially, to T4. We published this in this article, which was a follow-up of these cases where it was a procedure performed before, and then we found that in every single case where we could retrieve the previous material, there was evidence of tumor. Again, what happened here, this is, we already saw, this is the ideal en bloc, this is not en bloc. But this patient also, the patient who had this also presented with effusion, and all that our surgeon did is just submit several fragments of capsule. Certainly, what happened, the patient came with a recurrence of disease, more aggressive. What is beyond ALCL? There are other lymphomas which are identical, essentially the anatomic distribution and clinical behavior stage by stage, identical to breast implant ALCL. Among these cases are B-cell lymphoma, DLBCL, marginal cell lymphoma, extranodals, as well as EBV positive ALCL. This has been published in several articles that we have published in our group, where we find that these essentially look histologically the same, the behavior is fairly similar, the therapy is similar, stage by stage, and this is our publication of EBV positive large B-cell lymphoma associated in these cases. And this is an example. You can see it's identical. The only difference, these are all EBV positive. And finally, I'm not going to talk about this breast implant illness and some other lesions that occur also in capsules. In conclusion, this is a disease entity strongly associated with breast implant, can be cured if detected early. The diagnosis can be straightforward, but can be difficult also when the patient has been manipulated essentially and has been missed initially. And again, the emphasis here is that there are new entities, new other histological differences which are not ALCL. And that's our team. And thank you very much for your attention.
So for the sake of time, maybe just, do you have a question for Dr. Miranda?
Yes. So, Roberta, how many cases do you think we're missing and being misdiagnosed from incomplete capsulectomies? So, you know, the whole capsule isn't being removed, and so we're missing diagnoses.
We miss some. How many is difficult to say, but what I want to say is that if we miss the first fluid, we are going to miss the disease. So if the first fluid has been not analyzed and taken the second FNA the patient has, probably has going to have a very decreased, what we call tumor burden. It's going to have more inflammatory cells that Dr. Ariana also has described, is that there are more, look like acute inflammation. And then you say, well, it's nothing here. Why are you going to remove? And then take a samples of the capsule. You don't find anything. But leave it there 1 year. The patient can, with recurrent disease and more advanced. The numbers are very difficult to say. I cannot estimate that. Ariana?
Well, I just want to add a comment to your reply that the seroma is something that appears at the beginning of the disease, but after a certain time, I don't know how much, it could happen that you do not have any more the seroma, but still the disease is infiltrating. So you might think that the patient is okay because it doesn't have the seroma, but if you did not analyze that seroma, you may have missed the disease. So that's why, after a while, she developed a mass.
That occurs. A lot of time there is that we don't have the history. You think that the seroma went away. The patient many times have a drainage. They have catheters, and they have a lot of manipulation. For pathology, when we ask, we find that. Yes?
May I ask just one question? The T4 stage, does the local chest wall infiltration come always after lymph node involvement, or lymph node involvement can be also not observed in the later stages?
They are independent processes, lymph node involvement as well as chest wall involvement. Certainly, I didn't talk about chest wall involvement. I say beyond the capsule. The capsule is not the breast, it's just there. Go beyond, I call that T4. It can go to the chest wall. That will be a T4 real clinical T4 stage.
Thank you, Dr. Miranda. We'll continue on with Dr. Suzanne Turner, speaking on the origins of BIA-ALCL.
Well, good afternoon. Oh, is it afternoon? I'm not sure what time it is. But anyway, hello, everyone. I have to say it's a pleasure to be speaking in front of an audience instead of a Zoom screen. So really good to be here, and thank you for the invitation. So the title that I was given is Origins of Breast Implant-Associated Anaplastic Large Cell Lymphoma. And so what I'm going to do today, Oh, and first I'm going to give you my disclosures. So I do receive research funding from Allergan, and I'm very happy to discuss that with anybody who wishes to with me. But I won't go into that right now. But I'm going to take us back a few steps, and Ariana's really quite nicely set the scene, but I'm just going to take us back a little step and think about what is cancer. We're talking about this disease that develops in the context of breast implants, but what is it really? How does it evolve? And we all know our bodies are made up of millions and billions of cells, and all of those cells have a genetic code. But ultimately, a cell has to acquire certain phenotypes. It has to acquire the so-called hallmarks of cancer, so evading apoptosis, self-sufficiency and growth signals, and so on and so forth. So to get from this relatively healthy-looking little lymphocyte up here down to these quite ugly, sinister malignancies down here, things have to happen. So how do those cells acquire all those hallmarks, and how do they acquire them in the context of a breast implant? Wrong button. So, of course, every time a cell divides, it has to remake its DNA code because it's got to get a new complement of DNA for another cell. And every time the DNA code is replicated, as you can see there, it's a lot of DNA code to replicate, there's room for error. Just from the process of replicating your DNA. So as we sit here now, DNA is replicating in our cells, and there are errors which are ongoing, but we have DNA repair mechanisms. And that picks up most of those errors, but not all of them. But then some of those errors are in part of our genome which are maybe of no consequence. But occasionally they might happen in an area of your genome, in a gene which is a key driver of cell growth and cell proliferation. And then those cells can get a selective advantage, a growth advantage, and grow out. So when those repair mechanisms perhaps don't work, as is in the case of Li-Fraumeni syndrome, for example, P53, which is that security guard there, is not there. So the cells aren't able to make that decision whether to repair or to die. So essentially every day we're living the roulette wheel. Every day we spin that roulette wheel whether we know it or not. And sometimes we're spinning it because there are things going on in our bodies which we have no control over. So just replication of cells every day as a response to replacing your glandular epithelium or whatever. There's also metabolic damage going on, so reactive oxygen species being produced as a result of metabolism in your cells which can damage DNA. And then if we think about lymphocytes, lymphocytes inherently make their own DNA damage on purpose. Because in particular, B lymphocytes, if you think about those, they've got to produce antibodies, antibodies specific to a very particular antigen. So they go through a process called somatic hypermutation to increase the mutational burden within that repertoire. Of course, inherited predisposition in things like, oops, I've gone back and I don't know how to go back. There we go. Inherited predisposition is exceptionally rare, but we have these in children, retinoblastoma, P53, Li-Fraumeni patients. But there's also this big thing up here, these environmental exposures. And some of those environmental exposures, we have very clear evidence that they cause mutations in DNA and cause cancer. But, you know, we've all heard of someone who smoked 60 cigarettes a day, drank, you know, a bottle of whiskey and has lived till they're 110. So you might say they got lucky in the roulette wheel. They got lucky. But many people aren't quite so lucky. But what we do know, of course, is there are certain things. So if you don't smoke, you've got a lower risk of lung cancer. So we can tip the balance because we know there are chemicals in tobacco smoke that cause mutations to your DNA. And there are many more examples of this, of course. Asbestos and mesothelioma, skin cancer, UV light. More recent ones, perhaps, talcum powder and ovarian cancer. Zantac and, this one first, Roundup and lymphoma. Zantac now, it's turned out, I think, that these were contaminated with NDMA, which is a DNA mutagen. All these cases you hear about. Something closer to home for me, a RAF helicopter pilot who developed lymphoma of a lifetime of inhaling the fumes from helicopters. All these things, every day we're exposed to these mutagens. Hormone replacement therapy. And breast cancer, I guess the jury's still out on that one. What about microplastics? They're out there in the food chain. We ingest them every day. We don't really know what they do in our bodies and how they interact with our cells and our DNA. And of course, the one we're all here to talk about today is breast implants and anaplastic large cell lymphoma. So how can we work out what's going on? Well, in my lab, we've spent approximately 20 years now trying to work out how systemic anaplastic large cell lymphoma develops. And when systemic ALCL develops, it develops in the context of a very specific oncogenic event. And that is expression of this protein called nucleophosmin anaplastic lymphoma kinase, which I'll call ALK for short. And as you'll know, breast implant ALCL is ALK negative. That's one of the key diagnostic criteria. But in many of the children, particularly children and young adults that get ALCL, it's due to the presence of this translocation event. And we've done a lot of work showing that actually what initially happens when you express NPM-ALK in cells is the cells enter something called cell cycle arrest in a form of senescence. And to escape that senescence arrest, which is like an early abortive stage of cancer growth, they have to lose some of those checkpoint proteins. And in systemic ALCL, you more often see loss of retinoblastoma than you do P53. And so these cells then re-enter the cell cycle when they lose these proteins, and then they go on, and we assume they have to acquire more mutations because they've got to get all those hallmarks on board, right? And just losing one gene or overexpressing one gene isn't necessarily going to give you all those properties. So you need to mutate more genes. And we think with ALCL, particularly systemic ALCL, that this isn't a genomic instability, it's more an epigenomic instability, because the genome is quite silent when you look at SNPs and indels and these sorts of mutations. So what's going on with breast implant ALCL? And we hear chronic inflammation thrown around, and we know that when you put anything in your body, there's going to be an inflammatory response. Even if you cut yourself, there's an inflammatory response. It's the body's way of trying to deal with the tissue destruction. So we know there's tissue damage that goes on, and we know that there will be a whole plethora of inflammatory cells that get recruited to those sites. And as Ariana quite nicely set the scene for me, we know that there are some common underlying mutations in breast implant ALCL, but it's very chicken and egg, right? We don't know what came first. Did the patient have a predisposition in that they were BRCA or P53 mutated? Potentially. Did they not have a predisposition and got unlucky and happened to develop a mutation in one of those key driver genes? These are all the things we don't really know and what we need to find out in the case of breast implant ALCL. And of course, it's the T cells of the adaptive immune system which develop into this form of lymphoma. And we know, of course, what initially happens when you have an acute inflammatory response is that you get recruitment of all sorts of cells to that site. And the sort of cells that get recruited are things like macrophages and neutrophils to begin with. And what neutrophils do is they produce reactive oxygen species. Yeah? And these reactive oxygen species are produced as a result of this sort of this respiratory burst that they use as little suicide bombers to kill any infectious agents that are around. So you've got mutagens there, reactive oxygen species. You've got macrophages producing cytokines to bring in fibroblasts, to lay down collagen, to make your capsule. So those cytokines are telling other cells to come in as well. They're telling lymphocytes to come to the site. So your humoral immunity, your cell-mediated immunity, collectively called adaptive immunity. And those lymphocytes are going to be reacting to those cytokines and rapidly proliferating. And there again, when you're a rapidly proliferating cell, more chance of DNA damage that might not get repaired. So this is maybe how chronic inflammation drives cancer. And this is maybe how it happens in the context of breast implant ALCL. But why the T cells? Why do the T cells transform? Because it's the B cells are doing the somatic hypermutation, the class switch recombination. Why T cells are getting transformed? Now, if you look really closely at the DNA profile of tumor cells, they give you a hint as to what caused them to become tumor cells, what caused them to become mutated. And when you do deep sequencing of breast implant ALCL, you can do a similar thing. So you get these sorts of traces, and these traces tell you where the mutations are in the genome, which particular nucleic acids are being changed, swapped around. You can look at all these sorts of things. And actually, there's some nice work that came out of Serena Nixon-Al's lab in Cambridge, where she exposed cells to different mutagens and looked at the genetic profile that resulted in the cells. And what she could do is come up with all, I know it's too small to see here, come up with all these different patterns of different types of DNA mutations and could attribute them to a very specific carcinogen. And I'm going to point out one, and this dark green colour here, all these represent the signatures you see when the cells have been exposed to polycyclic aromatic hydrocarbons. Okay. And so you can match that up. And so what she did is then look at that signature and then compare it to the gene signatures that you see in different cancers. And so all the polycyclic aromatic hydrocarbons are here. And if you look at where the mutations are, they're there. And if you map down to which tumours we're seeing that in, it's lung cancer. And that's no surprise, right? Because lung cancer is associated with tobacco smoke exposure, and there are polycyclic aromatic hydrocarbons in in tobacco smoke. Okay, so this is the sort of thing you can do. So I'm going to leave you with a little teaser. And I'm going to ask you to spot the difference. And I've just put one case in there that's different to the others. And hopefully you can spot which one is different amongst all these. These are all forms of anaplastic large cell lymphoma. And hopefully you've spotted this one here. And this one's got a very distinct mutational profile. Very different to the others. So what's different about this patient to all the others? Well, these are all systemic nodal anaplastic large cell lymphoma. Some ALK positive, some ALK negative. This one here is a breast implant, ALCL. So what is causing this different genetic signature? And I'm going to leave you there with that little teaser and let you think about what carcinogens might be on the surface of breast implants that could be causing this mutational profile. And I'll finish there. And I just, of course, have to acknowledge the people that do the work. So this was our first socially distanced picnic in the open air post-COVID, where we're not allowed to be near each other normally. So this is the guys in the lab. This is Emily here, who sat just down here, who's doing this work, along with Jamie. And this is the Addenbrooke's cat. This is our hospital cat. He lives around there. So famous, he even has his own Facebook page. But of course, all the guys in the lab are very important for this work. A long list of collaborators that we work with who have been absolutely instrumental in helping us to do the studies that we do. And I'll leave it there, and I'm happy to take questions.
Yes, go ahead.
Thank you very much for the very nice presentation. I was, however, wondering whether you have the answer to the question why T cells, because T cells should be underrepresented as compared with other inflammatory cells in the milieu. So even if the signature is quite specific of a specific carcinogen, then why the T cells? Do you think they are in a sort of a more sensitive configuration regarding the mutagenic activity of whatever?
Yeah, exactly. So what I haven't talked about today, which I've talked about in other years, is that aryl hydrocarbons are processed by a very specific thing called an aryl hydrocarbon receptor. And aryl hydrocarbon receptors are expressed in very specific subsets of T cells. They're not expressed in B cells. Myeloid cells do as well, you're right. But they convert them into epoxides, which is the actual mutagen rather than the polycyclic aryl hydrocarbon. But I think on top of that, and I just sort of want to link in maybe breast implant illness here. What if we have more of these circulating cells, and within the T cell compartment is Th17 cells, which tend to be there. And of course, if we know these are the cells associated with autoimmunity. So it could be the case that there are more of these cells in some particular women, which could also partly explain why not every woman with a textured implant will get ALCL. But of course, we're also now seeing some of these B-cell malignancies, some of these squamous cell carcinomas starting to be reported in the literature as well. So it's not exclusively a T-cell thing, perhaps.
Can I say something? So also because if we look at reactive seromas, they are enriched in T cells instead of B cells. So it's the type of inflammatory reaction that is more a T cell reaction than a B cell reaction. So it might explain why we have a T cell lymphoma instead of B cell lymphoma, although as it's shown by Roberto, there are cases of B-cell lymphomas. They are mostly driven by an infection or a reactivation of a EBV, okay? So Epstein-Barr virus. So we don't know if actually also in those cases there's, an immune dysregulation of the T cells that follows the reactivation of the Epstein-Barr virus as any chronic inflammation state, right? So the T cells plays a very important role.
Yeah, in the comment on this EBV positive and lymphomas is that this is a local immunosuppressive environment, and they, in fact, they have a latency type 3 of EBV pattern, which means very immunosuppressed, and that probably because it's the isolation of the cells which are there.
Yes, so with EBV, it's like Burkitt's lymphoma, right? You have to have a level of immunosuppression which enables EBV to reactivate, drive B-cell proliferation, cause the translocations. So it's slightly different. But you know, with any inflammatory microenvironment, you're going to have a whole soup of different things in there. And cancer isn't selective in any way. It's very opportunistic, right? So it's going to very much depend on, you know, the cytokines in the microenvironment, also all sorts of different things. And so not every patient is ever going to be the same as the next.
Thank you so much, Dr. Cherny. We really appreciate that presentation. Dr. Andrew Feldman will now be speaking. This is his first time speaking to the Congress, but he's been a great collaborator on BIA-ALCL for many years, as well as he's on the Committee for the Classification of the World Health Organization. So we'll go ahead and start that video.
Hello, everyone. I'm Andy Feldman. Thank you very much for the invitation to speak. I'm going to be talking about defining breast implant-associated ALCL through molecular profiling. These are my conflicts of interest. So our group has used gene expression profiling to define genetic subtypes of anaplastic large cell lymphoma, including, in addition to ALK-positive ALCL, subsets of ALK-negative ALCLs that have rearrangements of DUSP22 and or TP63. And the remaining ALCLs that have none of those three rearrangements we've termed triple negative cases. So one of the interesting observations that came from unsupervised clustering of ALCL cases was that ALCLs tended to cluster more based on their genetic subtype than by their WHO subtype. And specifically in unsupervised clustering of a data set that included both systemic and cutaneous ALCLs, the cutaneous ALCLs clustered along with their genetic subtype, not along with other cutaneous ALCLs. And this is shown in supervised clustering down below. And so when looking at breast implant-associated ALCLs, it's important to recognize that so far all of the cases that have been published are of the triple negative subtype, in contrast to the distribution of genetic subtypes in systemic or primary cutaneous disease. Because of this, when we set out to examine the molecular profile of breast implant-associated ALCLs, we felt it was important to compare them only to their triple negative non-breast implant-associated counterparts, and excluded from this study ALK-positive ALCLs, other ALK-negative ALCLs of other genetic subtypes, and other PTCLs. So what we're looking at here is just breast implant versus non-breast implant triple negative ALCLs. And what we found was that the breast implant cases do indeed have a signature of upregulated genes. We also saw two other signatures, which are not surprising given the patient population we looked at. First, we saw a Y-linked signature because our other ALCLs included patients of male gender. And we saw a keratin signature because our other cohort included primary cutaneous cases. We now examined this breast implant-associated ALCL signature in greater depth. And one of the main gene sets that we saw enriched by gene set enrichment analysis was a robust hypoxia signature. You can see some of the genes here: VEGF, carbonic anhydrase 9, and GLUT3, for example. And this is not surprising given where we think breast implant ALCL cells originate in this avascular space surrounding the breast implant. So it makes sense that these cells would need some mechanism to overcome the deleterious effects of hypoxia in order to survive and become lymphoma cells. And of the genes in this hypoxia gene set, carbonic anhydrase 9, or CA9, was one of the most significantly differentially expressed genes. And so we looked at CA9 in greater detail. So CA9 is used as a biomarker in certain situations. In renal cell carcinoma, it is a very nice immunohistochemical stain, very reproducible. And you can see here on the left in example photographs, and on the right numerically, that CA9 is fairly specific for breast implant-associated ALCL. In the upper right, this is by WHO subtype. You can see very minimal expression in other types of ALCL. And down below, this is broken down now by genetic subtype, and particularly important, this is not just a triple negative feature, because non-breast implant associated triple negative ALCLs also lack CA9. It's only the breast implant cases that express it. So we examined the 3 TLBR cell lines for CA9 expression. So these were developed by Dr. Alan Epstein. And we looked at their CA9 expression under baseline normoxic conditions after hypoxia, and then we also knocked down CA9 with an siRNA. And the figure on the right shows what happened to the cells, relative growth. So interestingly, the 3 cell lines have very different patterns of hypoxia programming and CA9 expression. So TLBR1 actually has a constitutive hypoxia program and expresses CA9 even at baseline under normoxic conditions, although there's some further induction with hypoxia. And there's some minimal CA9 dependence, so when CA9 is knocked down, there is some reduction in growth. TLBR2 really is the model of canonical hypoxia. It does not express CA9 at baseline. CA9 is induced by hypoxia, and that's accompanied by a very robust increase in growth, and that growth is essentially entirely reversed by knocking down CA9. In contrast, TLBR3 is relatively resistant to the effects of hypoxia, and there's essentially no induction of CA9 and no alteration in the growth characteristics of the cells under hypoxic conditions. And so if we want to study the role of hypoxia-induced CA9, TLBR2 is the most appropriate model. And so we did RNA sequencing on TLBR2 cells in triplicate under normoxic and hypoxic conditions, and then also under hypoxic conditions after knocking down CA9. Here you can see expression of CA9 itself from the gene expression data going up with hypoxia and back down with siRNA. And as expected, treating with hypoxia upregulated this hallmark hypoxia gene set. What was very reassuring is that when we took the set of genes that we derived from tissue specimens of BIA-ALCL, this gene set was also very significantly enriched upon treatment with hypoxia, showing that this gene set really does reflect a biologic phenomenon stemming from the ALCL cells themselves. And then also interesting was when we knocked down CA9 under cells grown under hypoxic conditions. One of the most prominent gene sets that we saw depleted was the S phase gene set, so cell cycle gene set, suggesting that the advantage to BIA-ALCL cells with CA9 may be promotion of cell cycle. So we then wanted to explore that in mouse models. So here we use TLBR3, which, as I showed you before, lacks baseline CA9 expression, and then using a lentivirus, we either transduced in an empty vector or CA9 itself, as shown here, and grew these as subcutaneous tumors in NSG immunodeficient mice. And here you can see the percentage of tumor-bearing animals. So this is tumor take, and you can see a marked acceleration of tumor take in the CA9 overexpressing cells with very dramatic differences in the volume of the subcutaneous tumors, as well as a significant difference in survival of the animals. We also looked into CA9 as a possible biomarker in BIA-ALCL. These are the CA9 levels by ELISA in TLBR cell supernatants, and they correspond very nicely to what we saw in Western blots of the TLBR cells themselves, i.e. that TLBR1 has the highest and TLBR3 the lowest. So CA9 is secreted into cell supernatant. And then when we grew the cells as subcutaneous tumors in NSG mice, we looked at the CA9 levels in tumor lysates. Those were high in TLBR1 and TLBR2 and low in TLBR3. And then we looked at the mouse serum of these tumor-bearing animals. And we also found that CA9 levels in the serum were highest in TLBR1 and 2, lower in TLBR3. And so these suggest that the CA9 not only is in the tumor, but may make it into the serum as a candidate biomarker. In a limited number of patients, we had seroma samples from patients either with breast implant associated ALCL or peri-implant seromas without ALCL. And we showed increased and sometimes very high levels of CA9 in the ALCL patients. And in very limited study, we saw an anecdotal increase, at least in one patient, of CA9 in the plasma above the upper limit of normal. So in conclusion, BIA-ALCLs demonstrate a hypoxia signature, likely attributable to the unique microenvironment in which they arise. CA9 is expressed consistently in BIA-ALCL and only minimally in non-BIA-ALCLs. And these findings support other clinical and pathologic data that BIA-ALCL really is a distinct biologic as well as clinical pathologic entity. CA9 drives BIA-ALCL cell growth in preclinical models and is detectable in seroma fluid and or blood in BIA-ALCL patients in mouse models. And these findings support CA9 as a candidate biomarker and therapeutic target in BIA-ALCL. I'd like to acknowledge the many people who contributed to this work, including collaborators at MD Anderson and the various sources of funding support. Thank you very much.
Thank you, Dr. Feldman. That was very impressive. Are there any questions? Here we've got a question from the audience. Thank you also, by the way, for tuning in at what I know is a difficult hour.
Thank you. BIA-ALCL, even when the BIA-ALCL goes to the lymph node, or it marks just the seroma, the capsule-associated phase of the disease, let's say. The question is whether the overexpression of CA9 through lentiviral vector is recapitulating the hypoxia signature. At what extent does it recapitulate the BIA-ALCL hypoxia signature?
Yeah, good morning, everybody, and thank you again for the kind invitation. Sorry I can't be there in person. So CA9 is part of the cellular mechanism that allows cells to resist the deleterious effects of hypoxia, in part by balancing intra and extracellular pH, and it also has other intracellular mechanisms. So by itself, it doesn't necessarily recapitulate the hypoxia signature. And in fact, as we sort of suggested through those knockdown experiments, it may be playing a role in promoting cell cycle. And there are several papers looking at effects of CA9 beyond its relation to pH balance as an oncogene. So I think it's doing more than one thing.
Why don't we do one more question, just because he...
Hi, Andy. It's Suzanne. How are you doing? So really nice data. Good to see it. I wonder with your NSG mouse models, you're sort of creating a very artificial situation there with the subcut tumor. Do you see a difference when you, for example, put the cells in the mammary fat pad and sort of better mimic the situation in humans?
Yeah, that's a great question, Suzanne. We haven't done that.
Of course, the problem with working with cell lines is they've adapted to growth in vitro, and they're not necessarily in a sort of hypoxic environment anymore. So what you're seeing could be sort of an artifact of the cell line system rather than what's happening in vivo.
Yep, that's absolutely true, and we haven't done those experiments. I mean, I think when we showed those tumor data, what you see is very early take of the tumors, and I think that's one scenario where the model does recapitulate hypoxia. When you first inject tumors, of course you're injecting cells in a fluid. Which I think is actually very similar to the seroma environment. So I think the early take that we see is probably related to that ability to evade hypoxia, but the effects later on are not as clear.
Thank you so much, Dr. Feldman. We really appreciate it, as well as dialing in. It was a fantastic lecture. We'll go ahead and continue on with Dr. Kara Haymaker from MD Anderson Cancer Center. She'll be presenting on the immunologic factors underlying BIA-ALCL.
Hi, good afternoon, everyone. I'm excited to be here today, and thank you to the organizers for the invitation to update on some of our immunological work through the patients we've seen at MD Anderson. So the title of my talk today is Immunologic Factors Underlying BIA-ALCL. So I have nothing to disclose. As a very brief outline, I'm just going to quickly remind everyone on the previous findings that I discussed last year in this conference, and then some new data where we're identifying distinct immune signatures that are derived from gene expression profiling using nanostring, and now how we are utilizing single-cell sequencing-based technologies to understand both the TCR repertoire as well as transcriptomic profiling of the cells from the microenvironment, the summary, and next steps. So this is data that I'm presenting on behalf of a very multidisciplinary team at MD Anderson, where we are really attempting to understand from both surgical specimens and seromas the overall genomic and immunologic underpinnings of this histology. And so what I'm going to focus on today is some of our cytokine work that's been previously discussed, and again, our RNA gene expression profiling in single cell. So what has nicely been published and already discussed earlier in this session is that when we look at the seromas of patients with BIA-ALCL, we see a very distinct cytokine composition. In part, this is highly characterized by the presence of eotaxins as well as Th2-associated cytokines such as IL-10 and IL-13, and these can also be associated with other cell types that can be within the microenvironment. You can also find other types of inflammatory factors such as IL-22, interferon gamma, and TNF-alpha. We also know that the presence of eotaxin actually also associates with the presence of eosinophils within the capsule and is likely recruiting them to that microenvironment. So overall, we found that there is definitely a distinct cytokine profile in consensus with other data that's been reported. We see high levels of IL-22, of Th1, NK, and CD8 cytotoxic pro-inflammatory type cytokine microenvironments, and we see that the presence of eosinophils is really associated with these Th2-associated cytokines. We also interestingly found that a lot of the Th2 cytokines or associated cytokines actually positively correlate with each other. And this is not true of the pro-inflammatory factors. We see no association of interferon gamma or TNF alpha with each other, which is kind of a distinct difference. And we actually don't see, although it's been reported in other studies, we don't see any IL-17 in our seroma cytokines. So this led us to our hypothesis and questions, and we really, are hypothesizing that the development of this tumor is really associated potentially to either an allergic type response or a pro-inflammatory stimuli, has been kind of discussed in this forum. And so the questions we wanted to ask within our data set: is the immune presence in the seroma reflective of the cellular component that either is present in the seroma or in the tissue with the capsule? And can we define the transcriptomic profile of this disease? And are these T cells actually reflecting more of a clonal or a diverse TCR repertoire? So when we looked at the gene expression profiling of the tissue, we found that when we compared, here we're comparing 5 negative control samples with 28 positive samples. This is showing a differential gene expression plot. Here above the solid line is an adjusted p-value of 0.01, and you can see we have a very distinct gene expression profiling difference from the negative to our positive cases, although to be fair, this is not perfectly balanced. But we do see a lot of genes that are encoding cytokines, chemokines, pathogen defense response genes that are really clearly lining up with our BIA-ALCL cases. Just as a quick check, this also aligns with CD30 expression at the gene expression level, and then this is just showing that we also have a number of cytokines that are positively associating with this disease. Now, when we use nanostring technology to identify the cell types that we can explore in this type of gene expression profiling, we see that there is no difference in the overall immune composition in terms of just CD45. But when we break this down into subsetting, we see very striking differences in the cellular fraction that is associated with these tumor types. We see a lot of T cells, as you would expect. We also have a very high cytotoxicity score. This cytotoxicity score is comprised of both NK cell fractions as well as CD8 positive T cell fractions. And the CD8 T cell fractions have an exhausted type of phenotype. So this is usually reflective of a PD1, TIM3, LAG3 sort of status. And we also see that there is a significant increase or difference in the presence of Th1 cells. In this data set, we did not see any difference in T regulatory cells or myeloid lineages that are shown here on the right, or in the presence of B cells. The other thing that was very interesting, though, about this type of gene expression profiling is that if we actually rank these individual cases based upon the T cell infiltrate, and that is shown here on the bar on the far right, each row in this case is reflecting a different patient sample, and we're looking at the ratios of cells to each other. Okay? But we're ranking this based upon having either a very high T cell signature or a very low T cell signature. And when we do this, we actually find 2 very distinct clusters that are forming. We have this cluster over here that has a very low T cell signature. As you can see on the right, it's in blue. And instead now we have this association with a lot of NK cells and T regulatory cells, not as a total population, but as a fraction relative to the T cell. Now, when we look, however, at the T cell rich patient samples, we see this other type of ratios that are coming out, where we have an increase in macrophage and dendritic cells as it relates to those T cells. So again, kind of talking about how these the overall composition of the immune landscape could be very different based upon the T cell presence. Now, can we take this a step further? Can we really try to then understand at the single cell level what is happening in our patient samples? Can we utilize this technology to better stratify the tumor cell fraction from any type of other T cell that actually might just be there due to the local inflammation. We know T cells are going to be attracted based upon chemokine and cytokine microenvironments to just come into a site of inflammation, but they might not actually be pathogenic. We know that there is a very strong component here that is driven by cancer. And so we utilized 5' sequencing of single-cell T-cell, single-cell sequencing technology using the 10x platform. We had 10 cases that were cryopreserved from seromas that were cryopreserved as single-cell suspensions. We thawed those, and then we ran our 10x genomics platform. Using the 5' sequencing, we're able to get both transcriptomic profiling as well as TCR sequencing as well on the same cells. And so we can then look at the TCR composition relative to the transcriptomic profile. Using this type of technology, this is very early data that I'm sharing with you guys today, so I welcome all feedback. This is very exciting. We have our UMAPs here on the left, showing the overall overlap between these cases. You can see that there is a number of cases within the patient cohorts that overlap with each other. You can also see that we have some very distinct non-tumor seroma samples that really cluster away from any other cases. And this, of course, is the caveat here is that we only have 5 and 5, but for instance, this negative case here, negative 12, is very distinctly clustering by itself. It's not looking like any other negative case or any other positive case. When we break this down into overall types of clusters, we've identified now just 22 individual clusters, and we can look across the different populations for different T-cell signatures. A few things of interest that we found is that we can identify NK cells and cytotoxicity profiles across these both tumor cells and negative samples. And as something that was a little unexpected, because it's not exactly concordant with what's been previously published, we didn't find a strong myeloid presence in the cases that were selected for these tumor profiles. We actually found most of our myeloid features reflected in the negative cases. But again, this is only an N of 5, and these cases were actually selected based upon a high level of tumor presence, and so we were trying to really profile the tumor cells themselves. So of course, again, needing to expand this. Okay, I'll hurry. We're also looking at the co-expression of CD3 and CD30, and we're able to identify CD30 positive cells that lack CD3, and we're also able to identify CD3 positive cells that lack CD30, all within these same patient samples. Also, surprisingly, we found a very diverse TCR repertoire. Now, there's a lot of potential reasons for this. It could be due to just presence of cells that are coming in due to inflammation. It also could be due to genetic instability at the level of the DNA, where we are actually having minor mutations within the TCR that then is causing these to be identified as individual TCRs. And I think this is a really interesting data set, especially given the earlier talks talking about the high level of genomic instability in these cases. In addition to that, when we look at the hallmarks of cancer that are upregulated in these tumor types, we also see a strong hypoxic signature. We see a lot of STAT and IL-2 signaling, interferon gamma, TNF-alpha, and allograft rejection signaling as expected. And we are now deconvoluting the various cytokine profiles that you can see here shown at the single cell level. So overall, really pointing out that this is a very heterogeneous population that is characterized, however, by some very specific cancer pathways that do allow for concordance. So in terms of our summary, we find that transcriptomic profiling is really revealing a very high degree of heterogeneity within these cases. When we look at our differential gene expression, we find that we have a lot of signatures associated with cytokines, chemokine, pathogen defense, and NK cell functions. We also find, of course, CD30 being upregulated, although that is not the end-all be-all to marking this cancer type. And we identify that TCR clonality is highly diverse, and it could be very suggestive of multiple features of the immune response. And really, we would need to do some type of single-cell ATAC sequencing or other type of very deep profiling of the DNA to really try to understand what is happening as it relates to any type of mutations. And we're finding, again, these specific hallmarks of cancer identified using this pathway. So in terms of next steps, you can see those listed here. And definitely want to thank everyone on the team, our breast implant-associated ALCL team, as well as the individuals in my lab that performed some of this work. And thank you all for your time and attention, and happy to take any questions.
Wow. Thank you so much, Dr. Haymaker, for that absolute tour de force. That was really impressive to see that all come together. Gosh.
And
Dr. Turner, Dr. DiNapoli, I know that this is so in line with what you're working on.
Thank you very much. Exciting data. The single cell analysis are really very informative. I was wondering whether you have some data regarding the levels of expression of the TCR in these cases. So is the basic level of expression of TCR comparable with a, let's say, activated or exhausted CD8 expressing T cells, or the average level of TCR expression was lower in the malignant cells as compared with normal T cells?
It was lower than compared with normal T cells. And yes. Now, I don't have protein data, however, to back that at the single cell level.
mRNA,
But at the RNA and DNA level, it is lower.
Yeah.
Yeah.
Because the TCR isn't expressed in
Exactly.
ALCL, right? So,
Yes.
So,
Yes.
So this
And-
diversity could mean nothing,
Very.
essentially.
Very much.
Yeah.
Very much. Yeah.
Absolutely.
Yeah.
And did you look at so it's the CDR3 regions that you were looking at in
Correct. This is
particular?
full-length
Yeah.
TCR sequencing. Yes.
Yeah. Okay, that's interesting.
Yes.
So there's you don't think there's a common antigen then in that case?
No.
Yeah.
Well, yes, not a common antigen that would be driven through a TCR. A non-specific TCR activation could happen. Yes.
Yeah.
We can't exclude that.
Because I noticed you put potentially ILC3 at the beginning of your talk.
Oh, in terms of association with
Yeah.
IL-22, it's just a
Because
possibility.
ILC3s don't
No, they do
rearrange a
not.
T cell receptor,
No,
right?
they do
So
not.
it's definitely not ILC3.
No. We did not see that in the single cell data at all.
Yeah.
Correct.
But it's really interesting. So when you say the T cell receptor diversity,
Yes.
do you look at specifically at the CD30 positive cells?
Yes, so we're looking at the CD30 positive cells in
Yeah.
that case, and I apologize I had to go through that a little quickly.
No, it's cool.
But it's full-length alpha-beta sequencing of the CD30 positive cells. Yes, and they are not, they're very diverse. So I really think that there could be some very specific point mutations that are happening, or it's just down modulation completely at the DNA level.
Yeah, I think it's down regulation. I mean, I don't have time to present this data today, but we do have data to suggest why the T cell receptor gets down-regulated. But I think it's a part of the oncogenic process. The T cell receptor and JAK-STAT signaling or whatever else is just overkill for the cells. It's too much. So they have to down-regulate one or the other.
I think, it's so interesting, though, because I expected to see that at the protein level, right? I didn't expect to see it at the DNA level.
Yeah.
So that was very interesting. Yes.
That the T cell receptor was downregulated, as you know from our paper from the transcriptional analysis. But the point is, which is the cell of origin of this tumor? Is a precursor T cell, or is like an activated T cell?
Right.
When we perform a cybersort analysis, we found that the closer normal counterpart of BIA-ALCL was actually a CD4 positive activated T cell instead of CD8 cytotoxic T cells, although it has some cytotoxic features because they usually express granzyme B.
Yes, exactly.
For instance. So we actually don't know where is the BIA-ALCL, normal counterpart of tumor cell. We don't know if it's more a CD4 or more CD8 or whatever it is, or T regulatory cell.
Yes.
So we are
still that's something that we are trying to apply a trajectory analysis called monocle to. It's something that we do more in solid tumors with tumors. We haven't really done it with T cells, but we're going to try because it's really intriguing if we could actually track this back and identify a precursor within this data set. Yes.
Thank you.
I mean, I think the T cells they're constantly changing depending on how the cytokines change around them. And you know that axis between Th1, Th2, well, you can't go that way, but Th17 to Treg, and it's very fluid, very fluid environment. So there probably isn't going to be the answer. And of course, we know in systemic ALCL, right? For 20, 30, 40 years, we've been looking at systemic ALCL, and we still don't know what type of T cell it is, right? It's cytotoxic, it's helper, it's got a bit of this, a bit of that. Yeah.
All right.
Okay.
All right. Thank you so much,
Thank you all.
Dr. Haymaker.
Thank you.
Obviously, really interesting.
Let me draw your attention on one point, sorry. I really have no words enough to express my gratitude, those basic scientists coming here to help us, plastic surgeons, to deal with such a matter. So I'm really thankful. They woke up in the morning and they are not plastic surgeons, they're only basic scientists. So the only way that I can find to express my gratitude is to say that instead of doing 1 hour lunch and we stay 45 minutes, we recover 15 minutes and we get slimmer. Thank you very much.
That was a spectacular panel. This is really amazing to see.
It's interesting how everything's evolving. You know, great work from Carl, really great.
Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company.
Faccio veloce. Questo me lo tengo qua, se salta tutto.
CA9, ICC4, I don't know what it is. Uno, due. Che è? Funziona? Il terzo? Non serve, non serve. Ci sono solo due. Sì, sì, tutto il giorno. Sì, vabbè, lascialo per dopo eventualmente se sì. Iniziamo.
The session 3 that will be focused on diagnosis and management of BIA-ALCL, and Michael Sorotos will give us the first lecture.
Okay, thank you, Ariana. Welcome back, everybody. I'm going to speak to you about BIA-ALCL clinical and diagnostic elements. These are my disclosures. So the National Comprehensive Cancer Network guidelines that were updated in 2021 include as main physical signs associated with BIA-ALCL the presence of an effusion, enlargement, a mass, a skin ulceration, and more rarely lymphadenopathy and a skin rash, or capsular contracture. Although capsular contracture in isolation as the only disease manifestation has not been described, therefore its reliability as a symptom of the disease is questionable and may be coincidental. So all those symptoms usually present a year or more after implantation, and the mean time of presentation is 7 to 9 years. So during the initial workup, and this is the workup of a suspected case, the first line radiological exam is a breast ultrasound. And this is an easy to perform exam. It permits to identify an effusion and at the same time proceed with the aspiration. So any effusion collected should be sent for cytology and a culture for pathogens. We always do that. So in case of a mass or a biopsy should be done and also sent to pathology. So when ultrasound is inconclusive and we have a very suspected case, we can use MRI in order to evaluate our patients. So patients with T-cell lymphomas also often have extranodal disease, and which can be inadequately imaged by CT, and in these cases a PET scan should be used. I'm not going to focus more on the pathology workup. It was discussed before, and the treatment, because it will be discussed later on. So mean age of onset is 52 years, and the time of onset is usually 9 years post-implant. In 86% of cases, there is a seroma, an effusion. A mass is present in 15.7% of the cases, and regional lymphadenopathy in 15% of the cases, or none of those symptoms in 3.5% of the cases. The disease usually presents unilaterally in 98% of the cases, and only 2% of the cases are bilateral. So the question is, which screening modality is the ideal one? So this is a very interesting work by Adrada et al. It was aimed at describing the imaging findings of patients with BIA-ALCL and determine the sensitivity and specificity in the detection of the presence of an effusion or a mass. So sensitivity means the true positive rate, the proportion of positives that are correctly identified, and specificity measures the proportion of negatives that are correctly identified. So we're going to look at all those diagnostic exams and see how they perform. So ultrasound has shown to have an 84% sensitivity and 75% specificity in detecting an effusion, while it has 46% sensitivity and 100% specificity for detecting a mass. So this image on the left shows fluid collection between the implant and the capsule. It's very easy to identify and aspirate in order to examine. While on the right, we can see an ultrasound of the upper outer quadrant of the breast with a complex cystic and solid mass. A CT scan has been shown to have a 55% sensitivity and 83% specificity in detecting an effusion, so it's not the best exam, while it has a 50% sensitivity and 100% specificity in detecting a mass. So the image shows a mass adjacent to a breast implant. And then finally, we have the PET scan, which has a very low sensitivity for an effusion detection and 64% sensitivity for a mass detection. So it should be noted that the metabolic component of PET CT scan does not allow determination of whether a peri-implant effusion is benign or lymphoma related because of the cell density, which is very low. So we see here a PET scan with increased metabolic activity due to a mass present near the implant. So finally, regarding PET scan, although it has been routinely used for other type of lymphomas, it's not yet validated for BIA-ALCL. Nevertheless, it remains among the standard radiologic imaging techniques used for patient evaluation and follow-up. So regarding MRI, finally, we see that it has an 82% sensitivity and 33% specificity for detecting an effusion, while it has a 50% sensitivity and 93% specificity for detecting a mass. So we see an image with an implant and an effusion around the implant, seroma presence. So MRI, though, is very important because it has a very high sensitivity and 90% and specificity of 97% for implant rupture detection, and it is routinely used for patients with breast implants, and it is able to discriminate the nature of implanted prosthesis or if it is an injected material, and its sensitivity of cancer detection with MRI is not reduced through implants. We have some images of capsular contracture and implant rupture. So to sum it up regarding BIA-ALCL, we know that a first-line exam that we have to use is an ultrasound for the effusion and mass identification, and it can provide immediate fine needle aspiration and evaluation of the seroma. If ultrasound is inconclusive, we should use an MRI, and it is a second-line test to be used, and then CT and PET scan should be used for patient evaluation and follow-up. I will close my presentation by presenting to you a case we diagnosed almost a year and a half ago, but which I find very interesting to understand how important it is to be aware of the pathology and also do the workup very accurately. So we have this, I would say, textbook case of a patient that came to us, 76-year-old patient, presented in our clinic with a history of radical mastectomy and expander implant reconstruction with a textural implant 15 years before. She came to us in June 2019. So she had an effusion. Her history was of presence of an expander and mentor Siltex implant. So she came to us for a consultation due to recurrent seromas. We did fine needle aspiration of the seroma, cytologic analysis. Professor Di Napoli did the diagnosis and gave back to us the result. So as a protocol present in our hospital, we immediately did a PET scan for evaluation and immediately went on to do the surgery the week after with en bloc capsulectomy. And the histology exam confirmed the diagnosis. But what is weird, or what is something to note about this case, is that this case, although it seems like a textbook case, it has a more different history. So this patient in 2004 had the expander. 2005, she had the analogous BIA-ALCL implant. She had implant replacement in 2018 in another center for implant rupture. And at that time, she received a partial capsulectomy that was sent to pathology, and they weren't able to identify anything else than granulation tissue. So a month later, she had started presenting recurrent seromas, and that was thought to be, was attributed to the surgeries that she recently had. So they did multiple ultrasound aspirations of the seroma, but they didn't send it to pathology for examination. So then the patient came to us, and we did the diagnosis a year later. So when we evaluated the patient after surgery, Professor Di Napoli gave to us the result of the histology of the capsule, and we found on the posterolateral margin of the capsule the cells that invaded the whole capsule. So the result was an R1 staging, and so in a multidisciplinary approach, we decided to give the patient radiotherapy treatment that was successful in reducing the presence in the PET scan of a high metabolism. We recently published this paper in Annals of Plastic Surgery, and thank you very much for your attention.
Any question in the audience? Before the audience think about the question, I would ask you a question on your case. If I understand well, she had a seroma,
yes.
And because she had a texture implant, there was a confusion. We didn't know if it was a seroma from the texture implant or a seroma to be considered as ALCL. If it was a smooth implant, the question was not supposed to be think about. I mean, what do you think? Every seroma should be considered as an ALCL for you?
So in this case, the patient had surgery a month before she started producing these seromas. So, and this is why I think it wasn't tested. But in my opinion, all seromas should be tested. So we shouldn't think that the patient has a texture implant or a smooth implant. So all seromas have to be tested. This is what we do. We have a protocol. Everybody knows about that. All patients that have a seroma, they go through the same protocol.
We have the same, and since the ban of texture implant now in our country, it's the question of, it could be a seroma related to texturation, is not a question anymore. So it's one of the remarks I would like to make.
I agree with you.
Well, I just want to remark that there is a need of a multidisciplinary approach when there is a diagnosis of BI-ALCL in which different physicians come together and discuss about the case presented. In this particular case, we discussed a lot because I found this R1, so there was a microscopic residual disease. So we discussed of what to do, which is the best way to probably remove this residual disease, surgery or radiotherapy or other pharmacological treatment. But I think that each case should be treated separately and should be discussed in a multidisciplinary approach as the FDA suggested in their guidelines. So just thank you very much.
Thank you.
Okay, we go. So we go for the next speaker, Miranda. Guideline for samples processing. No. Sorry. Mr. Hunt. beyond guidelines, surgical management of advanced BIA-ALCL. Thank you and sorry for the miss.
Yeah, we should mark.
Yeah, we should mark. Huh?
Thank you.
Thank you very much. Pleasure to be here with all of you. So I have, these are my disclosures. I won't be discussing any of these relationships today. So to go back to the guidelines that was mentioned earlier, the NCCN guidelines, I couldn't agree more with the moderators here that although we have guidelines for management of these patients, each individual case presents unique situations, and so multidisciplinary input is so critical into what we do. So in general, localized disease, patients will go to surgery for resection, capsulectomy, and en bloc resection of any mass lesions. But those who have more extensive disease sometimes will need systemic therapy first before any surgery. And so I think the cases that I want to show you today illustrate some of the clinical scenarios and how we manage these patients surgically. So very commonly, of course, as the previous speaker stated, the effusion is one of the most common things that we see. Sometimes, though, patients will present, interestingly, with masses without any effusion at all. Sometimes patients will present with limited axillary nodal involvement. I'm going to show you a case with more extensive axillary nodal involvement, extension to the chest wall, and then another situation which we've seen in many patients is where they will have rashes or actual skin lesions that are part of the lymphomatous process. So typical effusion shown here, 56-year-old woman who had breast augmentation in 2005. 15 years later, she presented with swelling in the right breast. She had breast imaging looking for something in the breast itself. Mammogram was normal. Ultrasound showed fluid around the implant. MRI also confirmed that, as seen here. And fine needle aspiration biopsy was performed, and this showed BIA-ALCL. She had a PET scan. On PET scan, the effusion did have some FDG avidity, but not much. In April 2020, she had a bilateral capsulectomy, which was very successful. And on evaluation, the tumor was found to be multifocal, but it was confined to the superficial luminal side of the right implant capsule. And of course, it's only been a year and a half or so since her surgery, but she's doing well without evidence of disease. And this is some of the very typical. So if the effusion is identified early enough and they have en bloc resection and removal, it can be very successful with surgery alone. This is another case of a patient, 46-year-old, who had breast augmentation in 2004, and then 12 years later presented with a mass in the left breast. She had breast imaging, as would be typical with mammography and ultrasound, which really didn't show anything of suspicious nature. She was felt to have scar tissue related to the fact that she had breast implants. And so I think she went for at least a year without any further evaluation. And unfortunately, she presented a year later with another mass, and she had MRI examination which demonstrated mass lesion in the chest wall. And she actually had multiple masses, which you can see some of them here on the PET scan. She had 4 separate masses in the breast, one along the chest wall there. You can see abutting the ribs. And biopsy was consistent with ALCL. So in this case, because of the chest wall involvement, she was treated with brentuximab for 2 cycles, actually had a very nice response, and then presented to us for surgery. So you can see in the lower PET scan imaging that she still had some FDG uptake there, but it was much decreased. So she underwent bilateral capsulectomy. We also did partial mastectomy in order to have negative margins around the mass lesions in the breast. And then postoperatively, she received 7 cycles of brentuximab and is now still several years later doing well. This is a patient who had a very interesting presentation. She's 57. We just recently saw her, but she has a history of silicone implants placed in 1987, so quite a number of years ago. In 2007, she had the implants removed and replaced with textured saline implants. In 2015, she developed swelling and fluid around the right breast implant. She was seen at a very reputable center in the US where she had surgery and removal of the implants with placement of new implants. None of the fluid was sent for cytology or histology, and I think Dr. Miranda, who we recently took care of this patient, reached out to the other center and didn't find any evidence of any histologic examination or cytologic examination. So this patient in April presented with fluid around the right breast implant, and you can see in the upper image there, quite large. In her photograph you saw previously, aspiration was positive for ALCL. She also had this PET-avid axillary lymph node. And so this appeared to be limited nodal involvement, so a Savvy Scout device was placed in that lymph node so that we could target it for removal. And this just shows a specimen radiograph of the lymph node with the Savvy Scout device showing that we removed the appropriate specimen. She had bilateral capsulectomy, and it's only been a short time, but she's doing well post-surgery and does not appear to need any additional therapy. This is another case dramatically different with extensive nodal involvement. So this is a 54-year-old who had augmentation 2005. In 2014, interestingly, she was told she had complications and was treated with antibiotics. In 2017, she finally had a lymph node biopsy that showed ALCL, and you can see from the PET imaging here, both the breast and the axillary nodes quite extensive. So she came to us with 15-pound weight loss, drenching night sweats. She was quite deconditioned. She had extensive workup, including bone marrow biopsy that was negative. She was not felt to be a good candidate for any systemic therapy because she was so deconditioned. So we took her to surgery and did capsulectomy. She had quite large masses in the breast, and we did an axillary lymph node dissection with 15 positive nodes. Postoperatively, she received brentuximab and actually is currently doing quite well. And then finally, this is a case of extension to the chest wall, a 40-year-old female who came in through the emergency center at our hospital with a recent diagnosis of ALCL. She had had breast augmentation 8 years prior. This is her initial PET imaging where you can see extensive chest wall involvement and extensive nodal disease. So she was treated with brentuximab. She had progression of disease, very minimal response with different chemotherapy regimens. So surgery was requested, and of course we couldn't resect all of the chest wall disease, but it was felt that if we could remove the implants and the capsules, that perhaps that would help with her response to therapy. We also removed 8 lymph nodes that were completely replaced with metastatic disease. Unfortunately, she went on to receive multiple lines of systemic therapy and had continued progressive disease and ultimately died recently. And then the final case, a woman who had been treated for breast cancer in 2014 with breast-conserving surgery. She had invasive lobular carcinoma with extensive disease and positive margins, so eventually had mastectomy with implant-based reconstruction. A few years later, she noted left peri-implant effusion, which was positive for ALCL. On PET scan, she had some avidity around the breast implant. Ultrasound showed this dermal nodule in the upper aspect of the breast, and she also had a rash. So we did a capsulectomy and also removed the skin nodule. Unfortunately, the dermal mass turned out to be recurrent breast cancer. So this is a case where she had both ALCL and recurrent breast cancer, and that's why I think it's so important to understand all of the different components of the patient's history. So just in conclusion, I think this is a heterogeneous disease that can involve the implant capsule, but also surrounding soft tissue, lymph nodes, and distant sites. And evaluation for nodal involvement at diagnosis, I think, is very important, and targeting any avid nodes for resection can be helpful in eliminating the disease. But also evaluate for recurrent disease in those with a prior history of breast cancer, and also breast imaging to evaluate any concurrent breast disease is also important. Thank you very much for your attention.
Mark, question?
Congratulations, Dr. Hun, on putting that series together, which is really amazing to see all these cases where the guidelines totally fail us, that they just give us no help in these very challenging patients. You brought up one of the ideas that hasn't been talked about in any of the presentations, which is the use of brentuximab, and specifically you show an example of neoadjuvant brentuximab. When you're evaluating these patients, when do you decide to go to the OR versus when do you decide to send them to the oncologist to get neoadjuvant brentuximab, and then you take them to the OR?
Right, so that's a great question. I mean, I think the cases that I was trying to illustrate that would need neoadjuvant therapy are those where there appears to be chest wall involvement or more extensive soft tissue involvement, especially lymph node disease. And so I thought it was interesting to show the different cases, because the one patient who had such extensive chest wall involvement, obviously surgery would not be considered curative in that patient. But we felt like if we could remove the capsules and the implants and the capsules, that perhaps that would help her with her response to systemic therapy. The other, I guess because of my background in breast cancer management, we use neoadjuvant therapy quite frequently, and I think having some idea of response to therapy in those with more extensive disease is very helpful. So we saw the one case where the breast masses really shrunk and she did very well, in contradistinction to the other case where there was really minimal response to systemic therapy, and I think that predicted biologically she was going to have very aggressive disease.
So I have a question, if there are no others. So it seems from your case and also from our experience at the Italian Ministry of Health that the infiltration of the chest wall represents a poor prognostic factor. So we should be very, careful in evaluating the posterior part of the capsule, especially when it is attached to the ribs. So do you think that, I know that for a plastic surgeon it is not easy to detach this capsule from the ribs, but if the pathologist says that there is infiltration, so it is not a T1, it's just a T2, maybe T3, we should force the plastic surgeon to remove the old pieces of the capsule that is attached to the ribs, because we want to avoid that it infiltrates the chest wall, and then we have pleural effusions, and then the patient could die. So what could be, the risk? I mean, I'm just asking you, but also all the audience here.
The risk of the posterior capsule, pneumothorax. It's a big risk when the pocket is under the muscle.
Okay, but which is the best one?
I agree. But we can understand that we have to be extensive, sure, but we have to give information that pneumothorax could be a complication. So I agree. When I'm doing en bloc capsulectomy, and I'm always not afraid, but I have to be really careful for the posterior part. And it has to be extensive, I agree.
I think usually, unless, I showed some cases where extensive chest wall involvement, obviously we're not going to be able to remove all that disease. But in many cases, if you excise the periosteum over the ribs and take, the intercostal, a very thin layer of intercostal muscles in between, you can completely remove all the capsule. And there's been some cases where I have gotten into the pleura, but not into the lung. And so then typically, Dr. Clemens, who does the reconstruction, will place drains there, and usually it's a self-limiting pneumothorax because the drains are in place. So as long as there's no underlying lung injury, there won't be continued, air leak or something of that nature. So I think I learned that early on that, and also the case I illustrated where the patient had been treated several years before at another hospital, they essentially left the posterior wall, the capsule there, and that's why she continued to have the disease progressing. So when I do the resection, I try to remove all of the capsule, and in many cases that does require periosteum and muscle chest wall resection.
Thank you very much. So we are going to move on to the next presentation. And so what did it change after the banning of test-derived implants? Akram, please go ahead.
So I concentrate my lecture on breast reconstruction because probably Pat Malucci will do it on aesthetic surgery. Yes? So just a citation of Georges Clemenceau: "The truth of today may be the mistake of yesterday and could become, with the better knowledge, the mistake of tomorrow." I think it could be applied to our situation. So after the ban of microtexture implant in April 2019 by the ANSM, just you have to remember that the French market was 80% of anatomic implant and textured. You could imagine the great resistance for the change, so we decided in my institution not even use microtexture implant. You have to know that the microtexture market is decreased in France, and Munhoz is still okay to be used, but the market is very low and they are not distributed in France. So the question is almost done. It's okay. No more smooth implant, no more textural implant. So there was a great increase of autologous solution and a drop of breast reconstruction with the implant, 10%. So we have more and more autologous solution, DIP, PAP, FLAP, and even it's just because the people who were operated through breast implants, they didn't come anymore for a period of time. So we use more lipofilling, and that's it. But for the lipofilling, we use more and more, and we'll understand why. Just a remark, because we, in France, probably a patient with an implant, and we are trained to put more fat than implant for the volume, we go to 4 sessions minimum after secondary cases. We have to ask us if we could enhance the taken rate of fat grafting, because there is some institution who use SVF, PRP. I don't know if it's really work, and it could work because they publish it, and I hope that they published a real thing. But to be honest, I think we have to go on this direction, because if we could decrease the number of sessions of fat grafting, it will help everyone, the patient in an institution. Another interesting thing is the fat bunking, tissue cell technology. I had contact with them, and it could be interesting to use just to decrease the number of lipofilling. So again, texture implant to smooth. I used to be great user of Elegant 410. No shame for that. It used to be a perfect implant for me, but with a lot of complication. And so I moved to GC aesthetic and modify ergonomics and motivatrous fixation. And for the TE, tissue expander, I use Allergan Mentor and GC aesthetics, and now I'm using Flora expanders because they are one of the only smooth tissue expander on the market in France. So we still using below the muscle breast reconstruction, but we don't want to have breast animation. Could you make the video in the middle, please? So this is the reason why we go for pre-pack to retro-pack to pre-pack. You all understand that, and this is most of my decision to put it above the muscle. And I think it ruined the breast, the aspect of the breast, the shape, and the aspect of the outcome for the patient. So this is a pre-op above and post-op down and in the bottom. And you see with fat grafting and anatomic implant, and I was really happy with the situation before the ban. So we are still using this technique and using fat grafting. So just to give you my use of ADM, in 5 years I test all this kind of ADM. My preferred one, I'm Mercelis Pre-Pack and Surgimed PRS fenestrated, and I'm really happy with this too. Give you very nice results, even with round implant, with a good softness of the breast. And the most important thing in my practice was the increase on 23%. I did that, I studied that the last month. 23% in 2 years for fat grafting. So we can understand that through this example. It's a nice result, but you're going to see that the demarcation, the upper part, there is not a nice slope on the upper part. So we go through fat grafting for sure. And we have an increase of a number of sessions per patient. Sorry, move a lot. Here we're going to have the same problem. So I think it's we realize that we do more fat grafting session. But with smooth implant, I have less history of seroma. So no doubt now, if I have to consider if a seroma is related to breast, to the texture implant, no history of double capsule. Could you put the video on them, please? And for aesthetic, just to say on aesthetic cases, my only concern is elongation of the lower pole over the time. But for breast reconstruction, I didn't realize that. So this is the kind of example of double capsule I had in when I used texture implant. So this is the type of smooth anatomic implant. It's not flora, sorry, it's anatomical true fixation. It gives you a nice result with a nice slope, but the gel is very firm to me. Nothing, it's very firm because of the nature of the implant and the anatomic aspect to keep the shape of the implant. And the round implant ergonomics are way softer and nice to be touched by the patient and to have a nice breast to touch. So in an interesting case, she had a round implant and she switched to anatomic smooth with a nice results. It was a breast reconstruction with T-scar. So it's difficult to say if it's round or not round. So yes, it's round in this case. It could have been anatomic. Another story, yes, for sure it's round. And I don't think the result is so bad. I mean, we are stuck in a kind of reflex. If it's not anatomic, it's not beautiful. So I don't know what to do. I mean, I'm stuck with the situation, and the patient do not complain. Smooth tissue expander, the flora. What is really interesting, you can put your patient in an MRI with no problem because there is no metal, it's only a peak, it's a ceramic. You can do the irradiation simulation before the treatment, and it's an easy inflation. So, and for the moment, I had no rotation even with the tabs and the matrix because I use the matrix to have a good pocket. So I'm really happy with the system, and I used with the matrix. We go over that. So with quite good results, even in secondary cases. So in the last 2 years, 23% of fat grafting more, but I don't know yet if the patient are more satisfied with the anatomic or not. So we did a collection of the breast Q because we use the breast Q on a routine. And between the April 2017 and 2019, and between 2019 and July 2021, for the breast cord, there was no statistical differences between the two groups, before the banning and after the banning. It's difficult to say, it's a lot of patients altogether with implant, but really I didn't see any patient who will be not happy with a round implant and saying, oh no, I don't want an anatomic implant. And they are happier with breast palpation with the new generation type of implant. Just a few words for the future. The bio-implant is probably something we have to think about to avoid any kind of implant. And we work, well, they more than work. There is a 3D work with the cells, adipocytes, and ASC to do a breast. And there is French competitors for that, for bio-implant, lattice, mesolis, heel shape, and more in Europe. And what is interesting, just to show some results of lattice, between day 20 and day 80, there is a multiplication of 5 times of fat with their material. It's quite encouraging. They are not ready to be on human soon, but I think it's something we have to follow. So by the end, there was fear and acceptation, and no, I'm satisfied. Our patient notices change, I don't know, and probably not. Do we push sometimes too much to imitate the anatomic results? I think so, to me. Patients are happier with breast softness and suppleness with a new generation of implant, and I hope this new implant, bio-implant, will be ready in 5 or 10 years. Thank you very much.
Any questions from the audience? Okay, no. So I might have some questions. I'm not a plastic surgeon, as you know, but I'm interested in 2 aspects. You say that fat could be used instead of implants, and do you think that can be used in all the patients, or there are patients in which you do not recommend to use fat? And the second question is, you talk about fat banking, because if you have a very skinny person, maybe you cannot use her own fat, but in that case, we have to test for compatibility because we may have rejection.
So, no misunderstanding. The fat banking is to use the fat in one session of a lipoaspiration.
Okay.
And
so
then not to have to repeat the procedure of lipoaspiration and to do only the injection.
Okay.
It will decrease the time.
Okay.
And it will be better for pain for the patient because lipoaspiration is painful and whatever. So that's the point. And there is very few situations we won't do fat grafting for medical reasons, really. So if it's there is a doubt in the diagnostic, or we won't do it. But for sure, there is very few situations to make fat grafting impossible.
Okay.
Any question?
Yes, there's Mark.
Thank you so much for putting that together. Very much with regulation around ALCL, France would be many times the very first one to take action, and everybody else follow. So therefore, my question is kind of maybe what's next? Do you see anything on the horizon? Do you see any other actions from French authorities? And I think that one of the things that patients bring up is there any chance of there ever being an ask for an explantation, which French authorities did with PIP, but that nobody else followed. So we look to France very cautiously to see is anything on the horizon.
So you are lucky in this meeting. You're going to have Mrs. Duvignac, you could ask her, but prophylactic explantation could not be, to me, even related to the risk. I think it's not something I could say it could be reasonable to do. And what kind of explantation? Explantation only or en bloc? And you know, en bloc is not an easy thing to do, and probably with a longer scar and the risk under the muscle of pneumothorax and other risk. Thank you very much.
Okay, thanks.
Hello. One short comment only. the reason why they, correct me if I'm wrong, but the reason why they suggested to remove the PAP implant was not because of cancerogenic risk, but because they break. So it made a completely different scenario, because you just remove the implant and change it. You don't need to remove the capsule.
Last comment. 25% of 25% of PIP implant were supposed to be with a bad gel. It's nothing related in terms of statistics. So this is the reason why PIP, and all the patients were explanted freely and no charge for the patient. Sometimes it's good to be communist.
Okay, so let's move to Malucci's talk. So it's your turn to talk about the use of anatomical texture implant.
Okay, thank you very much once again. So I'm going to give a slightly different perspective, as you might imagine. These are my disclosures. Anatomical implants, has anything changed? Does losing anatomical implants matter? Michael, I'm going to say yes, it does. Does everyone need an anatomical implant? Of course they don't. And I use plenty of round implants. When the anatomy is good, these are all cases where you can get very nice results with round implants, and arguably in none of these do you need an anatomical implant. But the problem is that what do you do when these people walk into your office? Or somebody like this? What about when these two walk into your office? Or this one? Or this lady? Or this asymmetry? Or this poor soft tissue condition? Or these hanging pseudototic breasts? Or these complex secondary cases? I don't think you can treat those with round smooth implants. And the reality is that this is the scenario that we're mostly faced with, that the easy cases fall right to the left of that curve. And Michael, you're lucky that you don't have a choice.
Yeah.
But when you have a choice, you have a choice. The vast majority sit in the middle there. They're not simple, they're complex, or they can be very complex. So one implant cannot treat all of these conditions. It's not possible. So you need to be able to understand when and where to use an implant for those conditions. And there are things that anatomical implants can do that round ones cannot, and that's a fact. And this is why. Okay, it's all about volume distribution and the projection point varying on these two. And these are the fundamental basics of the difference between a round and an anatomical implant. The low projection point and the volume distribution means that you can change the shape of the breast, the orientation, in a way that you cannot with a round implant. This is what happens when you've got a high projection point, you push the nipple down. So that's volume, but it's not useful volume. Don't forget also about anatomical implants. These are three-dimensional. You can vary height, width, and projection. You cannot do that with a round implant, and this can be a very valuable tool and easily forgotten. So these are properties which are peculiar. So what do they give you? They give you volume distribution, versatility, form stability, arguably capsular contracture, positional stability, lower reoperation rates. And arguably, if you want to go down the aesthetic model, we're not going to argue about that too much, but 86% of our population study indicated a preference for the proportions that I've talked about many times over. So let's look at a few cases. Even sometimes the shape. I mean, this lady, she could do a round implant. It's a round-shaped breast. This one isn't. So why not use a short-height implant, which matches the morphology of her anatomy, and you can get a very natural result. What about somebody like this, with an amastia and a completely fallen away lower pole? Again, you can use your anatomical shape to completely obliterate that loss of tissue, create a very natural shape. It's quite common as well to get these slightly minor chest wall deformities, this prominent pectoralis. And again, you can completely annihilate that by choosing an anatomical implant, which will blend away the contours. You can use your visual imagination to be able to select that. Really poor soft tissue. Doctor, I want to be as natural as I possibly can. Very, very difficult in these conditions to produce a natural result. Asymmetry, ptosis, again, wants a natural look. Doctor, I want as natural a profile as I possibly can. You can't do this with a round implant in the same way that you can do with an anatomical.
And the classic constricted lower pole, the need to expand it with form stability and volume distribution. Complex asymmetries. This lady is asymmetric in every dimension: projection, width, height, fold position. And again, you can use your matrix to make up for these deficiencies in every dimension. Different heights, different projection, different volume. You can play around whichever way you like. Difficult anatomy. This is where it gets harder and harder. Again, you've got to be more selective. Shorten the height of your implant. Increase the projection. Try and play to the anatomy. Here you're completely reliant on a form-stable shaped implant to recreate a breast. This lady here wanted to avoid mastopexy. Again, you use a low height implant, you keep the projection point below the nipple, you can avoid a mastopexy. Round implant, the projection point's too high, the nipple drops. You can't do that. This lady came for a second opinion. Don't like my breast. My doctor wants to do a periareolar lift on me. Why don't we just redistribute the volume, take away from the top and add to the bottom, just as we can see in this case here. It's going from round to anatomical, and if you look at the difference that that makes in terms of volume distribution, taken from the top to the bottom, you can create very radical change. And again, you're just playing with shape here. Doctor, I want a slightly fuller, cuter breast. Let's change shape from round to anatomical, expand the lower pole, get the nipple pointing upwards, and you have a more charming breast. A complex secondary case. Doctor, I hate my breasts. Complete volume maldistribution, if you think of that 45-55. Let's just change the shape. Let's take advantage of that volume distribution, revise it, and produce something much more attractive. And even in very subtle cases like this, lady with round implants, very easy to say, oh yeah, that looks natural enough. But actually, when you compare it with the anatomical implant, and in particular, don't look at the upper pole, but you look at the lower pole and the way it gets lifted away from the chest wall through expansion through that volume distribution. And again, similar case here. I don't like my round-looking implants. I want something more natural. Change it to an anatomical, lower the projection point, elevate the nipple, and you see the same story repeat itself. And again, I think this final case, very unhappy with her volume distribution or maldistribution, nipples pointing downwards. All you've got to do is change the shape of the implant to solve that situation. And again, very powerful manipulation in terms of shape, going simply from round to anatomical. Either the pseudototic breasts, where you're trying to inflate the lower pole, and again, you're taking advantage of that volume distribution in order to be able to do that. Here we go with an anatomical implant. Again, it fits into place, low projection point. With a round implant, you can't do that because your projection point is too high. And then you've got these complex secondary cases. She has round implants. She's skinny as a rake. She hates her look. And this is my plan. These are my scribbles. I'm going to use a lightweight implant. It's going to be anatomical in shape. And use a little bit of fat to try and blend it. She goes from here to here. You've got a very depressed and unhappy patient and a very happy patient. So is there still a role for anatomical implants? Yes, there is a role for anatomical implants. And there are many problems that cannot be solved with a round, smooth implant. So we come down to then, what's the risk? You know, why can't we? And I don't want to spend too much time on this because we've talked about it a lot, and we've talked about, you know, 1 in 3,000 to 1 in 30,000. And as we know, there are many inconsistencies rather, even with the texture story. You know, where 3 and 4 are more associated with ALCL than groups 1 and 2. But as I said, even within this group, it doesn't make total sense, because if you remove Silamed and BIA-ALCL, then actually group 4 and group 1 have got very similar rates. So we've heard of lots of different associations today with ALCL, and maybe we should be focusing them, because as I said, once you take those 2 lines out, then regardless of the group, these look very similar in terms of contribution to ALCL. The other peculiarity, of course, and this is a great example, is that Saban went to copy BIA-ALCL. They wanted to create an exact identical copy, salt loss technique, and when you look at them under the electron microscope, you can hardly see any difference between the 2 of them, and yet Saban have no primary cases, and of course, Allergan we know all about. So, you know, a lot of inconsistencies. As I said earlier, 85%, well, 90% are BIA-ALCL. It's gone forever. So, if you do that calculation, then maybe the risk we should be talking about are much more like this going forward than the traditional risk. Maybe ALCL is rare again. Maybe we should be changing the language, as I said. And the reality is that although Peter and others report what they report in terms of their personal case history, the truth is that the average plastic surgeon will never see a case of ALCL in their working life, not even high volume users, if you believe these new probabilities and risk factors. We know this story here. We also know the downfalls of smooth round implants, the reoperation rates associated with those, the lack of stability. We've talked about risk of that as well, and that all needs to be factored in. So is banning texture justified? Are we losing perspective? This is a paper by Dave Seaver and Bill Adams, the micromort study, which compares risk of ALCL with mundane early activities. And it's a cold shower in terms of perspective of risk. And it's very easy in a meeting like this to lose proportionality and perspective. Is this victory of media over science, over pressure? Because I believe it's wrong to take the choice away from women, when the reality is that ALCL is rare, especially without BIA-ALCL. And just sort of final example, skinny lady, there's no possibility of fat, she's unhappy with the wrinkling. Just by changing implant selection, shape, form stability, you can solve her problem immediately. And finally, my comparison is this. This is how I get to work every day on a motorbike. And I know that the mortality of this is greater than driving. But I also know what the advantages are. And I can weigh up those advantages and those risks. And it's no different for women. I believe that you should have an open conversation with them, explain the risks and the benefits, and that it should be their choice. Thank you very much.
Thank you very much. You don't want questions?
Please.
So it's a very bold presentation to say that here, and congratulate you. Yes, we are lucky in France not to have the choice because we don't have to take any responsibility. And I agree, and I concede that. The thing is, you are telling, and you show us a ghost curve just to show that only a very few patients will need, in your opinion, anatomic implant. But anatomic implant it's not a question of ALCL anatomic, it's more the texturation, because texturation is anatomic, yes, but could be in round too. So if you have an anatomic which would be smooth, do we go there or not?
Yeah, I mean, this was a question about anatomical implants. So, as I said, I'm in favor of anatomical implants. So whether they're smooth or textured, the question is, is there a smooth implant that is reliable enough on the market in terms of its fixation? And I think that not everybody would agree that the true fixation is the solution. Whether its shape and the way it's manufactured, it's the only one at the moment. But as I said, I'm really making the case for anatomical versus round. I don't have a problem with a smooth anatomical.
It's just a question of what texturation could help you for these difficult cases of inferior lower pole retraction. You understand my point?
Sorry, no.
For the inferior pole, sorry, I don't have any case of tuberous breast, for example.
Yep.
What texturation could help you for?
But it's not the texturization.
I know. This is my point.
It's the volume distribution that helps.
Yes, I know. This is my point.
And the form stability.
I totally agree.
But it's not right to say that an ergonomics implant can do the job of a form stable anatomical implant. That's not right.
It's not right. It may, in other hands, it could be possible. Not in my hand, but it could be possible in other hand. And you may have a tool for that, and probably other company will do. And the only thing is, for Sabine, I think there is 1 or 2 cases quite recently, but it's not a question. You are right.
Not of the macro texture.
Are you sure?
I'm 100% sure.
Okay, we're going to check it. But it's not the problem. You're totally right. You show my publication with the shape of. It's not only the shape which is important when you compare BIA-ALCL and Sabine. It's almost the same. I totally agree.
Yeah.
But there is other factors. So it's not enough to compare. Just it was my point. Sabine could be nice, but.
Yeah.
I think there's
only one question. I apologize. I take the microphone, even if we are a little bit late. So I agree partly with you. I like very much your approach. But we have to consider 2.1 was touched by Michael. This is probably an ethical problem that is moved from authorities to us. It's not our duty to decide if it is ethical to achieve better results and run a carcinogenetic risk, which don't know exactly at the moment how much it is. And I would change your rates because it's much higher than what you explained. But I don't think it's up to me or you to take that decision, or the patient. Someone else has to tell us. We have to or we don't have to. So I think this is the main problem. And if I can disagree on something, is most of the plastic surgeons will never experience to have a BIA-ALCL cases in their life. That's not true. We have in that room plastic surgeons experience more than one case. Are they, my question is, are they unlucky? Are they a bad plastic surgeon? They are dirty? How is possible that we have private practice, Dr. Kolasinski, 4 cases, Peter Cordeiro somewhere? What are we? I got 4 cases myself.
But they are not the rule. They're the exception. Then they are the exception. The vast majority of us will never ever see a case.
Thank you very much for this position, strong position.
I think Mark.
Mark, because we are a bit late. Go ahead.
One last question. You co-authored a manuscript a few years ago on 46,000 implants, in imparting with a better technique that the risk of ALCL can be lowered. I take that as trying to suggest to physicians best practice techniques and to encourage better placement of implants. What could possibly be wrong with that? However, after the fact, manufacturers have definitely utilized that manuscript extensively. It was quoted by 2 separate manufacturers at the FDA hearings. It's actually been a key component of most of the litigation that's been brought forwards, usually by the manufacturers. Any thoughts from you, the original intentions of the manuscript versus the reality that we're seeing today?
I think the original intentions are exactly what you said. It's best practice, and there's nothing bad with good practice. I think to come to too many more conclusions beyond that is difficult, particularly when it comes to ALCL. I think it's difficult. It's association. It's certainly not proof of. But it's the intention is good practice.
Okay, thank you.
Thank you. We're going to move to the lecture. The lecture of Denise Hammond. It's recorded, and then Denise will be available online to answer your question.
Greetings. My name is Dennis Hammond, and I'd like to take this opportunity to share with you some thoughts about round, smooth implants. Can they actually replace anatomic implants? These are my disclosures, and you'll see several different implants from the Mentor Corporation as well as establishment labs. Now, my practice at one time consisted fully of 50% anatomic implants. They were of a cohesive gel and of a texture which was Siltex from the Mentor Corporation. The other 50% was really round, smooth devices. So we've had a large experience with both types of devices. And I must say right from the outset, I am an anatomic implant fan. I was able to generate beautiful results, as you can see here in this 6-year result of an anatomic implant in a particular patient like this. The best example I can see in addressing the argument between round and anatomic implants is demonstrated by this patient. What I did here is I put in a 330 cc anatomic implant here on the left breast and I put a round implant in on the right. And when you look at the side view, you can see here that the round implant gives just a little bit more upper pole fullness than the anatomic implant. So the best way that I heard this talked about, it's just a matter of taste about which type of implant you like. And here's where we put the same anatomic implant in from the front on both sides here, and this slide here on the right. Now, the anatomic implants, I think, do offer an advantage, and in that they give better volume distribution and they provide an aesthetic shape. They expand the lower pole, which can be an advantage. And I think they are less prone to rupture because they don't wrinkle quite as much. However, certainly problems have been identified. They are more firm because they typically are a more cohesive gel. Rotation is probably a bigger problem than what we've been able to see so far in the literature. Certainly I've seen it in my practice. And there are instances of capsular contracture. These implants can rupture. And now the whole specter of ALCL associated with the textures that are on these devices has really limited the availability of these implants now for use. So as a result, there's been more attention directed now towards round implants. Now, round implants do have advantages. They're of a softer gel. They don't shed particles so that they're smooth, and there's never actually been a case of an ALCL associated with a round implant up to this point. Newer versions of the round implant are more completely filled, which makes them wrinkle resistant. And the two that I've used up to this point have been the Mentor Smooth Round Gel Extra, which is filled with a little extra gel, and then the Ergonomic Silk, which is essentially a smooth implant from Motiva. So as far as a Mentor device is concerned, this is a newer modification in that the old silicone gel implants are filled to a greater degree. They're soft, they give a little bit more projection and comparatively less base diameter, but as a result, they offer less wrinkling. And here's just an example. Same volume. Here you can see a little more properly filled, so you get a little bit more projection and a little bit less base diameter. But these have worked very well. Here's a case of primary breast augmentation with a Smooth Round Gel Extra. Here's our marks, and here she is at the time of surgery with a 370 cc implant. Final postoperative result at 6 months shows really a very aesthetic result. And then from the side view, which is really the view that shows the difference between round and anatomic implants, you can see this implant has settled to the bottom of the pocket and created a very nice upper pole. So this concept that round implants can't provide the type of result that you're looking for really is overplayed a bit. Round implants can work actually quite nicely. Here's an example of an implant exchange. This is a patient that had a capsular contracture around old saline implants, as you can see here. And we were able to get her at 3 years to a very nice result using a 300 cc high profile smooth round gel implant in the partial subpectoral space. And from the side view, you can see very nice control of that upper pole, very much akin to what you would see with an anatomic implant. Well, she came back and was asking actually to go bigger. So we worked with her, decided to go up to a 450 cc device. So we bumped her up from 300 to 450. And here's her result early on. But you might think that bumping up that volume would end up creating deformity here in the upper pole, but actually we've been able to maintain that same degree of control in the upper pole with a round smooth implant. And comparing to her original shape, really a very nice result. And then really interesting cases here. This is a lady that's going to have an anatomically shaped implant. Here was her result with the implant in place. And at 7 months, a pretty reasonable result. Good control of the upper pole, given the deformities that she has in her chest wall. Well, sadly, at 22 months, she showed up with breast distortion and basically a rotated anatomic implant. You can see the difference in the shape in the breast over time. So the idea here was to replace this now with a round gel implant. So the anatomic implant was supposedly giving us an advantage on shape is replaced with the round implant. Now on the right side, you can see the orientation stripe here. This implant was properly oriented, but on the opposite side here, you can see the orientation stripe. This implant was rotated such that the bottom of the implant was actually up in the upper inner quadrant of the breast. This is the axis of the implant right here. So we took this out, we replaced it now with the round smooth implant, and here was her result 2 years later. So we've been able to really provide the same amount of upper pole control that we could with the anatomic implant using the round implant. And over the long term, this is her 4-year result, giving her, again, a very reasonable result after her breast augmentation. And then for revisions, here's another case of reconstruction where we've got our anatomic implant in place. Now, this has been complicated by the development of capsular contracture, which certainly affects the shape. But we're going to go back now, and to simplify things, we're going to suture the muscle down and replace this with a round, smooth silicone gel implant. And you can see that if you get the scar out of the way and allow the implant to drop down to the bottom of the pocket, you can achieve a very nice result with a round, smooth implant. And looking at her pre and post-op, like this. And then lastly, for reconstruction, here's an example of what we use as our pre-mastectomy mastopexy. So here will be our preoperative breast reduction for this particular patient. We waited 3 months to let everything heal. That gets that nipple up and reduces the skin envelope. Now we come back through the vertical incision to our mastectomy here with our tissue expander in the pre-pec space. We blow that expander up. So now that we come back, we'll do a slight scar revision. We're going to take that expander out, replace it with a smooth round gel extra implant, and add fat grafting. So here she is with 180 cc's of fat on this side and 220 on this side. And here's her final result at 6 months. So with a smooth round gel implant and really the most challenging environment, we're able to achieve a very nice result, almost anatomically shaped breast with a round implant, which is actually very soft. So the early results with the extra are certainly encouraging. We get better projection with less base diameter. It really shines, I think, in the augmentation patients. Higher volumes for reconstruction get a little bit wide in the base diameter. But most importantly, with that smooth surface, never been a case of ALCL documented with a smooth walled implant. And then moving the same kind of analogy with the Motiva silk implants. These are soft implants. Again, they're filled. They have that shape holding volume, and they have what's called a nano texture. So these devices here are very nicely shaped. So when we go ahead and we take these devices and we pull on them, you can see here that have a responsive gel like this, which allows that implant to settle to the bottom of the pocket very nicely and holds its shape. So what you can do is you can settle that, let that set. You can see it almost has an anatomic shape associated with it. Now, the thing about these devices as well is it's not exactly smooth. It's got this nano texture associated with it, such that according to the grading system, silk surface and smooth are graded in the same category as a smooth walled implant. And what these do is they react very favorably with the capsule to create a very soft, elastic capsule, which has been associated with a very low rate of capsular contracture in the studies that have done thus far. So again, looking at how this interacts now with the soft tissue, it's very similar to the smooth walled implant. There's a case of an AUG after a year, and the telling view on the lateral view here is very nice control of that upper pole as that implant drops down to the bottom of the pocket. Another example, breast augmentation in a bit of a challenging patient, very thin on lateral view, very nice control of that upper pole, very similar to what I'm seeing with my anatomic implants. Implant exchange as well, similar kinds of observations. Here's a patient that presents for her breast augmentation. We did put in a 355, nice control of the upper pole. She came back wanting to be bigger. So we bumped her from 355 up to 500. Again, there's that capsule associated with that silk surface, that nano textured device from the Motiva implants. And here you can see what she had in and what we bumped her up to. And here she is now with a 550 cc implant in place, 2 years post-op, but still, despite that increase in volume, a nice control of the shape of the upper pole. A telling case here would be anatomic replacement. This is a lady that has an anatomic style 410 implant in place. We're going to go back, take the capsule out, touch up the skin envelope, and here she is with replacement with a round silk surface Motiva implant with, again, good control of the upper pole. This is a lady that has an anatomically shaped implant in place, really struggling a bit with some of her shape issues. And again, when we went in, the anatomic implants were rotated. So there's the axis with the 6 o'clock position in the upper outer quadrant of the breast. We replaced this here, the CPG implant, with a round ergonomic implant, silk surface, and we're able to utilize these kinds of forces to create this sort of a result. So here she was now with a round implant replacing the anatomic implant, and you'd be hard pressed to tell the difference between the two. So the question is, can round implants be used to replace anatomic implants? In this particular case, absolutely. Here's a revision, complicated, of course, by the development of capsular contracture, an old polyurethane implant. The idea is to go in and get the scar out, replace that implant with a silk surface anatomic of some volume, 450 and 500. Here she was 6 months later. And this just demonstrates the effect of getting the scar out can go a long way towards allowing that implant to settle to the bottom of the pocket and create the shape that you're looking for. And then finally, in reconstruction, here's an example of a patient that's going to present for our breast reconstruction. We're going to use an inframammary fold incision to accomplish our prepectoral placement of our expander. We insert that expander, bring her back, take it out, fat graft, put in our anatomic implant, our Motiva silk surface round implant with 150 cc's of fat. And here's her result at 3 years. Just a very nice, soft breast. And then just a little video clip to demonstrate really the quality of her result. And this is with a round implant. So we don't have to worry about the firmness of the device. We don't have to worry about rotation. So combining this round implant with fat grafting creates now with this implant a wrinkle resistant device, which has got a low rupture rate. It's very shape friendly. No particle shedding, means no issues related to ALCL, and a very soft feel. So at the end of the day, I think round implants are a really nice substitute for anatomically shaped devices. They're soft, they don't shed particles, they're wrinkle resistant and more completely filled. So this is how we're using round anatomic implants in our particular practice. I hope this was helpful. Thank you very much for the opportunity to present.
Thank you. Hello, Denise. It's Michael Atlan, and all the audience is ready for question. Do you have any question from the audience? Just a question. So you made a switch to CPG to round implant for all your cases, or do you have still cases with CPG anatomic implant?
I've completely transformed my practice all the way to round implants. Just because of the results I tried to show you in this talk, they really work quite well. And I don't have to begin to worry even a bit about the ALCL issue because of the smooth surface.
But Siltex was not so much involved in ALCL, but it's more a question of outcomes for you.
Yeah, you're correct. Siltex is not really associated with ALCL, but there are some cases. And so I took a pretty hard line on that. I just made the very firm decision. I don't want to even take even a minuscule risk for that sort of thing happening. And so that's why I've decided to move to the smooth world.
There's a question from the audience.
Peter Cordeiro.
I would totally agree with Dennis. I think in concept, I totally stopped using any textured implants about 2-3 years ago, when the numbers I thought had become too high. And you can debate different brands, et cetera, but the one outstanding fact in my mind is that there has not been a single case worldwide over 40 years with a smooth implant. So to me, we are obligated to our patients to use what we think is safe, and the only thing that I know is safe is a smooth implant. Dennis's results are excellent. I was shocked because I used 95% shape textured implants, mostly reconstruction. And my results with the round implants are just about as good. And at some point, I'm putting together my experience. I've replaced about 500-600 shape textured implants with round smooth implants. And shocking to me is that my results are still just as good. And even more shocking is that the patients are happier. More than half of them are happier with the round implant. I wouldn't have predicted that. So I personally don't see why you would take the risk. And you can make the argument for a few very exclusive cases where a textured implant might help, but I think round implants work just as well. You know, and Patrick's cases were beautiful cases, but I think many of us in the audience could have gotten the similar results with round, smooth implants. And Dennis, you're using the CPGs. I use Allergan makes a smooth cohesive gel implant, the SCF, SCM, with multiple dimensions in terms of projection, diameter, etc. And it works very well and really holds up for reconstruction, the very thin patients with rippling, etc. It works quite well. So you can play around with the numbers and talk about, one implant is less likely to have, this consequence, but I still think the outstanding fact is that the only thing that we know is safe or smooth.
Okay.
Can I just comment to follow up on that? I agree. Yeah, I'm kind of surprised myself. Work as well as they do. If there was a significant drop-off in my aesthetic results, moving from a anatomically oriented concept to a round-oriented concept, I might rethink about things like risk and really what is the risk with an anatomic implant. But in my hands, there really has not been a big drop-off in aesthetic results. And as you said, many respects, they work just as good with much less worry. I saw Patrick's talk, and obviously he gets wonderful results with these devices, particularly in those challenging people. But you're right. It's like I said in the talk, it becomes a matter of taste. How much extra work and worry are you willing to accept to get that little extra bit of result that you can get in some patients with anatomic devices? And everybody can make their own choice.
Question, yes.
Zlatko Zagreb, Croatia. Congratulations on your results. Just one short question. Bottoming out. What do you think about that? Follow up and bottoming out. What do you expect in 3, 4, 5 years?
Yeah, so this is where I really have an advantage here in the United States over my colleagues in Europe, because I think has been stated, you're a textured world over there. There's many, many surgeons that never even put a smooth-walled implant in anybody. We've been using them here in the United States for many years. And so we're quite adept at techniques to preserve the inframammary fold during dissection, manage the width of the pocket during the dissection. Many techniques have now been described for suturing down of the fold to control it. And so we're accustomed to working with some of the challenges of smooth-walled implants as far as management of the pocket and implant malposition is concerned. So in the European world, I would say that as you move more towards round implants that are smooth, you're going to have to pay closer attention to how the pocket's developed, and then things such as suturing down the fold or being careful which kinds of patients you use these devices in. For instance, patients that require the fold to be dropped during the course of their planning are really at risk for the development of bottoming out. And in particular, those patients require some sort of maneuver to hold that fold in place. But with experience, you become accustomed to these challenges and you can certainly use them safely.
Pat here. Thank you for your talk. Look, I'm here as the token rebel, so I'm not going to agree with Peter entirely. And you showed some nice cases, but there's a big difference between an already expanded secondary augmentation where there's capsular contracture, and yes, there's a lot of room for give. I think a lot of those primary cases are much more difficult cases. But I think you said it right at the end. The whole question about aesthetic outcome and risk, it's a choice. And I have a very open conversation with my patients, and I say, look, depends what you're choosing. If you're scared, you want a round smooth, we'll do a round smooth, but you're not quite going to get
the result that you'll get from an anatomical. The choice is yours, and I think that's the point. It is all about choice. It's about explanation of risk and choice.
Okay.
Patrick is a good friend. I'm very familiar with his results. He's a marvelous surgeon. I've told him before, I've marveled that his practice has some of the most detailed, exacting patients you could ever want to have. I think he has to go home and have a drink every night after a clinic day. But you're right, it's a matter of choice. And here in the United States, maybe we've got a little bit more of a different litigious environment. But if I was to put a BIA-ALCL implant in somebody today here in the United States and they got ALCL, I would not have a leg to stand on. So some of this is self-preservation as well, but it is a choice, that's for sure. And hopefully we're going to sort this out. And you know what the best circumstance would be? To have an anatomic implant that does not have to live in the ALCL world. Now that'll be a great day when that happens.
Thank you so much. Thank you. Bye, Dennis. So Mark will give us a lecture on management of existing texture implant patients.
So a patient comes into your clinic, completely asymptomatic, no problems, and before you can even introduce yourself, she says, "Help me, doctor. I have a ticking time bomb inside of me." That's the focus of this lecture. My disclosures is that MD Anderson does participate in clinical trials with Mentor as well as establishment labs. I did discontinue being a consultant for Allergan 7 years ago. I would be remiss if I did not acknowledge Dr. Gary Brody did pass away this past spring. He is truly a pioneer of breast implant ALCL, and upon his shoulders, I think all of us stand, and really advanced. He was the very first one to notice a relationship with texturing. He was the one that brought our attention to BioCell, and at a time where he was the only one that was saying it. So we do greatly appreciate his legacy. We're going to cover definitions, risk counseling, surveillance, and explantation. And this slide is completely for Dr. Malucci. So all four of these implants are implants, but we're going to use very specific words throughout this entire talk. For instance, I'll refer to these as implants, but I'll refer to these as the textured implants, and they all have a causal relationship to BIA-ALCL. I'll refer to these as the macro-textured implants, polyurethane and BioCell, as having the highest risk of BIA-ALCL, and I'll refer to these, the BioCell, as being recalled worldwide, and when device was known, being responsible for 91% of known BIA-ALCL cases. And we have to be very careful in our word choice. I'll refer to each one of these four groups, depending on what I'm talking about. There's different classification out there breaking down all of the different types of implants, but most of them fall into what are the ISO classifications of smooth, micro-textured, and macro-textured, with the vast majority of cases being in the bottom row. This paper that we just collaborated with MIT, Rice University, Johns Hopkins, showed that textured implants, again those three groups, were different in how the immune system responded to implants in comparison to the smooth implants. We classify as ISO smooth less than 10 micrometers. So those three are just different in the way that the immune system relates to them. Higher levels immunosuppressive, FOXP3, regulatory T cells. The body just reacts differently to textured implants as a whole. And we also know that there's none, not any smooth implant cases of ALCL to date, and said at this meeting 12 months ago by the FDA, we have received a report of a smooth implant in ALCL that has no history of textured implants. We are asked by many if this is a pure smooth case. No, we cannot confirm this as a pure smooth case. We cannot verify it at this time. That's critically important because most people will say that the FDA is the source of the smooth implant ALCL. They contradict this themselves. They say that no, not worldwide, we've never seen a smooth implant case. So how do I counsel my patients? Well, BIA-ALCL we've seen we have very good data on, and I can say BIA-ALCL has a risk of somewhere between 1 in 350 to 1 in 2200 based on prospective series. Beyond that, it's really a shot in the dark. I can't quote you what macrotextured is. I can't quote you what textured is. We're using numbers like 1 in 50,000, 1 in 80,000, but that doesn't feel very satisfactory, and we have very poor data supporting those numbers. And smooth, well, I can comfortably say that that's the same risk as the general population. Notice some big gaps there. So you need to be very careful in how you actually explain this to patients. Also, part of risk counseling is I like to let patients know how many cases to date. And every year we've given this slide, and this is updated as of today. We are aware of 1,148 total world cases and 35 deaths. And what I can tell you is some big shifts over the past year represented mostly in Europe. The most number of cases have developed in Europe, really catching up to the numbers that we see in Australia and in the United States. In the flip side, Australia and the United States have stagnated. In fact, we've had the lowest reporting that we've had in a decade in those two places. Has COVID slowed down reporting? Have we caught up in the number of cases that are out there? I don't know. We've also seen an ascension of Asian countries now reporting much more cases than they ever did before. In counseling, I think that it's important not only to show a higher risk with textured implants and BRCA, but also breast cancer recurrence. Notice I'm using the word textured implants, not BIA-ALCL, not macrotextured. Textured implants have higher breast cancer recurrence rates. So what did that do at our own practice at MD Anderson? Well, I can tell you the #1 implant that I placed from 2012 to 2017 was an Allergan 410 implant. This represents nearly 10,000 implants placed by the 26 faculty members at MD Anderson. And what we can see is when FDA approval of the 410 and the CPG, we start using more textured, then we start to lose favor, and we finally completely abandon it in 2019. Also important for risk counseling is the SHEAR report that just came out for the very first time, saying that there was a moderate weight of evidence for a causal relationship between textured breast implants and ALCL. Some have translated this to say moderate must mean none. Actually using that word, moderate must mean none. I would actually say moderate meaning strong. So to hit the high bar, what is high level of evidence, means a meta-analysis of prospectively randomized controlled trials. Many prospectively randomized controlled trials is what we would need for a high level of evidence. And that would actually have to be on BIA-ALCL. It's never going to happen. In fact, there's very few absolutes in this study, but I can tell you we will never achieve a higher level than what we have just recognized, which is a moderate weight of evidence for a causal relationship. And for the very first time, we're using the word causative. Very first time, 2021. We've never said that before. For more information on this, I would turn your attention to this further reading, breaking down by risk estimates, Europe, world, as well as how to advise patients. And strategically, all of these are open access, free to download. We actually authored the advising patients with our patient advocates, Terry McGregor and Raylene Holra, who spoke at previous meetings, and we really appreciate them helping us with that. Surveillance, we've already talked about that we usually recommend all implants, not just textured, all implants, an ultrasound or an MRI after 5 years, and then checking them every 2 to 3 years with an ultrasound. I've already quoted our paper showing very poor adherence rates to that, but that was with MRI. We think that extending it to 5 years and allowing ultrasound will actually allow for better follow-up of patients. What does that mean? In our own practice at MD Anderson, we're seeing a higher rate of explantations that we've ever seen before, really taking off in 2019, and really driven by the gray bar, which is the fear of breast implant ALCL. However, I try to talk my patients out of this. As we've shown before, a subtotal capsulectomy can still develop breast implant ALCL years later. Even a total capsulectomy can still develop ALCL years later. There is no known risk reduction. And all implants, including textured implants, do really require lifelong surveillance, and we cannot screen disease in the absence of symptoms. Some of the lessons that we've learned from the ASPS Breast Implant Surgeon-to-Surgeon Expert Network. In the United States, we have this where any surgeon can speak with a BIA-ALCL specialist, and I wanted to show you some of the lessons that we've learned from this network. And this is probably the most important slide that I'll show today, which is what are the most common missteps that most surgeons make when approaching breast implant ALCL. They proceed to surgery without doing any imaging or workup. They don't involve lymphoma oncology at any step. They leave behind the posterior capsule because it's just hard to get out. They do incomplete or partial mass resection. They'll spill the tumor or the effusion. That's not theoretically leading to disease. There's actually a disease in the UK where spill actually led to a recurrence in a drain tube. Leaving behind lymphadenopathy, again, because it's difficult for a plastic surgeon, and not giving patients the option for immediate reconstruction. Now, the FDA says that they keep this in our hands and they allow us as plastic surgeons to treat them, but not in these suboptimal situations. This suboptimal really questions whether our guidelines are enough and whether we need to do more to actually get people to adhere to it. And the picture that I show is a patient that unfortunately had many of these missteps happened, and unfortunately was our first death as of April of this year. We've already shown NCCN guidelines. I won't go into detail, but I will say that they don't speak to what to do with textured implant patients that don't have disease. Dr. Miranda showed that 12 biopsies per capsule was critically important to pick up disease. I would argue that if it had a textured implant patient and they were going to the operating for an implant exchange, and the reason why they were was that they were worried about ALCL, I do try to talk them out of that procedure, but I do think if you're taking them to the operating room, it behooves you to actually do multiple biopsies, because even in an ALCL case, you can miss the disease with one biopsy of that capsule. So a textured implant patient, and you're trying to screen them, you really need to do about 12 biopsies. We also see that the disease can progress if left untreated. That was a big paradigm shift that we proved this past year with Dr. Miranda. And so if you'd like further information on this, I would turn your attention to these two manuscripts that just came out on the management of symptomatic patients with textured implants. And I'm going to conclude with the idea that, number one, let's be reassuring. Breast implants are safe, at least the ones that are available today. However, they do have known complications, and they are not lifetime devices. BIA-ALCL is emerging, and the risk appears to be manufacturer-specific, and I can tell you at best, we only know it from one manufacturer. We can't even really quote rates on the other ones. COVID may have impeded reporting in the past year, which is very significant, which would mean that we might even see an uptick in the next year. Textured implants can cause BIA-ALCL. Please inform your patients, but don't frighten them. It's important that they're aware of this disease, but they shouldn't go thinking that they have that ticking time bomb inside of them. And we do believe in the surveillance of all patients, not just textured patients. There is no known risk-reducing procedures. Please follow NCCN guidelines. Please test before you cut. Please image before you treat. Please come to Houston in 12 months. Thank you.
So, thank you very much for the lecture. I immediately have you to comment on a recent paper that published in PRS that was dealing with a patient with a smooth implant that developed BIA-ALCL, but they stated in the article that it was because she experienced a textured expander. So what do you think about that case?
Yeah, so that was interesting. In 2019, when the FDA did the Class 1 device recall, they included textured implants out of the theoretical risk of ALCL, removing biocell tissue expanders, only to then see 2 years later in this publication it's not just theoretical, it's in practice, that a patient can develop the disease if exposed to a tissue expander. Interestingly, in that case, there was a longer exposure than average. It was about 14 months of exposure to that tissue expander. However, yet still you had it swapped out and replaced with a smooth implant, which was in place for years. It speaks to the idea that just taking out implants doesn't reduce your risk or seem to affect your risk. And we haven't even seen that removing capsule really can affect your risk. I think that we need to look more what can do risk reduction, but that was a very important paper.
May I add? And most possibly, this patient was exposed to all the factors that predispose to. Because
She
it's
has
a
autoimmune
cancer
disease.
patient, so it's oncology predisposition with German.
And she was also affected by, I think, an autoimmune disorder, if I'm not wrong.
Question?
Congratulations, Professor Clemens. I have one question. What is your take-home message for us, for plastic surgeon? We check the patient with capsule 2, 3, grade 3. Yes, ultrasound is okay. There's not any mass. There is not seroma, and what we have, and there's a texture implant. And we perform the surgery. We exchange for smooth implant. What kind of capsulectomy do you recommend?
I don't. So I think that capsulectomy is a very morbid procedure. It has higher rates of hematomas, pneumothorax. Dr. Swanson talked about the death. There's a case where they got into the subclavian vein. I think that it's unnecessary to think that you're treating something even if you don't have the disease. So do with the capsule what you would normally do. That said, don't think that if you're taking a small little biopsy of that capsule and sending it for path that you've somehow screened that patient for ALCL. Either don't do anything with that capsule and treat it as you normally would, or serially sample it, 12 different samples from 6 strategic areas to, if you're going to try and give some kind of reassurance to the patient, if they're looking for that, if they're trying to say, I want to know if I have the disease, it kind of needs to have that kind of level of sampling to say it to the patient. Otherwise, you're not really checking. So I don't advocate taking the capsule out unless you had planned to anyways. Sometimes you need the capsule for implant stability. Just do what you always did before. No, realize we have cases after total capsulectomies. They still can develop the disease. So it's one of the reasons why no government authority recommends that as a prophylactic move. You can't necessarily say that was any kind of a treatment, and so it's definitely not the standard of care that somehow all capsules need to come out. We should dispel that myth.
Mark, you have a question of Dennis Hammond.
Oh, Dennis, you're still here.
Hey, Mark, you mentioned that case with a tissue expander that was followed by the smooth-walled implant. And I think that I think a lot of attention could be focused on the presence of particles that get left in the capsule from the textured surface of the device. And it makes perfect sense to me that a BioCell textured implant that was replaced with a smooth, where the capsule was not removed, it has done nothing to reduce the risk of the fact that there was still that textured surface implant in, and the particles could still be eliciting their inflammatory effect. Does that line of thinking make sense?
And I think it speaks to that. I use the analogy with my patients that it's like a child living in a house with asbestos, and when they turn 60, they develop mesothelioma. They may live in different houses through their entire life, but they've been exposed at a time up front. And once they've had that exposure, they can develop that iatrogenic injury decades later. Does that mean that we should take out all those capsules of all those tissue expanders to try and get all those particulates out? Well, Dennis, as you know, those particulates are freely taken up by macrophages, which freely float to the lymph nodes and back again and are dispersed through the breast tissue. And you could hardly ever think that you were getting every single particulate piece out again. And we wouldn't even know if that somehow had imparted some kind of risk reduction. So that's one of the reasons why I don't necessarily go after it, but it definitely gives us insight into the pathogenesis and I think gives credence to the theory that you've written on before.
The smooth expanders.
Looking at capsules, digesting the tissues, and the capsules from BioCell implants are loaded with particles. And so if you were looking for a spot to attack as far as trying to do a risk reducing procedure for future development of the disease, it would certainly make sense to start with the capsule. Now, do you get every last particle of silicone out? No, of course, I don't think so, but you certainly get the vast majority of them out, thinking about in terms of a capsulectomy. So hopefully we'll have some elucidation on that in the future.
We have to move on. Thank you very much, Mark.
Thank you.
Dennis.
Thank you, everyone.
Thank you. So it's the last presentation of this session, recorded chemotherapy and targeted immune therapy in BIA-ALCL.
I'd like to thank the organizers for having me join, albeit virtually. And I'm going to go over chemotherapy and targeted immune therapy for breast implant-associated anaplastic large cell lymphoma. Those are my disclosures. So as you all know, breast implant-associated anaplastic large cell lymphoma really fits into the spectrum of anaplastic large cell lymphoma, at least in the last WHO classification system. And I show this just to point out that our treatment paradigms outside of local or surgical therapies, so really our systemic treatment paradigms, are really derived or borrowed from what we use for other types of anaplastic large cell lymphoma, primarily systemic ALK-negative ALCL. So when we think about systemic therapy, I think the first question is who would get it? And the data generated by many of you really shows that patients with local seroma-only disease really do exceedingly well with surgical therapy, complete capsulectomy, and implant removal alone. And there probably is really no role for systemic therapy. But once we get to higher stages of disease and maybe bilateral disease, infiltration of the capsule through the capsule, and particularly those with extracapsular disease, either locally or nodal disease, that's where we really see survival fall off. And those are the patients who are candidates for systemic therapy and really stand to benefit. So I think when we think about therapy for ALCL, really the fundamental change or the medication that really carries the heavy work of treating ALCL is brentuximab vedotin, again, at least when we're talking about systemic therapy. And the data for that really stems from the phase 2 study that led to registration in relapsed anaplastic large cell lymphoma, showing what at that time was really a remarkable response rate, almost 90%. More than half of patients with relapsed systemic ALCL had complete responses, and you see the waterfall plot there. With long-term follow-up of that, we do know that a subset of patients, albeit a small subset, do have durable remissions without consolidation. So if you look at the 38 patients who had a complete response, 16 of those were consolidated with transplant. But of the 22 that were not consolidated, almost half of those patients remained in remission at last follow-up without consolidation. So that suggests that at least there was a possibility that this could be curative therapy in the adjuvant setting. And of course, in implant-associated ALCL, there are a number of case reports, these are just a few here, that really point to what appear to be long-term remissions with single-agent BV alone. However, when we think about curative therapy for systemic anaplastic large cell lymphoma, we really think single agents are unlikely to be curative. Maybe it was 10% in the single agent BV study in the relapse setting, but most of the time when we think about curing people with systemic disease, we're thinking about chemotherapy or combination chemotherapy. And I think there really our best evidence comes from the Echelon 2 study, which again, as many of you know, was a randomized study in systemic T-cell lymphomas, untreated T-cell lymphomas, randomizing brentuximab vedotin versus a CHOP backbone. In this case, it was CHP, eliminating the vincristine due to concerns about overlapping neurotoxicity, and that was randomized against CHOP. And again, this was double-blinded, placebo-controlled study. If we look at who was included, about 70% of the patients in the study had systemic anaplastic large cell lymphoma. So that's really our comparative group when talking about these disease. Those patients who didn't have ALCL had some eligibility criteria regarding CD30 positive. But of course, in ALCL, the patients are always essentially uniformly CD30 positive. And this is who was enrolled. So again, when we're looking at who to extrapolate data from, I think for systemic or extracapsular involvement of BIA-ALCL, we look at the ALCL subset, and about half of the patients actually had ALK negative disease. The study was positive, so there was a statistical benefit in progression-free survival. This is the 5-year update, so this is longer update that we presented at ASH last year. And similarly for overall survival, significant benefit over CHOP, with most patients being cured. When we look at subtypes, I think this is where we really start to think about how we applied here. So if you look here for anaplastic large cell lymphoma ALK negative, this is again the largest group, and you see confidence intervals that really don't overlap with 1. We do have a tendency in systemic ALCL to consolidate with auto transplant. So Carrie Savage led a look to see whether there was additional benefit on top of what we already saw with adding brentuximab to CHP. And these are just the patients with the ALK negative anaplastic large cell lymphoma who had a complete response. So the ones who might benefit from transplant. And here we see that when you added transplant, it looked like there was still potentially some incremental benefit. Again, this is a not randomized, not stratified, so a little less solid evidence, but it looks like there is still some incremental improvement. And we think about that for our patients with nodal involvement of implant-associated ALCL. And when we look at the literature in terms of how patients have been treated, we have our own experience. This is experience largely led by MD Anderson with 2 sequential series looking at patients with more advanced disease. On the left, it was patients with nodal disease. On the right, they expanded that to include other aggressive features, which included bilateral disease and added patients. And you see that the treatment is very much in line with what we did. Some of this was before brentuximab vedotin data, but patients get chemotherapy. Radiotherapy, I assume, is for people with mostly local disease, and a good number of patients also were given auto transplant either in first remission or in relapse. And again, it's hard to extrapolate from these small series, but if you look at the patients with lymph node disease at presentation, while they do worse than those with no lymph node disease, those curves are not bad for people with systemic ALCL. In terms of other newer therapies, beyond BV or BV plus chemotherapy, there are a couple of CD30 targeted treatments in development. So AFM13 is a CD30, CD16 bispecific antibodies that preliminarily had some activity in systemic and cutaneous ALCL, and is now in an expanded study for people with anaplastic large cell lymphoma. And there are some increasing experience with CD30-directed CAR T cells. And you see here just an example of an initial experience from Baylor by Carlos Ramos, and then a larger publication in JCO last year. Again, a small number of patients with systemic ALCL, but there are some responders. I think the other area where I'd look at for additional therapy is the importance of the JAK-STAT pathway in the pathogenesis of implant-associated ALCL. So many people at this meeting have generated some of this data, and just for time, we just see that when we do genomic looks or next generation sequencing or looks at other molecular techniques looking at fusions, we do find frequent perturbations or activation of the JAK-STAT pathway, often through mutations. This initial report by my co-chair for this session, this from Andy Feldman's group, looking at the frequency of JAK-STAT mutations, and then this from our group showing that most of the cases we look at either had mutations in the JAK-STAT pathway, and then there was this novel STAT-JAK2 fusion. I think we've recently completed a study. This is in press in Blood right now, looking at ruxolitinib, so sort of proof of principle that targeting the JAK-STAT pathway can work. And this was in T-cell lymphomas across the board, led by my colleague Alison Moskowitz. And what we saw, if you look over here at the clinical benefit rate, so those are responders or long-term stable disease. Again, these are patients with systemic and cutaneous T-cell lymphoma, that patients who either had an activating mutation of the JAK or STAT, or functional evidence of pathway activation, and that was a high phospho-STAT3 expression by IHC, as you see down here. Those were the patients who were most likely to respond. So I think just to sum up, when we think about systemic therapy of implant-associated anaplastic large cell lymphoma, it's primarily for people with extracapsular disease. I think what's a little unknown, but we think about is high-risk patients with capsular infiltration or bilateral disease, so local disease that may be of high risk of recurrence. And in those cases, we sometimes think about radiation or adding single-agent BV. Again, the approaches are largely extrapolated from systemic anaplastic large cell lymphoma, and I would say the preferred or most active treatments are either BV, CHP, like we use for systemic disease, with or without consolidation of autotransplant, or in certain cases, single-agent BV may be effective. And again, there are case reports of durable remissions with that agent alone. Of course, other chemotherapy works for ALCL and would likely work here, and I highlighted a couple of the investigational approaches that are just underway. So I really thank you for your time and look forward to questions. Thank you.
So I don't know if there are questions for the audience. Yes, Mark.
Hi, Steve. Thank you so much for putting all that information together, as well as chairing our NCCN guidelines committee, and really paradigm shift in the treatment of this disease. I want to have you follow up to some of the comments that were made this morning, specifically by Dr. Arianna DiNapoli, showing that TP53 portends a statistically worse prognosis, appears to be a more aggressive disease with more lymph node metastasis. You showed that JAK-STAT presence may have a benefit of using ruxolitinib for benefit. Are we to the point where we should be genetically sequencing our patients, since it has both treatment ramifications and prognosis ramifications?
Yeah. Thank you. And again, thanks for having me participate. I've really learned a ton. You know, it's just as a personal note, it's great to sit with a group of people who really think totally differently about diseases and approaches. And it's really been a pleasure to be part of this. Yeah, I think that's a great question. And I think it's something in evolution. We profile essentially all of our patients with T-cell lymphoma, partly to understand better, and as time goes on, it's starting to influence our treatment decisions. And we've seen similar things, that TP53 goes along with worse prognosis overall in T-cell lymphomas, including ALCL, and that worse prognosis is primarily chemorefractoriness, which, you know, is one of our main treatments. So while I don't know that I would say it's an absolute standard of care, I think if I had a patient with more advanced disease with TP53 mutation, I would worry that that patient, should they progress or have worse disease, would be harder to salvage. And in some of these borderline cases where we think about, do we give adjuvant therapy, brentuximab, or radiation, really in the adjuvant setting versus observing, you know, I think that wouldn't, not enough data to decide the decision, but that might inform the decision. I think in patients who already have systemic disease or extracapsular disease at that point, probably the cat's out of the bag, and you might think of treating those patients with aggressive disease, with aggressive therapies. Our understanding of targeting the JAK-STAT pathway, like that study with ruxolitinib, which is a decent but maybe not the optimal JAK inhibitor, I think is emerging. You know, as I said, that's a proof of principle that strategy can work. But there's other JAK inhibitors in development, there's STAT degraders, there's other ways to target that pathway that are really clinical trial or investigational approaches. But a long way of saying, yes, I think that's a promising pathway to target, but not that we have a quick answer for right now.
Just one last question. Do you will use brentuximab instead of radiotherapy when you have just local residual disease?
I think that's an individual choice, and what we think, you know, we know for other situations in lymphoma that for local disease, radiotherapy is curative and brentuximab is less likely curative. So all our patients, you know, where I work are basically have had breast cancer. So in an unirradiated breast with residual or high-risk disease in the chest wall or outside the capsule, I have a little more confidence in radiation as curable or locally curable. But for someone who's had previous radiation, we would think about brentuximab, or in these rare cases with bilateral or maybe not truly localized disease, we would lean towards systemic therapy or sometimes both.
Thank you. Thank you, Steven. To connect, this is Fabio. Thank you very much. I please draw your attention on the last two sessions, are very important. So take your coffee break, 15 minutes. Try to come back sharp in time. There are two interesting sessions. One is the social psychological aspect, and that's very important for counseling our patient. We have to understand the patient we counsel for. And then the last, the most important, is the authority guidance. We have to know from there what to do, so it's important to attend it. Thank you very much.
Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, Our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our patients feel safer. Establishment Labs, a women's health company. Over 10 years ago, Establishment Labs was born. And like many of the world's greatest companies, we started in a garage. Years later, we have now grown into a global company, presence in over 70 countries around the world. And even though we began in humble origins, our vision and mission allowed us to focus on the future, allowing us to push the scope of what we thought was possible. Not just for us, but for women everywhere. We wanted to change the game, to revolutionize the industry, to make a difference in a world that needs something new. And with the creation of a new generation of aesthetic products, we did just that. We changed everything for women everywhere. Since the very beginning, women have always been at the center of everything we do. And as a women's health company, we strive to work with innovation and science to make our
session on socio-psychological aspect of BIA-ALCL. I will moderate together. Okay, Professor Lucidi will be replaced by Professor Chirico, who can definitely assist me much better than myself in the moderation, being in the field. So, if you agree, we can start with the patient advocate, Cook. Do we have a registration? Jennifer.
Hello, my name is Jennifer Cook. I'd like to thank the sponsors and organizers of the conference for this opportunity to present. By way of perceived conflicts of interest, I am a plaintiff in a lawsuit arising out of my diagnosis of BIA-ALCL. My presentation will be on the psychosocial impact of BIA-ALCL from the perspective of a patient and a patient advocate. My perspective on BIA-ALCL is shaped in large part by my own story. I was diagnosed in 2017. I had masses along my chest wall. I was treated at MD Anderson. My treatment involved 2 cycles of brentuximab, an oncologic en-bloc resection, followed by 5 cycles of brentuximab. My perspective is also formed from my advocacy work. I have testified before the FDA twice, and I have also been an administrator of several BIA-ALCL-focused Facebook groups for over 3 years. All women facing a life-threatening disease experience similar psychosocial impacts. However, I will focus on the impacts most unique to BIA-ALCL itself. First, I will discuss the topic of betrayal, including causes and effects. Next, I will discuss the unique burdens of having an emerging disease. And finally, I will end with some brief clinician recommendations. So why do patients feel betrayed? A principal reason women feel betrayed is that almost none were warned about the risk of the disease. This fact was highlighted in a 2018 letter to the editor by Drs. Swanson and McCarthy. Not only were most women not warned of the risk of BIA-ALCL at the time of implantation, but as knowledge and concern about BIA-ALCL grew, many women were still never directly contacted. Indeed, many women learn about BIA-ALCL only at the point of developing symptoms and searching the internet, or at the point of diagnosis itself. For some, the delayed knowledge and delayed diagnosis mean grueling treatment and a heart-pounding prognosis that may have been entirely preventable with the simple act of sending a letter or making a phone call. Feelings of betrayal are also sparked when patients encounter the misleading narrative many continue to promote. These misleading messages include seemingly intentional use of imprecise language and mentioning only the positive aspects of BIA-ALCL and none of the negative. The ongoing problem of misinformation about breast implants and cancer was documented this year by the Cancer Therapy Advisor. Such an article really should not have been necessary in 2021. Let me be as direct as possible. Whenever someone speaks about the safety and risks of breast implants, BIA-ALCL should be mentioned, should be identified as a cancer. The evidence that it is associated with and caused by breast implants should be acknowledged, and the full scope of the harm the disease can cause should be stated. To not do this is reprehensible. The more you know, the more prominent your position, the more minds you are trying to reach without telling the whole story, the more outrageous your behavior becomes. The effects of betrayal are as insidious as the causes. The effects include mental health problems, such as stress, anxiety, and depression. Medical care itself can be impacted. For example, a betrayed patient may have difficulty taking advice, may avoid care altogether, or may have needs that lead to inefficient appointments. Betrayal trauma also attacks a patient's self-confidence. They may wonder how they can make informed decisions when they were denied that right in the past. Basically, a betrayed patient faces a dilemma. They feel betrayed by their doctor, or at least the industry they're a part of, but yet they need their doctor to survive. An emerging disease presents unique burdens for both the diagnosed and those at risk. For example, patients frequently have to educate doctors. Even if the surgeon is knowledgeable, the radiologist or pathologist in an evaluation may not be. In these situations, the patient will have to rely on their doctor to bridge any knowledge gaps. The extra steps that must be taken to avoid diagnostic and treatment pitfalls are extremely stressful. Thanks to the amazing doctors at this conference, the data on BIA-ALCL is growing, and we as patients are grateful for this. However, our doctors, unless they're leaders in the field, often don't have time to stay on top of it all. So as patients, we must be the ones to read and study it, and this again adds to the burden of the disease. I will now review some of the most difficult and concerning questions facing patients. We continue to see women have negative fluid but a positive capsule, causing patients to ask, how reliable is fluid testing? We know the problem is sometimes due to a failure to follow well-established guidelines, but that is not always the case. If fluid testing is incorrect, it can have serious consequences. For example, a patient may be denied healthcare coverage for explant. They may also be denied a PET CT scan or an oncologic en-bloc resection. Unfortunately, patients face a whole host of other fluid-related quandaries as well. Some women wonder when a normal or trace amount of fluid should be investigated. Some articles say it should not be investigated in an otherwise asymptomatic patient. But how many patients are truly asymptomatic? Does any reported change in the breast, including pain, itching, or sign of capsular contracture, render a patient symptomatic and prompting need for further investigation? If so, what kind of investigation would be warranted? An MRI, fluid testing, explant and capsulectomy, or all of the above? Recent articles address this problem, but none offer easy solutions. Women often wonder, how do they know if they have just a normal or trace amount of fluid around the implant, or whether the amount of fluid is perhaps more significant? An article from the Journal of Breast Imaging highlights the value of an MRI, for example, for assessing fluid collections behind the implant. Another recent article from Italy recently identified a case where ultrasound showed a scant collection of fluid, but on PET MRI, the fluid collection was found to be moderate in size. Some women worry about swelling that comes and goes. Some women in our Facebook group diagnosed with BIA-ALCL reported this as a symptom. Fluctuating breast size as a symptom of BIA-ALCL is also documented in the literature. Patients also worry whether their capsule testing will be thorough enough to not miss the disease if they do in fact have it, so they can avoid the risk of an inadequate resection. A groundbreaking article authored by several of today's speakers highlights that BIA-ALCL can be focal and sometimes present without grossly identifiable lesions, and therefore a minimum of 12 strategically collected samples are needed to increase the probability of disease detection and the identification of any positive margins. But patients worry whether, if they're just suspicious for but not diagnosed with the disease, whether they'll be able to have this level of capsule testing. Perhaps the most common and distressing question facing women at risk for BIA-ALCL is whether, and if so how, they should explant. We know this is always a case-specific question. The benefits of finding occult disease in the capsule, however, is rarely mentioned, but we know this has happened and it continues to happen. Are the risks of a total capsulectomy always higher than implant removal alone? Is there any research that directly compares the risks involved in the two procedures? Are insurance companies covering explant for biocell implants in asymptomatic patients? If so, why would they if there's no potential medical benefit at all? Perhaps better research and data collection will help us with these problems. Patient advocates believe Profile should collect data from international and U.S. patients. We also believe that patients should be allowed to submit medical documentation directly to Profile so that the database is more accurate, comprehensive, and up-to-date. Here are some brief recommendations for clinicians. Don't get defensive with patients. Acknowledge feelings of betrayal. Speak up and speak out when you hear others try to mislead or minimize the disease. Assemble a team of radiologists, pathologists, and oncologists that you have confidence in. Stay current. Support better and unbiased research. And tell patients about any of the above things that you do. That is what will build trust. For clinicians who want to hear about published and unpublished information directly from experts, advocates, and diagnosed patients, here is the official name for the private Facebook group. The group is just for clinicians and diagnosed patients. No one should have to face BIA-ALCL alone. If you have a patient that wants support, tell them about our website. The website is easy to remember, www.biaalcl.com, no hyphen. The website has links to communicate with advocates by email, as well as links to our patient-focused Facebook group. On behalf of all patients facing the threat of BIA-ALCL, thank you for listening.
So thank you so much. Andrea Chirico is one of the moderators of the session. And I don't know if you can look at me, I'm here. And I'm very happy to listen this discussion. I have just a question that arises me from this discussion. It's about how do you think a psychologist can interact with the team in order to provide support in terms of knowledge or information?
I guess a psychologist may be able to help the patient understand what they need in terms of whether their psychological distress is having to do with a lack of information, a lack of support, and maybe just get a better understanding of the source of any stress and anxiety that's inhibiting, their medical appointments or their quality of life. Sometimes when you're in the middle of a crisis, you have a hard time understanding, the source of different, mental health issues.
So I would like to discuss about one of your points. So what's the minimum amount of serum of liquid that should be sent for cytological examination? And you cited one of the recent Italian paper that deals with 6 ml of seroma that was diagnosed as BIA-ALCL. Well, I reviewed that case, so I know it well. So it was a true BIA-ALCL in 6 ml of seroma. However, we have to know that the patient had the previous seroma that was sent for flow cytometry, and they did not diagnose it as BIA-ALCL. We could not review it because we don't have any, cytosmears, any cytoblock. So it is not easy to say if it was not already a BIA-ALCL. So what we have a seroma, we can maybe better split for flow cytometry, for cytology, and for culture studies. So it is better to have something that is like a cell block. I'm looking to Miranda because, we have to manage these things because we have to be sure that the first seroma was not, a BIA-ALCL already. I don't know if you want to add that.
Oh, Ms. Bennett, thank you. I listened to your comments. I appreciate that. I appreciate Dr. Di Napoli comments. I think lethal fluids are always very difficult to handle. We can miss the diagnosis too. But as Ariana, Dr. Di Napoli said, the first fluid is the most important. If the patient presents with 100 mLs and that is drained, and a month later has 100, and it's drained again, and the next month is going to have 5 mLs, and that's what they send, we miss the diagnosis. And the patient has 100 mLs. Sometimes the lab only receives 5 mLs. Where are the other 95 mLs? So we try also to, we have been learning here, we have to educate our other colleagues in the medical team. The radiologists, please send us the fluid. Why are you keeping it? Or to the clinicians, so you are suspecting this, please send us this. Also, when we process this, for example, we process a capsule, and we say, wow, this is suspicious, has features that can be ALCL. So I think we have learned much, as particularly me, to be bold and say to my clinician, you know what, this is suspicious. I think you should keep a very close look at this. I suspect that there is lymphoma there. Please, if you didn't do complete capsulectomy, you have to do it here. In this circumstance, I am suspecting here.
Question to our speaker?
Thank you very much. I hope there is a radiologist with us to answer this question. What is the time, the normal after the implantation of the implant or the surgery, Ferris surgery? Sometimes we see the fluid 1 year after the first surgery, sometimes 2 years. Do you have any idea about the amount of of time that may be associated with fluid? Is it normal after 1 year or 2 years to have fluid around the implant? When is a fluid suspicious after it is recurrent? We say recurrence of a fluid, let's say it was drained 50 ml a month, and 3 months later, still you drain it, and you put a drain there. After that becomes infection, comes fibrosis, and the disease starts getting distorted. When you see that, you have to suspect very, very strong that it can be a lymphoma, something which is protracted course of disease. I will be very worried. I think there are several signs that it could be lymphoma, which I've seen those cases when they are missed, and they are missed up to 6 years. The patient has been having the problem 6 years. I've seen cases that they have removal of the implants. They left with just the capsules, and then the disease, sometimes it stays in the same state. It was not an aggressive disease. And sometimes they progress. So I've seen all the spectrum too. Again, I am talking about very limited number of cases. I don't know how much frequent, but I've seen those patients.
Thank you.
I cannot say how extensive this damage can be.
Thank you very much. We go on with the next, Professor Costantini. Please try to stay in time because we have the authority guidance session to respect, and no break in between. Thank you. Sì.
So, thank you, Fabio, for the kind invitation and for the wonderful hospitality last night. I want to apologize, first of all, because I will read part of my speech. My English is not so fluently, so time is really limited, and this is why I will read. I'm not use it. So now let's introduce. No. Come vado avanti? Okay. Okay. Let me introduce psycho-oncology as the referent context in which I will treat my speech. Psycho-oncology is a borderline discipline between psychology, psychiatry, and oncology, an area in which different knowledges and practices interact and converges for the best interest of patients. The involved actors must recognize how specific characteristics of disease, treatment, and doctor-patient communication can profoundly influence psychological adjustment, as well as psychological and psychopathological aspects can influence illness behavior, compliance, and, in some cases, survival. In this perspective, vorrei tornare indietro. Come torno indietro? In this perspective, psychological implications and reactions may differ depending on the specific clinical situation, both in case of diagnosis and in case of communication risk. For this reason, psycho-oncologists need to know the specific characteristic of disease of their patients, in this case, BIL characteristic. For example, that the majority of cases are localized
and can be cured by implant removal, but that a small percentage experiences disease relapses and widespread dissemination requiring systemic therapy or antibody drug. Acknowledging the risk of BIA-ALCL, it may increase fear of recurrent syndrome, a prominent clinical issue, distressing, long-lasting, and can be associated with poor quality of life. In case of BIA-ALCL diagnosis, the international scientific community since the 90s has recognized cancer as a traumatic stressor that may cause other syndromes such as post-traumatic stress disorder, depressive and anxiety disorder, adjustment disorder, demoralization syndrome over the course of disease. But regardless of the perceived severity of the illness or tumor dimension, the 30 days following the diagnosis are very sensitive period. But what do we mean by traumatic stress? A traumatic stress is a breaking point in the experience of oneself. It's an attack on the sense of personal security. It's an emotional tsunami. It's a flood of chaotic affective states with a disorganizing effect and that the mind cannot easily process. My whole world came crumbling down again. I had spent the past 6 years going to the oncology every 3 months trying to keep cancer away, and here was something I put in my body to try to help me feel more like a woman, and it gave me cancer. I thought I am not going to see my kid grow up. A person's emotional response to cancer is determined by interpretation of the diagnosis. Existentialists would say that we are creatures in search of meaning, perception of control, opinion about prognosis. For example, one may feel guilty by attributing the choice of breast implant to a matter of vanity. As psychologists, we know that taking responsibility for something is paradoxically a way to cognitively master a traumatic event. Psycho-oncological literature shows how many factors can influence these 3 aspects. Last but not least, information received. For instance, research has shown that negative interpretation of ambiguous information correlate with long-term low resilience. What health professionals know very well is that information is not just about the medical legal aspect of consent, but is associated to understanding and appropriately reacting to the risk, formulating of surgical preferences, and more important, to have future awareness of suspicious symptoms. However, communicating the risk could be a complex matter in a psychological sense. For example, facing complex decisions, individuals may overestimate or underestimate personal risk to reduce distress. Negative emotional memories influence the new information in our mind as cue to establish our own risk and drive decision-making. For example, this is why a woman with a previous history of breast cancer or post-surgery adverse events may think that the personal risk to incur in BIA is very high, and she might make decisions based on the emotion lived in previous cancer experience. A recent study showed how only a minority of surgeons explain about risk during pre-surgery consultation, and I add, in my 20-year experience as trainer in communication skill in doctor-patient communication, even less verify the patient's understanding of the information received at the end of a consultation. The truth is that there are many obstacles to be faced in doctor-patient communication. And my opinion, and not only my opinion, is that lack of training includes almost all the above. Can we do better? Of course, we can. Improving doctor communication skills, improving and empowerment of patients, improvement collaborative multidisciplinary teamwork, and psycho-oncological specialistic support. For sure, it has been extensively documented in the past 20 years that communication skills are associated with important care outcome. Since 2004, we have been working with Professor Bale and the Anderson, introducing Oncotalk project in Italy to overcome cultural barrier, paternally special in particular, and teach communication skill in dealing with difficult information in oncology and palliative care. A model of BIA-ALCL informed consent implementation and healthcare provider education increase the likelihood of discussing risk and feeling comfortable answering patient questions. In the context of care, the active role of psycho-oncologists is relevant for taking care of patient emotion, support physician during communication risk, guarantee patient information and psychoeducation, explore women's concern and preference, and in case of patient undergoing oncoplastic reconstruction, support should be based on these useful recommendations suggested by the Milan group of IEO. Once the diagnosis is made, reflective acceptance, personal existential awareness, adaptive action are the goals of psycho-oncologic intervention to help transform overwhelming emotions into invigorating and revitalizing one. Since 2007, we have been collaborating with Sloan Kettering Psychotherapy Laboratory and other centers in US and Europe to introduce new psycho-oncology intervention evidence-based. Today, all these interventions are validated in our culture, manualized, and available in Italian language. In the last 36 years, psycho-oncology significantly contributed to the transition to palliative, to patient-centered medicine. And we hope that the 300 psycho-oncology registered center in Italy will be empowered to continue this important cultural change as indicated by the state-region agreement document. Thank you.
Thank you, Dr. Costantini. I have just a very quick comment, and based on your experience in the field, how can really we use your experience as a psycho-oncologist to intervene in all this cognitive bias about the making decision, the conflict of decision that the patients start to have in doing or not doing a breast reconstruction, for example, after a cancer?
Very often, because, for example, we work a lot with a patient of Professor Santanelli, and the patient after doing consultation with surgeon speak with us and expressing doubt, alternative, and concerns, and we, in general, we work with their doctor and their surgeon to clarify about every doubt and evaluate cost and benefit obviously in accord with doctors and team. We work in multidisciplinary team.
Okay, great. Thank you.
Thank you. Then we can go on with the next presentation from Georgina Jones. It's pre-recorded from UK.
Hi everyone, my name's Georgina Jones and I'm a Professor of Health Psychology and Director of the Interdisciplinary Centre for Implant-Based Research at Leeds Beckett University, UK. Thank you for inviting me to speak at your conference, and apologies I can't be there in person, but I'm delighted to share with you the findings of, from a systematic review we've undertaken to explore what the psychosocial issues are for women diagnosed or concerned about BIA-ALCL. The question we wanted to examine in the review was, what are the key psychosocial issues for women with a diagnosis or concerns about BIA-ALCL? And the aim of the review was really to try and understand what the overall impact of this diagnosis is upon the psychosocial and quality of life issues as self-reported by the women themselves. Our search strategy involved searching across a wide range of medical, nursing, psychological, humanities and social science and open access databases. We searched up until the 30th of June 2021. We additionally hand searched reference lists of eligible studies and review articles, and our sources included quantitative, qualitative and mixed method studies and full text English language papers. In terms of patient characteristics, our inclusion criteria was that the women had to have been aged 16 years or older. They had to have undergone breast implant surgery for cosmetic cancer or risk reduction purposes. And they also had to have been diagnosed or concerned about BIA-ALCL. We excluded papers that had been undertaken on non-humans, where they were aged younger than 16 years old, the population focused on transgender women, or the women hadn't undergone any type of breast implant surgery. As you can see from our PRISMA flowchart, from the records identified through our database searching, we retrieved 526 papers. But after removing duplicates, screening abstracts, and then the full text articles for eligibility, only 4 studies were included in the review. This table provides an overview of the 4 papers that were included in the review. All of the work had been undertaken within North America, with 3 studies being carried out with patients from Canada. There were 2 qualitative papers and 2 quantitative papers. All of them differed though in their reason for the study. So only 1 study was specifically carried out, including a sample of women with BIA-ALCL, that it explored their barriers and concerns and worries related to breast implants and BIA-ALCL. So firstly, the review showed us that there was a paucity of psychosocial research in this area. This is perhaps not surprising, given that BIA-ALCL is an emerging field, and this was highlighted in the publication dates of the relevant literature, as all the papers were published last year in 2020. None of the papers focused exclusively on women with BIA-ALCL. One paper reported that they did include women with BIA-ALCL, but they were a mixed sample, including women who had breast implants and were concerned about potentially developing this condition, or they included lay women as well. So it's a real heterogeneity in the samples of the relevant literature. There was also a lack of long-term follow-up studies, and what this highlighted is that there's a real need for focused psychosocial research with this specific group of women. So whilst I've just highlighted what the limitations are to the relevant literature that we found in the review, we were able to tease out some emerging factors that appeared to contribute to a poor psychosocial well-being as self-reported by the women in the studies. The first area was around fear, and many of the women expressed a fear of developing BIA-ALCL, and this was reflected in 2 papers that reported that a number of patients in their sample were seeking explantation as a result of this fear. Problems were also expressed between the doctor-surgeon and patient communication. Women, for example, expressed not feeling listened to, and that trust was being lost in that relationship. There was problems in seeking explantation, and this particularly related to differences in the wishes of the patient compared to their doctor-surgeon. So, for example, for the women, some of the women in the study, the only option was surgery and to have the implants removed. But this was often against or differed to the advice given by their attending clinician. There was problems with follow-up and monitoring. Many women felt that this was inadequate and didn't meet their needs. There was problems expressed in terms of delivery and communication of evidence-based information, and this particularly related to issues around the communication of risk in relation to breast implant surgery and also BIA-ALCL, and also particularly around the informed consent process, with many women expressing that actually they didn't feel fully informed before they went ahead with the breast implant surgery. And there was also a lack of global trust in the wider breast implant related stakeholders. So, for example, manufacturers, commercial entities involved in breast implants. There was this feeling that the wider global community was contributing to a poor psychosocial well-being for these women. So, having shared with you the problems that have been raised by women in the existing literature, how can we better support them moving forward? Well, there's 3 key things that we can do. First is that we need to provide high quality patient information, and this really needs to be around how we explain risk and for example, which needs to be tailored before they have the surgery, but then women need to feel informed about any emerging risks post-surgery. We also need to provide BIA-ALCL evidence-based materials that will support decision making and particularly informed consent. The second thing that needs to be done is to really ensure there's positive patient-doctor-surgeon relationships, and this is really fundamental to improving the psychosocial well-being of these women. And one way to do that is to ensure that trust is built and maintained, and this can be done by pre, during and post-implant surgery, really listening and responding to the patient, and also acknowledging their concerns and any future signs and symptoms and concerns post-surgery that might be expressed by them. And the third thing we can do is to really improve care pathways, and that will involve much better monitoring of these women through the development of registries and guidelines, which I know are taking place, but also undertaking ways to routinely collect outcome data from these women as part of routine clinical practice, so that they can be, their quality of life and their psychosocial well-being can be captured. And then finally, we need to provide better access to clinical and psychological support. And one of the ways this can be done is through the development of breast health clinics that are within the community or in outside of primary and secondary care, more drop-in centres for women to go to, through referring for professional, take proper counselling. And again, as part of clinical care, the psychological services are limited, but these need to be expanded on for this group of women. And also through the development of BIA-ALCL focused psychosocial interventions. So to conclude, we've reviewed the psychosocial literature and found it to be currently limited, but we were able to identify some emerging areas of patient need which can begin to inform clinical and research practice. Again, I think at this point it's important to say though that because of the gaps in the evidence base relating to the clinical management of women with BIA-ALCL, then it's probably very difficult to answer some of those challenging questions and meet all the information needs for patients that they desire at the moment. But hopefully more research can be done to move that forward in this area. Our team are currently undertaking some more research with this patient group to try and address gaps in the psychosocial UK evidence base relating to BIA-ALCL. I'd like to acknowledge and thank the rest of the study team who've been involved in this review. Thank you for listening, and if you'd like to see the full information about our review, please go to Prospera.
Thank you very much. So, if Professor Kiriko agree, I would like him to take the advantage of his fantastic synthetic capacity in order to put together those concepts and highlight something, including with your experience.
Okay, so thank you so much. If there is any question for our speaker, I will try to do this sum up anyway. Okay, so thank you, my colleague. And
thank you, Georgina.
Thank you so much. So actually, my presentation, I will try to be so quick in order to give you the time for the next session that I understood that is very important for you. And my speech was about body image perception. That probably that last part of this story that has been mentioned. I think since the review that show also my colleague now expressed that there are just 4 studies on psychosocial factors on BIA-ALCL. So we as psychologists probably we should start to sum up some integrating idea, some multidisciplinary thing. So I think that some of the variables that came up from all the session are the fear of recurrence, are communication skills between surgeon and patients. There is a problem of making the right decision. So what seems to me, and I would like to know also your opinion as doctors in this field, and we can also argue that we can try to answer any question or idea that came up from you. It seems to me that there is a need, and probably this would be the place, Dr. Santanelli, to ideally create a group, a multidisciplinary group, integrating the psychologists in the variables that we traditionally take care, for example, for psycho-oncology. So I don't know if any of you any thoughts on this, and if there is any idea for this. Because, for example, my speech will be about body image perception, but this has been studied mostly and only on cancer patients. And what we see in the literature review of my colleague is that 78% of one of the study on BIA-ALCL, the sample was 78% breast cancer patients, that they need to choose to have a breast reconstruction or not? And then there is a knowledge gap about the problems and the risk for BIA-ALCL. So I think here we try to do our best as psychologists to integrate our skills that we develop in psych-oncology or in other different fields. But probably it's the time to do a working group with the psychology, try to address some specificity that came up from this session, that there are some needs from BIA-ALCL and also from doctors and all the team that are related to it. I don't know if I'm expressing good my idea, my opinion. I will be happy if we can just a couple of minutes or more of any question or idea.
Sure, thank you very much. I think that not by chance our faculty is named Medicine and Psychology. So we are integrated by the name and the nature of our faculty and faculty member, of course. And so we work really close, elbow to elbow with Dr. Costantini. So I think it's definitely also the aim and the goal of this meeting is to put together different aspects of the same problem in order to make a multidisciplinary approach and to be as much as comprehensive and inclusive as possible, in order to have a clear picture of the situation and not a monochromatic picture of the situation. What do you think? We have a few more minutes if you want to give us your opinion. After Georgina for a comment.
So, of course, I agree. And I am really interested in the Mark Clemens experience, because I know that you published, and I show your paper, on the implementation of informed consent and education for healthcare providers in MD Anderson. So I don't know if a psychologist worked with you. I know very well Walter Bale that worked in MD Anderson. I collaborate with him a lot of years, but I dream to replicate something like that. And I am really interested in your idea and how you have imagined, how you decided to improve in this field.
Thank you very much.
It's off.
Thank you so much for those comments. The informed consent manuscript was back in 2015. And I can't tell you, it was really challenging to bring to publication. I remember the reviews were very poor with the journal, with one of them saying that they felt that it was purely written for lawyers and that this should never be considered a standard of care. But I think that we found that most physicians were not including it, that it was clearly already involved in the package insert for all the manufacturers, and that at the end of the day it became a something that needed to be educated on to change the mindset within the society. So I can say it wasn't well received, but it was very nicely received by patients. We did have the fear that patients would run out of the room or be very frightened or didn't know how to handle the idea of an iatrogenic malignancy. At time of initial consultation on the reality was that they actually appreciated that additional information. They felt more informed, and they could still choose to get the implant, but that they appreciated being part of the decision-making process. I think that we could go farther, though. That I don't think that, as you saw from the patient presentation, is that there's still a number of concerns that are not addressed, and we need to do better with that.
Okay, I think there's Georgina that
Yes.
wants to say something about it.
Hi, can you hear me?
Yeah, we can hear you. We'll listen to you.
Yeah, I just think it's a fantastic initiative if a working sort of psychology group, with global partners could be put together. I think from a UK perspective, we've battled in a way because of it's still seen as a rare condition, and that's changing. It's changing to being an emerging condition, but in terms of providing psychological support and raising awareness of the psychological needs, unmet needs for this patient group, it is challenging. And there are so many different types of psychological intervention. There's patient decision aids, for example, that we have a lot of experience in developing, but many others that would be of value. And I think it would be great if we could all come together and work out, what might work best, how might clinical practice benefit from different types of psychological support. And I just think it was a fantastic suggestion that was just raised a moment ago.
I think that it is a rare condition, but actually we should also think about how the cultural changes. So we have a higher number year by year of breast implants, and we think also about cancer, breast cancer. Now the standard, the gold standard of surgery is the breast reconstruction. So even if it's a rare, we are statistically the incidence is the same, but we have a higher number of people now having breast implant in different condition. And also about breast cancer, there is two different burden. You have the burden of having cancer and probably already had a surgery for this, and then the burden to feeling the fear of the risk of BIA-ALCL. So I think this is very worthwhile for us as psychologists and for you. And I think also there is a need of the doctors. There are some needs, communication needs. There's a lack of knowledge also. And this is if I was a doctor, I was scared about expressing this kind of risk to a patients, even to breast cancer patients, about how can really deal communicating right risk without giving fear or putting some cognitive bias to this person or denying her body image, problems. And I think there's a very great team group, and I would like to take this initiative with Dr. Costantini, with all these speakers this session, and try to create also an European working group on this. I don't know if it's possible, and with Professor Santanelli is agree.
Sure. I think it's a great idea. Is there any comment from the audience? I would like only to state one point. If we should pay a little bit of attention in wording, the BIA-ALCL is not a rare condition. BIA-ALCL is an uncommon condition, which makes a difference. It seems subtle, but it's a substantial difference. So it's no more rare, it's uncommon, and we have to start thinking in that direction. So I don't know if Mark agrees, but it makes a difference. Then I agree fully with you, and I think we have to move in a more European group of, multidisciplinary. So I thank you very much, and we can now start probably.
Last things.
Yes, 1 minute only.
Sorry, Fabio, yes, I did said that it's rare. I didn't mean that. I think it's rare. I think there's a perception in the UK still amongst lots of practitioners that it's rare, and because of that, when people who work in this field don't like to think of it as rare, it just makes our role as psychologists harder to get into to try and move this patient need forward. So I completely agree that we shouldn't use the word rare as well, and it's just that there is a lot of that perception in the UK that's made our work very challenging. So I apologise if that I didn't make myself clearer when I just raised that point a moment ago.
So now I think we can move on to the next session, which is the most important, At last, but the most important, which is the International Authority Guidance session, I would like to invite my co-president, Mark Clemens, to chair the session. Thank you very much, Professor. Thank you to all the speakers. And it's going to be very challenging and interesting. We're going to have a presentation from Paul Piscoy, which is the chief of the European Task Force for BIA-ALCL. And then we will have Wim de Jong, which is the chairman of the SHARE committee, and other authorities from France, the Netherlands, and have a thorough discussion altogether. Thank you very much. We go on with the Paul Piscoy. Thank you.
Good afternoon, everybody. My name is Paul Piscoy. I work for the European Commission Medical Devices Unit, and this afternoon I will present to you the work of the Task Force on Breast Implants and Anaplastic Large Cell Lymphoma. As a way of background, the signals coming from 2008 on a new entity which was linking lymphoma and breast implants become maybe one of the first regulatory reactions by the US FDA Food and Drug Administration, publishing on their website about the possible association between the breast implants and the development of anaplastic large cell lymphoma. Then in 2016, the World Health Organization introduced in its classification of lymphoid neoplasm a new provisional entity called breast implants associated anaplastic large cell lymphoma. In EU, in the end of 2012, a task force was established by the member states with the participation of the European Commission in order to try to deal with this new emerging entity. 12 member states plus Switzerland and UK, together with Commission, joined to exchange all the information that was available at that time, to pool the data, to cooperate with international regulators. So far, we discussed many times with USA, Canada, Austria, Brazil, and Japan, to share information on national measures and to discuss and coordinate national regulatory measures. The last two bullet points are separated because the delivery of public health measures is strictly the duty and falls under the competency of the member states. Some highlights of this task force include many teleconferences between the member states and with international regulators, the cooperation with the European Commission scientific panels, and I will describe that in greater detail later, and provision of data to the one of the scientific committees of the European Commission. Then also we participated at scientific discussions and regulatory consultations in Amsterdam, in Paris, and today in Rome. When discussing about the interaction with SCIR, which is one of our scientific committees, in 2017, we received from them a scientific advice linked to the status of available scientific information on BIA-ALCL at that time, and one of the conclusion was that a more in-depth evaluation was recommended. So within the task force, and also largely with the member states, we came up with a mandate that Mr. Wim de Jong will describe later. And in 2021, the committee delivered an opinion, and I will try to highlight some of the points in this opinion. Maybe the first one is that a moderate weight of evidence for a causal relationship between textured breast implants and anaplastic large cell lymphoma was found, and Mr. de Jong will explain the meaning of this. Then it is very difficult to assess the magnitude of risk per type of breast implants, so a risk assessment per implant type is needed. Then the pathogenic mechanisms of BIA-ALCL are not understood. There are a few competing hypotheses, and also very important, especially that today we have a very large audience, including patients, that devices, this type of devices, breast implants, are not lifetime devices. And it is very important for the patients to be aware of both the benefits of the implants and their risks. In the cooperation between the task force and SCIR, maybe one of the most important transfer of information was the sharing of the data collected by the member states over time. And this data was split by the committee in member states, in filler and in surface categories. And as an overall figure, at that time, there were 345 confirmed cases of BIA-ALCL. Maybe one of the most important slides of my presentation is the update of this information from last week. To date, we have 426 confirmed cases and 56 not yet confirmed ones. Quite interesting, there is one report coming from a member state on a possible association with a smooth implant, and also one case coming from literature. In August, there was a study published. There are some limitations, but nonetheless, the possibility that this association exists also with smooth implants is an important one and needs to be considered. I have underlined the need for the patients to be informed. And also, I can say that from 26th of May 2021, the new regulations on medical devices is in full force. And these regulations mandates that in the public domain, there are sources of information. And I will name the most important one. They are the summary of safety and clinical performance, the implant cards for class 3 and implantable devices, then the instructions for use, also certificates, manufacturer's data, and the unique device identifier will be in the public domain. And it is also requested that the clinical investigation reports and summaries are made public. This information will be found in a future database called EUDAMED, and I included a link in the presentation to the page which informs what is the latest status of its development and also provides the link to the future resources. I would like to underline that it is the duty of the physician to inform the patient on both the benefits and the risks of the devices, including breast implants, and that the breast implants are class 3 devices. This in practice means that they are under the highest regulatory scrutiny in terms of their safety and performance. This was my presentation for today, and I thank you for your attention.
So are there any questions from the audience?
Well, I only have 2 points that I think we have to probably go deeper and discuss probably a little bit. We as European societies have a connection, and we try to collect all cases according to the diagnostic criteria of the CNN, of the NCCN. And at the moment, we made a recruitment of all our expert and referee, and we have 489 cases around Europe. That's its hour. And it surprised me those 2 cases so smooth, because we've been discussing one case, which was published in literature, and it's hard to consider a smooth case, this one. We are far too considering. And the second, I don't know which one is, I don't know, what's your opinion, Mark? And
yeah, that was one of the questions that I had, was where there's been no reported case in 24 years worldwide in any case series or registry or case report in the literature. We know that the paper that it referred to in the little asterisk referred to a patient that had textured BIA-ALCL tissue expander for 14 months and then a smooth implant and then developed the disease. Can you give any further information on the pure smooth implant case? As you said that you thought that it was critically important that that represented that it was associated with smooth implants.
I guess the question is addressed to me. So Paul Piscoy here. Thank you for inviting myself and the other regulator colleagues today. As a matter of fact, the two cases that I listed there, one I found when I was reviewing the data after before this conference, and I didn't have the time to go back to the authority that was reporting it, in this case Spain. So see it with a bit of reserve. And the other one that was in the public domain that I quoted was also made available to me by email, or available to the whole task force by email a few weeks ago. So I recognize that there are some limitations in that study, and remember that most, although we are qualified people and even medical doctors in the task force, we are not scientists dedicated to all the details and intricacies of these studies. So I just wanted to flag them for the discussion rather to impose that those are necessarily proven cases. Think of that slide as mostly as a sign that those types of that type of discussion needs to take place. And also I'm aware that the Italian colleagues from the Competent Authority will write a letter on that study to the publisher. So I don't think that I can say most at the moment, or at the moment. Maybe some of my colleagues know more details, or maybe even Wim de Jong.
Thank you for...
There's a question down there, please.
Erik Vogelenzang, Establishment Labs. Just can the panel clear us up, because we saw an FDA number of 733 earlier today. We see now a European number of 450 plus undiagnosed cases. But, and I saw, Mark, in your presentation you said 1145. These numbers don't match. So where is the discrepancy on those numbers and presentations? Thank you.
Yeah, I believe that's the difference between US numbers, European numbers, and then global numbers. So the number that I gave was global across 48 known countries that have reported a case. I believe Paul Piscoy's was based on the European Task Force, so it was limited to the European Union. And then the FDA numbers were a predominantly US based, except for it does include, if somebody has a international case that they decide to report to the MOD database. In our 2017 paper, where we reviewed all of the reports in the MOD database, we found that approximately 15 to 20% were from international, and about 80 to 85% were US based. So there's where those discrepancies come. It depends on the reporting body and where they're getting their numbers from. To the best of our knowledge, and again, that just comes from American Society of Plastic Surgeons global reporting, we see that 1100 number that I presented, but totally different what they're tracking.
So I have a question for Mark. Mark, my point is, I've never been very good in mathematics in my childhood, to be honest, but if in the United States we may say that we have something like 5% of texture implant, except 2015-16, where we had about 23% and then slowed down immediately again. So we may say that 10 years ago we had something like 5% of texture, 95% of smooth. Well, at the moment we have 373 BIA-ALCL patient connected to texture. So my question to Mark is, where are the other 35,340 BIA-ALCL with smooth implant?
I can't answer that. We do need to have better tracking of cases, reporting, education to the public, referral patterns to registries, but at this point, there may be additional cases that we're not aware of, and we are seeing discrepancies between countries in their reporting structure.
Thank you very much.
A couple of things here. Paul Piscoy. So in the EU, the cases that you see as confirmed are confirmed on the WHO criteria. And I'm sure that Mark can explain that much better than myself, but my understanding is that Mo database is also based on self-declaration. So as the FDA acknowledges on their website, it's not necessarily fully tracked cases and fully confirmed cases. So there might be duplications in the database. So it might help explaining the discrepancy. But as Mark said, tracking of cases is not ideal at a worldwide level.
Point, as he pointed out, they've done very good due diligence within the European Union to only have absolutely strict criteria for all the cases that they can feel comfortable that those are actual cases. Whereas the FDA MOD database, quote, unquote, may be inaccurate, unverified, untimely, and biased.
Okay, last question.
So the question was, you know, it's a cancer, so it should be reported. If you had an increase in ALCL in Europe, it should be reported by each country by the hematologist who were treating lymphoma, even if it was not associated with the breast implants that were put in. And I've not seen in the data that was been published or something that those increases are seen.
We have seen quite a large increase in Europe. In fact, Europe reporting has probably grown faster than any other area of the world in the last 18 to 24 months. So we're definitely seeing a lot more cases. It does suffer a bit. I don't think that we've had as good of education penetrance into the oncology world of Europe. For instance, we have NCCN guidelines, which are US-based. The equivalent would be ESMO guidelines, of which there are none for breast implant ALCL. So I think that would go further in helping with referral patterns and tracking.
Yeah, but every lymphoma has to be reported by the hematologist. So if they had lymphomas which they were treating, even if they were not associating it with breast implants, they should have reported this. And there is not a huge increase in number of lymphomas treated in Europe from the data that's available on the websites. You have the registry, cancer registries in each country, which people have to report every single case of a malignant disease. Right. So, and this has not been the case that I can see from hematologic sources.
Yeah, again, it would be uncommon. You would expect in the number of hundreds of patients in a populations of tens of millions to hundreds of millions. And so I don't know if it would be enough to shift an overall lymphoma reporting a significant amount. We definitely don't see it for systemic ALCL. We didn't see a number of increasing just because the breast implant ALCLs got tacked on there early on. Systemic ALCL has been around since 1986, and it wasn't like an enormous number jumped up in the 2000s. It's breast implant ALCL still represents a very small proportion of non-Hodgkin's lymphoma, which is approximately 1 in 50 in the general population.
So, if you're happy, thank you. We can go on with the next presentation from Wim de Jong, who is the chairman of the Share Committee of the DG Sante European Health Commission. Thank you, Wim.
Good afternoon, ladies and gentlemen. My name is Wim de Jong, and I was chairman of the working group on breast implant-associated anaplastic large cell lymphoma. I would like to thank Fabio Di Santanelli and Mark Clemens for inviting me to present here the final opinion on the safety of breast implants in relation to anaplastic large cell lymphoma as published in March of this year. I would like to make a disclaimer that the views expressed in this presentation and in the scientific opinion are the views of the SHEAR Scientific Committee and do not necessarily represent the views or the politics of the DG Health and Food Safety of the European Commission. The mandate on which the opinion was based was already previously published and discussed, but in general there were a number of questions as a kind of introduction on what is BIA-ALCL, what are possible alternatives, and an evaluation of the risk of BIA-ALCL for women with a breast implant. We used the weight of evidence approach according to the memorandum of the scientific committee. It was based on literature searches and literature provided by the working group members. After excluding irrelevant papers and duplicates, a total of 605 papers remained for the evaluation of the opinion. There was a public consultation period, and we received from 37 persons or institutions 160 contributions. And based on this public consultation and the comments, the opinion was adapted and based on these comments. As you know, BIA-ALCL is an uncommon occurrence adjacent to breast implants. It was recognized as a provisional entity by WHO and generally has an excellent prognosis. In the epidemiology, we have seen an increase in numbers reported worldwide. This can be attributed to several aspects. There is, in general, has been a raise in awareness, both in patients and in clinicians using breast implants. The last years, there have been formulated specific diagnostic criteria, and there has been improvement in the diagnostic tools, especially in the imaging techniques. Major problems, however, are that we do not know how many women actually have a breast implant, and more importantly, we also do not know the subtype or the surface characteristics of these implants that are used in these women. When we look at the epidemiology, over the years, there has been an increase also in incidence. It started with Jong et al., who had an estimation of 1 to 3 cases of BIA-ALCL per 100,000 women with breast implants. In 2020, Cordeiro et al. Even published a paper where they found 1 in 355 patients. In general, for larger evaluations in the Netherlands and in Australia, an estimation is that 1 in approximately 3,000 cases is at risk for development of BIA-ALCL. When we look at the surface characteristics, as far as these could be identified or are known from the implants associated with these BIA-ALCL cases, almost all, with the exception of 1 case, were textured implants. So this clearly indicates an association between a textured implant and the induction of BIA-ALCL. When we looked at manufacturers, it became obvious that especially the BioCell implant from Allergan was present in the majority of the cases. For other brands, much less or only incidental cases were observed. However, almost all brands do show some cases. When we look at data from Australia, we can look at 2 sets of data. One is on the surface characteristics, and you can see that either polyurethane coated or textured implants, both types of implants showing high surface roughness, form a majority of the cases. When we looked at manufacturers, again, 2 manufacturers are obvious: the Silomed polyurethane implant or the BioCell Allergan implant, with the highest risk for the development of breast implant associated anaplastic large cell lymphoma. Both implants are currently not available on the market anymore. When we look at the surface areas, you see that the polyurethane foam and the salt loss technique as used for roughening the surface of the Allergan implants have a high and intermediate surface area. The surface area can be best measured or evaluated by the ISO 14607 standards published in 2018. However, just indicating the surface area as either rough or by its roughness is not sufficient, and currently this standard is under revision to add more characteristic for identifying breast implant surfaces. What can we conclude so far? There is clearly a relationship between the presence of breast implants and ALCL. There is a relationship with textured implant surface, but not all textured implants give rise to BIA-ALCL. Most brands had incidental cases with BIA-ALCL, but the majority of cases was associated with two specific brands of silicone breast implants, being the BioCell implant from Allergan or the Silumet implant. Also, it is present in the literature that ALCL, CD30 positive and ALK negative can be present at other implant sites, be it in incidental case reports. So could ALCL be considered as an uncommon or rare implant-related phenomenon? It can be present with breast implants, but there are case reports for stainless steel plate, a dental implant, a gluteal silicone implant, aortic prosthesis, and a titanium implant. More importantly, other cases are observed at pathological signs like a breast cyst or dystrophic calcification, and also spontaneous ALCL in the breast can occur. When we look at the study from de Boer et al., they found an association between ALCL and breast implants. However, these authors did not look at silicone breast implant patients. They used the ALCL tumor itself as a starting point and did a retrospective evaluation of a histopathology database. And this evaluation was from over 25 years of histopathology and treatments. So after evaluation, they found 43 cases of confirmed ALCL as primary ALCL in the breast and 146 case controls for non-ALCL lymphoma. And when we look at the data, that from the 43 ALCL cases, almost 75% was associated with a breast implant. There was also 25%, there was no indication for an implant history. In contrast, when they looked at non-ALCL lymphoma in the breast, only one case was associated with a breast implant. So this clearly indicates the association between breast implants and ALCL. The moderating factors for BIA-ALCL can be the genetic alterations or genetic predisposition, the presence of bacterial contamination, the shedding of microparticles from the surface shell, surface characteristics of the shell, and implant-associated reactive compounds. The major issue seems to be induction of chronic inflammation with T cells that obtain lymphoproliferative properties resulting in ALCL. We found the conclusion of SHEAR was that there is a moderate rate of evidence for a relationship between silicone breast implants and BIA-ALCL. That means that there's good evidence from primary line of evidence, but evidence from several other lines is missing. What does it mean for BIA-ALCL? There is sufficient evidence for a causal relationship, but there is missing information on the mechanisms of induction. This slide shows you the levels of the weight of evidence here, and as we can see, the moderate rate of evidence is relatively high in this ranking. It's only second to the strong weight of evidence, where you have both coherent evidence of several lines, but also you have knowledge on the mode of mechanistic studies, how it is induced, which is lacking for BIA-ALCL. Well, the answers to the mandates, of course, we have the general answers that on the use of the breast implants. We have answers on the possible causal relationships, factors inducing, these are all mentioned. Alternatives may be autologous tissue or fat transfer, and we presented in the opinion also recommendations for research. Recommendation series 1, what is absolutely necessary is a high quality registration with a harmonized data set. And that goes beyond, so just a serial number or just say the brand, we need more detailed information. This should include a unique device identification. For the epidemiology, systematic data collection in these registries is necessary. Also, there is a need for a universal accepted grading system for the surface. Surface roughness by itself does not seem to be sufficient. We need more characteristics to be identified. This is currently done in a revision of ISO 14607. Furthermore, we should look into the role of chronic inflammation and factors that can induce this chronic inflammation. I would like to acknowledge the contribution, especially of the external experts. Of course, SHEAR does not have its own clinicians. So clinicians, Mark Clemens, Hino Rakhorst and Fabio Santanelli provided input from the clinical point of view. Daphne de Jong provided input as a hematopathologist, Ingrid Hopper from Australia on data and registries, and Suzanne Turner as a basic researcher for ALCL. I thank you for your attention.
Thank you so much. We really appreciate that clarification. I think that there's been so much talk about trying to read between the lines and what did SHEAR mean by their report and trying to understand it. And I think that you very clearly and precisely labeled all of the findings of the report, where there were shortcomings, recommendations for help going forward. I was wondering if we could maybe go back to the word that has caused the most controversy, which is the use of the word moderate, a moderate level of evidence. Is there any guidance in what the strong level would require? Do we have even the ability to obtain in the future that strong level? What might those studies look like so that we can start them tomorrow if that's needed?
I have a feeling that can you hear me? I have a feeling that whether that really would be necessary to have a strong level of evidence and whether you eventually can reach that, yes or no. Because what you see also in the presentations, if you take out the BIA-ALCL and Clemens numbers, you're actually left with a very low number of cases.
I can add to Wim, this is Fabio. Thank you very much. Yes, of course, if you take out data from those two implants, not if you take out the implant from the patient. So the only chance we have at the moment is to do retrospective cohort studies. If we ban those microtexture implants, we are not able to do any more prospective studies, which are the most important to validate the causal relationship, the strong level of evidence. Am I correct?
Yeah, but the problem, why do you want a strong level of evidence? Let's say what you would then need is not so much you need data on patients, you need information on the research in terms of what induces the inflammation that may be different for the various brands. we may also make a statement that it's, let's say, a rough textured surface is certainly involved in the development of BIA-ALCL, but it's not the only causing agent. It's not sufficient to induce BIA-ALCL. So other factors are there as well. We heard today a lot on also genetic background or genetic variations in the tumors. So, yeah, bring us further in our way of thinking, but I really wonder whether you really, in the end, would come up with a final pathway which is absolutely certain how these tumors develop.
Thank you very much. So,
the various approaches taken by the various researchers.
I share with you, of course, the feeling that we don't really need to go to the strong level of evidence, but I mean, it was just to open the discussion and to be more transparent as possible.
Yeah, and so I want to get back to a sentence that you said in your presentation, which is that there now exists a causal relationship between ALCL and textured implants. We see some that took the SHEAR report findings and said, the way that they paraphrased you was there is a lack of evidence for a causal relationship between ALCL and textured implants. So if we could just be really super clear in the way that we're going to say what that moderate means, does that moderate mean there exists a causal relationship between ALCL and textured implants, which is what I think that you said, or should we be saying there lacks evidence for a causal relationship between ALCL? You can see that it's almost the exact opposite statement. And some people are interpreting the word choice either way. So maybe if you could choose, or is there something in between that you'd rather say?
Well, the moderate weight of evidence, what it tries to say that there is sufficient evidence to demonstrate a causal relationship. You only can go to the highest level, a strong weight of evidence, if you also know the mechanism or the adverse outcome pathway that leads to, let's say, the ALCL formation. It is a ranking of how certain is the scientific committee in his conclusions. And this means that in this level, we also have a weak level of evidence that say that there are indications, but they can be contradictory to each other. Moderate level is much stronger explanation. It really says there's sufficient evidence, so we believe in a causal relationship, but there's also information missing to make the picture complete. So it's not indicating that there is a lack of evidence. It is a lack of supporting evidence in terms of why and how does it occur. And also, if you look at the data, the wording of moderate was chosen because if you look at all the cases, there are no definitively proven cases with smooth implants. So the surface area of these implants has to have some effect in the whole process. And as mentioned also, and that's more qualified comments or remarks in the final opinion, where it says that not all implants with a textured surface induce ALCL. There are a few cases, but we all know the exception or the extra large number of cases for the biocell implants. There are also various types of surface texture, which were also discussed today. We have macro textures, micro textures, and even now nano textured surfaces. They all have their benefits also for the patients. And so far, for most of the brands, there are incidental cases presented in the literature.
I have to say how much.
The macro surface and the intermediate surface as present for the polyurethane implants does contribute to the development of ALCL. It is also so that there are other polyurethane coated implants which have not a higher incidence. They also show incidental cases of ALCL.
Thank you so much, and I think we all appreciate yours and Sheer's thoughtful approach to this. Do we have time for one more question?
I think that I don't want to be impolite with women waiting, and there is Madame Duvignac who's waiting for us. So we have a session of Q&A at the end, Susan, if you don't mind, we take it later all together. So I would give the podium to Madame Duvignac for her presentation. From the France authority, regulatory authority. Thank you.
Good afternoon, everybody. So my name is Hélène Duvignac, and I work for the NSM, the French competent authority, in the direction of the medical device, the cosmetics, and the in vitro medical devices. As you may know, NSM took a decision in 2019 to ban some of the implants that presented a high level of texturation. They were the micro-textured. We wanted today to provide you with some elements regarding the impact of this decision and how NSM is now handling the breast implant market surveillance in France. Well.
Ce l'ha in mano, deve usare quello che c'è in mano.
Okay, thank you. Yeah, thank you. Before starting, I declare that I have no conflict of interest, past or present, regarding the topics that have been discussed today. First of all, some material vigilance data on BIA-ALCL cases. I remind you that all serious effects associated with any medical devices should be declared to the competent authority according to the medical device regulation. trends in France. Since the first case that has been identified, the number of cases reported has increased. But it is now quite stable, I mean up to an average of 10 to 12. This is the first graph. The second graph in the left is the same information but presented in cumulated and not according to the vigilance report date but with the diagnostic date. And the third graph is the number of diagnoses of ALCL per year. We can see that there is a high level of diagnostic in 2019, which is logical since the decision have certainly made people more aware of the situation, and there might have been a peak of detection. The low number of diagnosed cases in 2019 and 91 may also be linked to the pandemic situation. But we are looking with a great interest the trends and how the decision might impact the number of ALCL cases reported. In April 2019, France has taken a ban decision of some of the microtexture implant. This is a precautionary measure because we don't know the mechanism, but it is based on 3 concurrent elements. First element, the French material vigilance data collected and analyzed. Second element is that several expert groups that identified that there were more risks to develop an ALCL with the highest textures. The groups began to meet in 2015. And also cross-references from the literature. So after analyzing all the implants that were on the French market, the decision included 6 families that corresponds to the one that present the same structure with a large porosity under the surface. The top of it is more or less open, and that were also identified as microtexture in a study performed by the European Institute of Membranes in Montpellier. And it was confirmed through cross-references. Polyurethane references were also included in the decision for similar reasons. Now, how do INSM handle the new breast implants that are notified on the market in France? Since the 2019 decision, INSM has settled a new market surveillance process for any new reference notified. INSM has for biocompatibility data, the manufacturing process information, and also the level of texturation that is claimed by the manufacturer and some images of microscopy on the new implants, and also some finished product samples. The purpose is to identify if the new implant would fall within the scope of the 2019 decision, to evaluate precisely the texturation level of the new implant, and whenever it is needed, samples analyses are tested according to the Institute European Membrane Scale for the texturation level. Biocompatibility is checked according to requirements. The purpose is to apply the same level of surveillance for all the implants on the French market as was previously performed before the 2019 decision. As you may know, an international task force is working to define an international guideline for texturation reference, and in the meantime, INSM continues to monitor the different type of texture with the IEM method. Regarding the market of breast implant in France, there has been a shift in the market since the decision at the beginning of 2019. So, as I said just before, we are following the trends with 2 means. First, the texture claims on the manufacturer, because most of the time The claims are according to the ISO 14607. And we also follow the trends according to the EIM scale, which may provide sometimes different results. So you have two graphs. On the left side, you have the 3 last year market share of the total implants on the market in France. And you can see that on the left side, it is according to the manufacturer claim. On the right side, it's according to the IEM scale. But both show that there is a shift from the very high textures to the lower texture. In pink, you have the smooth implants, and in dark blue, you have the more textured implant. Also, INSM is also carefully looking at the material vigilance data trends to determine the impact of the 2019 decision. Of course, for the ALCL trends, but also for other reports, such as the rupture or the contracture, because it is important. Capsular contracture is looking with deep interest. I thank you very much for your attention.
Thank you so much for that great information and just a recap. And I can't tell you how much we appreciate to hear from the ANSM. The statements and the reaction by ANSM was really some of the first in the world and really set a standard that I think many government authorities followed after the fact. And so we congratulate you on what I know must have been challenging decisions at the time.
May I blow away a suspect? I mean, we are extremely happy that the European Task Force and the Share Committee joined this session, which we found extremely important and the most important of the meeting. And we are honored to have the authority, regulatory authority from France, the Netherlands. Unfortunately, we don't have Italy, and I'm very sorry for it. But I want to be clear that we invite Italy from the very first World Consensus Conference. They did not show up. And then we invited to the second and the third, and they didn't answer at all. So we are inclusive. We do this kind of meeting because we want to hear opinion, share opinion, and get out the best of it. So there is no reason that anyone has been ever excluded by us. Thank you.
Yeah. Are there any questions from the audience? Yes, go ahead.
The first question.
Microphone, please.
This the previous problem of PIP affect decision of the France now, according to BIA-ALCL, because you are very strict. And the second question, did you ban it for permanent, or it is the ban of this implant has a kind of limit?
For the first question, I guess I haven't understood the purpose, but I will answer to the second question. We took a decision, but we are really looking at the trends because we had data regarding material vigilance data, but we are really looking what's happening, and so today it's not a suspension; it's a ban.
There is any other question? Because otherwise I would take the opportunity of having Madame Hélène Douvignac here. I'm not sure if I remember correctly, but I think that recently Belite implants got into the French market, and then there was a problem with the CE mark with the German authority, German notified body, and so they were suspended. And I don't know if it's in your possibility to update us the situation. What's now with Belite implant in Europe? I mean, the CE mark has been recovered or not, and what is? Thank you.
it's difficult to answer, but I will give some elements. Yes, the CE was recovered, and so this is an information, but I guess it was already official. But I mean, the CE is not identified, or it is not. It is the notified bodies that that issue the CE. It's not the competent authority. Competent authority are performing market surveillance after the EC. So, so yes, there has been a problem. They have been suspended, and they corrected. And this EC was restated. So that's all. I mean, after that, if the one manufacturer has an ASPS certificate, he can seal in every country. But it was part of our process, of our new process, to evaluate these new implants and to communicate with the notified body in case we have a problem.
Thank you very much.
Thank you. That was very helpful. Thank you. So we're going to turn our attention to an update on the German breast implant registry as well.
Dear ladies and gentlemen, dear Mr. Chairman, thank you very much for giving me the opportunity to introduce the German implant registry to you. The BfArM, where I'm working, is a higher federal authority in the portfolio of the Federal Ministry of Health. Also, other federal authorities are in Germany the Paul-Ehrlich Institute, the Robert Koch Institute, and the Federal Center for Health Education. Hereby, I declare that I'm not subject of any conflict of interest. So, coming to my presentation, I would like to first present the German BIA-ALCL cases and then talk about the implant registry, which we are establishing in Germany. For several years now, we have published a special form on our homepage that physicians should use to report BIA-ALCL cases to us. This is now established in Germany and works quite well. We believe that by publication on our homepage and the close cooperation with the German Society for Plastic and Reconstructive and Aesthetic Surgeons, we believe that nearly all plastic surgeons know about the reportability of BIA-ALCL cases, and so we are quite sure that we receive the greatest number of at least confirmed cases of BIA-ALCL. Since the form is written in German, I would like to show you the main contents here in English. As you can see, in addition to the patient data, both the implant data of the currently implanted breast implant, including its characteristics, are requested. These are, for example, the implantation date, but also explantation date is of very big interest. We ask for the manufacturer and for the type and model of the device. And in addition, the properties, smooth, textured, EU coated. Furthermore, we ask for the implant history, the diagnosis, and the microbiological findings. These are of importance because the diagnosis might contribute to the complications with the breast implants. The summary of the German cases shows that we have registered about 30 cases of confirmed BIA-ALCL in our database so far. The distribution over the manufacturers and the surface structure does not show any particularities compared to the data of other countries, as well as the length of time until the diagnosis of ALCL or the frequency of previous implantations. However, Germany has a relatively low incidence of ALCL compared to other countries. Why is that? We don't know. In any case, however, we must recognize that the absolute number of cases can hardly be evaluated if we do not know the number of implanted persons or implanted devices. As almost everywhere, also in Germany, we lack the denominator, and this makes it very hard for interpretation of the reported cases. To address these statistical gaps, it is necessary to record and evaluate all breast implantations, if possible. To this end, the German government has decided that a national implant registry must be maintained. The basis of this registry is the Registry Establishment Act. In German, it's called Implantateregister Errichtungsgesetz, and the Implant Registry Act, in German, the Implantateregistergesetz. I just translated these two German terms for you, but it's not an official translation, I must say. The very important point is that these laws oblige to participate in the register. So the register is mandatory. Entry in the register is therefore not voluntary. So this is achieved by requiring all manufacturers to register their products or devices in a product database. If they do not do so, and if one of their implants, which is not registered in the product database, is implanted, then neither the implanter nor the manufacturer will receive any money for their performance. The same applies to healthcare facilities that do not report implantations to the registry. In this case, too, medical services are not paid. In fact, we have to assume that not all implantations will be recorded in the registry anyway. Because if someone has an implant abroad, there will probably be no entry in the registry. But we hope that with a mandatory registry, we will capture the much larger proportion of implantations. The goals of the German implant registry are to obtain data on the safety and performance of implants, but also data on patient care and market situation, as well as quality assurance. The fact that this is a mandatory register naturally has quite significant consequences for data protection. For this reason, Implant Register of Germany is built on 3 columns. The basis is the product database, in which manufacturers register their products and the essential characteristics of their devices. The registry database records all implantations, explantations, and interventions related to breast implants. For example, also follow-up interventions due to complications. The implanter uses a scanner to scan the barcode of the implanted devices so that there is a direct connection between the registered data of the patient and, on the other hand, the device which is implanted. All data in the registry itself are anonymous. The link to a patient can only be established via a trust office, which can interfere patient-based on the registry code. For its part, however, the trust office has no access to any health data in the registry, and the three centers are separated, both spatially and in terms of personnel, thus ensuring maximum data security. In the BfArM, which has none of the register offices, data evaluation takes place via evaluation groups. These groups do not only consist of a BfArM member, but also of members of special stakeholders. These may be employees of the scientific societies, clinicians, manufacturers, and other experts. Here too, it is ensured that no personal data is made accessible to the evaluation groups. A link to the patient and his registry data is only foreseen in emergency cases and will not be performed regularly. Other interested parties, such as manufacturers and scientists, can also be provided with anonymized register data for a fee. So research on the basis of the registered data will be possible. The structure of the register queries is shown here. There is a core data set, which contains more or less general patient data and data provided by the surgeons. Also, there are they comprise all the question of autoimmune diseases, causes of autoimmune diseases, and so on. Since the registry is not only made for breast implants, but also for other implants, the core data set is completed by a supplementary data set. It makes concrete reference to the essential implant characteristics and to the individual patient characteristics. As you can see here, we have also recorded concomitant diseases that could have an influence on the compatibility of implants. For vigilance, it is of course much more interesting to record explantations than implantations. The problem, however, will be that implantations of the products that are explanted with the start of the registry are not yet recorded in the registry at all. Therefore, for explantations in the coming years, we will have to rely on the information in the implant documents of the persons concerned. However, this also makes it clear that the implant register allows post-market surveillance geared to the future, the results of which are promising but will not be available for some time yet. The mandatory start of the breast implant registry is scheduled for the 1st January of 2023. Joint implants for the knee and for the hips and aortic valves will follow. The mandatory start for endoprosthesis for hip and knee is planned for the 1st January of 2024. For aortic valves, it is not yet clear. Of course, the order is not a ranking of importance of the devices, but is based on feasibility. Thank you very much for your attention.
Ask you the timing to be active from the law to the real real functioning register, and you said it's 15 months. So I'm very impressed because in Italy we had the law in 2012, And now we are close to celebrate the 10th anniversary, and we are still at the stage of a pilot study. So I'm very happy. But the main question is how scientists will be able to take advantage of the data you collect. Because it's extremely important what you do with registry, as long as we can work on it and try to find out, what's behind this data. Otherwise, it remain not so important.
This question. Of course, the data we collect, they are not made for a box. They are made to research. To first of all, the law describes that every year we have from BfArM and from the evaluation group to report about what happened the last year. So every year a report will be published. But on the other hand, interested scientists are welcome to use the data. There is only one restriction. It's because of the mandatory data collection that we have to look for anonymization. Yeah, sorry.
An excellent answer.
You're welcome to use the data, of course.
I will contact you.
You're welcome.
Thank you. Mark, do you?
I want to congratulate you on taking this step, which was a recommendation of the SHEER findings as well, and I know is really a Herculean task to pull off. We see so many countries going for an opt-out option, but still struggling to get physicians to sign up for it to even get to their patients. Is there any concerns that patients may not want to be a part of this? Is there any way that a patient could say, I don't want my data involved? Does that even need to be built in, or really is the solution we just have to make this mandatory across the board?
The patients, it's really mandatory. And the patients, they will not be asked. They will only be informed that that their data will be included into the register. But they don't have the choice to say, no, I don't want to be included into the register. This is not an option.
Remarkable, and I'm very excited to see the data that you were able to generate in the years to come. Are there any questions from the audience? And this is an incredible opportunity having all four of you represented here across Europe. Any questions?
If there's no more question, then we can open the Q&A session, and I am pleased to say hello to the regulatory authority from Ireland, Tom Melvin, that join us. And so maybe Mark, I think this first question, it was probably already partially answered by, I don't know if we want to go with the same one or...
Yeah, we essentially said that European Commission released the SHEER finding.
Go with the first, please.
On the safety of breast implants in 2021. The report concluded that there now exists a causal relationship between ALCL and textured implants with a moderate weight of evidence. Is a strong weight of evidence still necessary to achieve in the future? If so, what type of definitive studies would this entail? I think we had Wim's answer, which was that moderate means sufficient. I think that that's a great word choice that we learned today. But from maybe three of the other, or actually we're up to five of the other, do you think that there is other further studies that are warranted in the future? What could we go after as we're designing studies right now?
Does anybody want to add something?
Maybe I can kick off the discussion. So I think first of all, we need to acknowledge that in the room we also have our colleagues Laura de Vries. I see her at the podium, I think, and of course our French colleagues. So it's all of us that will participate to this session. It's good news from Germany on the registries, and I'm aware of registry in the Netherlands, and Laura will probably give us more detail on that. And frankly, your question is quite a scientific question, and I believe that Mr. Wim de Jong started the discussion already. Not sure if we as regulators can make actual advice or give advice on what type of scientific studies need to be pursued. But we have understood after the intervention of Mr. de Jong what is the meaning of moderate weight of evidence. We need to be aware that BIA-ALCL is still a very rare occurrence, that breast implants has both benefits and risks, and of course patients need to be involved in understanding those, and very, very important. Besides the fact that we have this benefit risk ratio, is that the risk assessment of implants in general and of breast implants also is device specific. It cannot be category specific. We can't reach a conclusion on an overall type of a device and say that a certain conclusion is valid for all breast implants. And we've hear the discussion in today, so I don't think we need to dwell too much on that. The matter with the registries, and maybe they have the key, and they also have some limitations, is they need time to be populated. So now I turn to my colleagues. Thank you.
I mean, I want to say that we are scientists, unfortunately, so we are not able to perform that good question beside our science. So we apologize, but nevertheless, please feel free to answer only what you really feel comfortable to. Yeah. Otherwise, I mean, you just keep it, it's not a problem. And I introduced, of course, Laura de Vries. I didn't want to be impolite, but of course it was in the shadow, so I said turn on the light and show also Laura. Thank you. For any other comment to the first?
I think we have a hand up.
With Tom? Yes.
Thank you, Professors Clemens and de Santanelli, for the invitation. I guess just from my perspective, coming from the Irish Authority, and I guess being a regulator rather than a research scientist or a surgeon, I think it's, as Paul was describing, in terms of getting a better amount of evidence, leaving aside maybe for a minute the formal definition that the Shear group would use for a high weight of evidence. To me, I think it's really important that high levels of completeness, and Joseph described the German situation, which I think is excellent. I think it's the use of post-market registries that will really help us to understand. I guess in very kind of summarized fashion, I think where we sit now in Europe is that we have I guess an open question in terms of the extent to which the type of implant surfacing might correlate with a different relative risk for an incidence of BIA-ALCL. And I think that registries really are the only way to help us settle that. There's a lot of different dynamics happening now in that we have different product availability internationally. So historically in Ireland, we would have seen excellent data coming from Australia and New Zealand. But I guess market dynamics have changed a little now. So I think in Europe, we really need to try and find a better focus on good registries with high levels of completeness. And I think that will help us to try and get to a more definitive position on the way that ALCL may be associated with particular types of implants.
Yeah. Can I make a comment on that? The issue is, of course, when you rely on registries, that you get data on information on implants and patients. What you want to need for a strong weight of evidence, as was asked for, you need basic research. And we have seen that in the last decade, we have seen an enormous development, especially in the molecular biology. You need knowledge on the biology of BIA-ALCL. And as Susanne Turner this morning already said, she works already for 20 or 30 years on ALCL, and even there, the mechanism, how it develops, is still not known. So registries will help you to get a more informational relationships between breast implants or maybe breast implant surfaces and BIA-ALCL, but it will not give you information on the actually biology of the development of the disease. For that you need more basic research, and especially in view of the molecular biology development, now you also have more tools to look in to the genetics and transcriptomics of all these patients, both the patients and the tumor characteristics.
Thank you for having me here. From a regulatory perspective, I think it's very important that we have these registries. And in the Netherlands, it's actually a quality registry set up by the Scientific Society. And they are kindly providing the data to us. So what you have seen in the SCARE report reported to us is actually the data from the Society. And I think from a regulatory perspective, it's very important for us to monitor what is going on with implants. So the data that Tom Melvin from HPRA is alluding to is very important for us to know, to see which implants perhaps are have a higher association or stronger association with BIA-ALCL. So that we can, and for us it's always important to have that risk-benefit balance. So we cannot decide on that alone. So we need a discussion with plastic surgeon societies, but also, of course, with patient groups and other experts to see when the balance is going to tilt towards an unacceptable risk. So for us, it's very important, and that's why I learned a lot today. So thank you for that. I think it's really important to also elucidate how the biological mechanisms work and how ALCL arises, because all body of knowledge will be helpful in this case. But again, we have to, with each other, decide on what is an acceptable risk and what is not. And in the case of the BioCell implants, I think the notified body did its job and did not provide a new CE certificate, and that is how the implants disappeared from the European market.
Thank you. I see Paul has his hand up.
Thank you. I only want to compliment, if you hear me, the intervention of Mr. de Jong. Knowing the mechanism, the pathological mechanism, the etiology of BIA-ALCL has significant practical impact on regulatory decisions. So maybe also one of the important message of today's discussion is, yes, registries will maybe give us the strength of the association between BIA-ALCL and certain types of devices, but knowing where the disease is coming from with as much precision as is possible is very important in knowing what measures can be taken. Thank you.
Quick question to Susan, or she will kill me. And then, yes, the hostess, thank you very much. Sure.
I'll try and keep it quick. So it seems to me that the regulatory agencies, and thank you all for being here, have been very, well, not very reactive, but certainly not proactive in this situation. So the company essentially withdrew their implants from the market, which basically sort of took the responsibility out of your hands to do something about it, didn't it?
No, I don't agree with you.
You don't agree with that?
No.
But if you look at it from a female perspective, a woman who has a breast implant, this is how they see things. And even with the SCHEER committee report being out there now, and as Wim said, a moderate weight of evidence is enough. Why isn't it enough for the regulatory agencies to do something about this? because it's really important that you learn from this, because you need to know what toxicology studies you need to ask for from these companies before you allow new medical devices onto the market. So it's really in your interest to do that, to look after the populations you represent, and to really learn from this so that this mistake doesn't happen again in the future.
Well, if I may respond
Sure.
to that, and I ask my colleagues to fill in when necessary. We as regulatory agencies are not involved in the market authorization of medical devices. The legal system has put that task at notified bodies. And again, we are responsible for supervising the notified bodies. So the notified bodies need to assess whether a device complies with the essential requirements of the legislation. And new evidence, clinical evidence, is relevant to include. So a large body of evidence became available in the past decades regarding BIA-ALCL. And with that knowledge, the notified body in case of the BIA-ALCL implant said, well, do the benefits still outweigh the risks? And decided not to provide a new CE certificate. That is why those implants removed from the market. So the legal system perfectly did its job there. We have seen today that the BIA-ALCL implants are overrepresented in a number of cases. So we have to see how that evolves. But also we have to monitor how BIA-ALCL cases evolve with regard to other types of implants. So we as regulatory authorities have to check if the notified bodies do their job properly. So that is why we requested as a European task force to all the notified bodies who issued CE certificates for breast implants to again monitor and assess the body of evidence for the implants that they assessed, if the benefits still outweigh the risks. And so far the conclusion has been yes. And it's again a balance, because medical devices will never be 100% safe. There will always be risks. And like I said before, we need to have that discussion, which risks do we consider to be acceptable? And in this case, except for the BIA-ALCL implants, the conclusion has been that the risks are acceptable. So I don't know if any of my colleagues would like to add to that.
We have a question from...
Yeah. Yes, and I think this all makes
Introduce yourself,
good sense. Erik Vogelzang, Establishment Labs. It all makes sense. However, what happens and what is the dynamic or mechanism that Madame Dauvignac can, with the ANSM, can actually put a ban on the market where the other 24 or 25 member states don't follow that recommendation? How does that work from an EU perspective, please?
Can I go, or does someone else would like to address it?
We've got a lot of hands up. Maybe from Ireland?
You, and I know there's a few others hoping to speak, so I'll be quite quick. Essentially, we have a somewhat complex medical device regulatory system in Europe because it's decentralized, and I think Laura explained very clearly some of the challenges that you have in terms of engaging in what Helen described as market surveillance. So coming from the Irish regulator, I don't approve products to get on the market in Ireland or elsewhere. That's done by independent certification organizations called notified bodies. So it's always a challenge when you're looking at market actions that are done on what's called a precautionary basis. And when we look at market action in our legal system in Europe, essentially we have to follow very generic guidance that doesn't just apply to medical devices, but any products that fall under what's called new approach legislation. That's law that applies to all of the products traded in the European Union. And essentially that blue guide would describe that an authority is well within its rights to take a precautionary action on the basis of emerging data of a risk. So before the risk is realized, you can act. So I guess the French, and I'm not speaking for ANSM, but from my understanding of the blue guide, they were very well reasoned in taking an action under that guidance. I think one of the open questions that we all have to face now is, now that the Allergan BioCell product is gone, and given that that's where the vast majority of cases came from, we have to try to understand, with the products that are remaining out there, with varying types of surface texturing. We have the polyurethane foam coated, which have a unique type of device body interaction. We have what's often called macro textured, or the more highly textured, then micro and smooth. I think we all have to try to understand what is the relative risk with those subtypes. And I guess that then generates a huge amount of work, where we have to better categorize the surface texturing, and we have to follow the data to see where these risks might be more associated. And then that will help us to be more definitive in any precautionary type approach. And just one very brief thing, and I'll hand back. In Ireland, we did a huge amount of work in 2019 following the French action, as well as the emergent scientific data around the risk of ALCL. We worked with our National Health Service to inform every woman in Ireland who had a breast implant, Allergan BioCell or otherwise, going back over 20 years. And it was very enlightening, because we were able to see the level of awareness amongst doctors and patients. And it is something I think that we need to improve. There's wonderful awareness, and it's a great initiative to have these types of congresses, but in the general communities in medicine and surgery, we found that there was a great need for further information. So I think there's two main aspects to this from my perspective. It's figuring out the relative risk with certain implant types, and then the awareness, because if women are aware of a painless late seroma, that's something that needs investigation, and if the doctors are aware of how to investigate and diagnose it, that will help us to reduce the risk of death or serious injury for implanted patients.
At one point, I 90% agree with you, but I feel that there is a missing step. You probably jumped a step, because you said, once we know now that the most risky implant have been taken out from the market, we have to think about the other brand, other implants. Well, there is missing something in between. I think, don't you feel that we have to think now first about the patient that still have the banned implant in, before going in trying to understand what is the risk of the other? We know what is the risk for those patients. I think that that's choice that it cannot be left to us, surgeon, but someone has to tell us what to do with this patient, because we know the risk of this implant, and we have to behave in one way under your directory. Do you agree?
Maybe just quickly, if I could, I completely agree. And I guess, again, in our role as a regulatory authority, we're mostly responsible for the product. In Ireland, we saw that there was a big need to improve a health system response, and that's why we worked with our Ministry for Health as well as our health service in Ireland. We wrote out to all women who we were able to find going back 20 years, which was a huge job of getting into old written surgical theatre notes. We set up helplines, and we also got discrete information. And I think some of the work led by Professor Clemens with the NCCN guidelines was really helpful for us in getting discrete guidance to the radiologists and histopathologists as well as the surgeons. So I completely agree. We do have a duty to ensure that there's great awareness, both with the patients and with the health system. And looking after the implanted patients with the, quote unquote, banned implants is an important thing that I think we have to work on. But I guess it's also a health system challenge, because as a product regulator, the strict powers we have are essentially to ban products for future interventions. We have limited power under European law for people already implanted. But I guess that's where we have to then turn and work with our health system partners on a national basis.
That we have prepared.
May I add something? Tom said, concerning your question, if we, from a regulatory point of view, should give recommendations concerning the patients or the women who have, for example, BioCell implants. We, from a regulatory position, we can only give recommendations for special devices. But the patient and physician interaction, it's very individual. So we cannot recommend an explantation for certain devices, perhaps in some very special cases, but not when the risk associated with the reoperation is on the same level with the risk to get a BIA-ALCL. So this decision should be a decision which is made between the physician and the patient itself, but not from a regulatory point of view.
Paper you probably did not attend the whole, but we done a study on 100,000 operation, including first implant, replacement, and exchange, and the mortality risk was 0 on 100,000. So up to the knowledge I have today, the mortality risk for implant exchange is extremely low compared to the occurrence of the BLCL. So that's the point we raised today in the session. So something probably has changed.
We haven't gotten a chance to get to all the questions that we'd established. I know we've gone a little bit long. I would like to ask you one more question, which is relevant to what all of you presented today. Is there a need for a creation of an EU registry that gathers data from all of the EU countries? You would have a standardized data set that you're asking questions. For instance, in Germany had very detailed questions, but it would be great if everybody was gathering the exact same questions regarding the safety of breast implants. Would this be feasible? And how might such a registry receive funding? It would go across all of the countries.
I think perhaps Paul could take this one.
Okay. Paul, I see your hand is up. I don't know.
To kick up the discussion again. So I've mentioned in my presentation the new regulation on medical devices, and we have in there an article, the Article 108, which foresees that the European Commission will encourage the establishment of national registries and national data banks. So you can hear from the wording that it's a bit of a soft power, it's just encouragement, and we do that mostly by discussing with our colleagues from the member states, with participating with the conferences, even sort of financing projects, including more than including a few member states, including registries, but there we focus mostly on methodology of data assessment rather on the establishment data sets and actually financing the registries. And one of the difficulties there is that in order to have an EU-wide registries, which would, as a matter of fact, only be able to pool the data, we need first to have established national registries. I don't think that direct reporting from national health systems would be able we would be able to do it in a central register, if only for reasons of protection of medical data. Nonetheless, there are initiatives, and I would mention ICOBRA, for instance, which is an international initiative, and it has a huge influence, hugely influenced, and I think it's even driven by the colleagues from the Netherlands, HINA Accords. And there is also a new initiative under the current presidency, which foresees the establishment of an EU health data space, which aims at pulling cross-border data in health settings. At the moment, there are only 24 networks, and we don't have actual networks for breast implants. And one of the specificities here also is the difficulty of having registry specific for devices, because we have a huge variability of devices. At EU level, we have about 25,000 of types of devices. So it's not that easy to establish specific registries for all types of devices, and maybe more restricted to implant devices. But we heard today of initiative Netherlands, Germany, And I think there are other member states also starting to set up registries. And we will see in the future if we are able to, as a matter of fact, pool the data cross-border, which I believe is the core of your question. At the moment, we don't have such an initiative, and also financing is not being discussed. I hope this helps, and maybe my colleagues can supplement with more information on the national initiatives, if not already covered. Thank you.
I'll follow up on that one. It's actually Birgit Stark has actually started work on a combination, collection of the data from the different breast implant registries in Europe. And they believe they have perhaps overcome some of the greatest difficulties from a data protection standpoint. And there's certainly some precedents in the US for ways you can do that, where the actual original raw data resides, stays in the country, and you can combine it. So those efforts, actually, Birgit Stark is spearheading that right now, who runs the Swedish registry. So that is underway.
Thank you. And did anybody else want to respond to that?
I don't know if we have time more. We are 10 minutes over the time. Shall we go for another question, since we have this unique opportunity to have you with us? What do you think? There is another question.
Yeah, so unrelated to that last topic, but I think one of the things, Dr. Vries, you mentioned was about risks and benefits. And one of the questions that came up, I was saying it's a unique opportunity given all the registry folks and regulators we have here, was there is this a subset, a module of the breast queue called the breast implant surveillance module that they've been testing out in Australia. And I was just wondering if there's been any thought about trying to incorporate that into these European registries to get collect more data on sort of the benefit side, and the other what things you get from PROMs.
Yeah, we've seen Ingrid Hopper talk about that there's a patient-reported outcomes component of their registry where the patient is actually contacted by an email to fill out a survey, satisfaction, and their personal response. Has that been incorporated? To my knowledge, Australia is the only one to do that. But is patient-reported outcomes or any types of like breast Q surveys, has that been incorporated into any of the country trackings by anybody here?
Well, the Dutch registry is from the scientific society, so we're not involved in the setting up of the database and the maintenance of the database, so I cannot answer your question at this moment.
If Alain, do you want to add anything?
Well, I can say we don't make follow-up like you just mentioned, but what we are looking for follow-up surgeries for complications. And of course, we will register the death of a patient from the health insurances so that we can observe the patients, but not concerning how the patient feels. This is not the intention of our register. Thank you.
So a new registry which is starting. So it is the beginning, and there will be more and more information in it.
Thank you. So I don't know if you agree that I am fully satisfied. That was a fantastic session. I think we got so much information and we learned a lot from you today. So I'm personally very happy. I like to only say that, of course, we will not miss the chance to invite you again next year in Houston. Of course, you can decide the best way you like to be in teleconference. I think it works quite nice with teleconference with the authority without disturbing you too much. But I would like to give one data only that thanks to you and to the excellent faculty, those 2 days we were able to be followed by 2,000 4,260 participants. So it was enormous, a huge participation. So I'm really happy. Thank you very much. And I give the microphone to my co-president, Mark Clemens, for the final remarks.
Yeah, I would just say that that's absolutely astonishing. This has been unprecedented, having so many government authorities coming to a plastic surgery meeting, taking questions. I know that this is challenging and difficult, but I can't tell you how much we, as our societies, as surgeons, appreciate your leadership and willingness to take these tough questions. I want to reiterate our commitment to dispersing this information freely around the world, that anybody that wants to watch these videos, wants to have this information, we don't charge for it, and we're going to continue to do that going forward. We invite you all to this same meeting next year in Houston, Texas, and it'll be, again, September 30th to October 1st, 8th International Breast Surgery Workshop, 4th World Consensus Conference on BIA-ALCL. And Fabio, it's a wrap. Thank you.
Thank you very much. Now enjoy Rome.